para-influenza viruses. So patients seen from 7 days before onset of parotitis to 9 days after parotitis, we can take PCR, buccal mucosa. So remember, we said the infectious period is 2 days before onset of parotitis until 5 days after parotitis. So that infectious period, you can take buccal mucosa. And please, you need to, just a reminder, to notify to us whether on suspicion. Whenever you think that when you suspect, especially GPs, when they suspect that it's mumps, notify us. You don't need to wait for the positive result. The information also is available on our website and health pathways. Then pertussis, aka whooping cough. The clinical presentation starts with by cough and one or more of the following: paroxysms of cough, cough ending in vomiting or apnea, then inspiratory whoop. The incubation period is between 7 to 10 days, but with a range of 5 to 21 days. And the infectious period is from the start of the symptoms until they get 21 days, or until they get appropriate antibiotic, for example, azithromycin or erythromycin. Azithromycin, which is a 5-day course, So within 2 days, if they take the azithromycin, after 48 hours, they can be out of isolation. But if it's erythromycin, it's a 14-day course with for 4 doses a day. So people tend to, if you have no contraindications, people tend to take the azithromycin, which is a shorter course. And so the phase 1, as you can see, starts with the catarrhal phase, which is the most infectious period. Then phase 2, the paroxysmal, which takes a bit longer, first 3 weeks. But antibiotics given in the first one, the first phase, they can help to reduce severity and duration and reduces infectivity. But then antibiotics be given during paroxysmal, because sometimes parents call saying, oh, my child is still coughing a lot. The antibiotics are not going to stop the coughing, but they will reduce infectivity. Then we have phase 3, convalescent, which lasts longer. Recovery is up to 10 weeks. I give back to you.
Cool, yeah, so over to me again. So good point to just pause. And are there any questions or anything we need to clarify at this stage? You guys all good? Okay, cool. So we'll carry on. We'll carry on with meningococcal disease. So, meningococcal disease is a really life-threatening and serious bacterial infection. There are lots of serotypes, but the serotypes which most commonly cause disease is A, B, C, Y, and W. It's transmitted through large respiratory droplets. So what's interesting about meningococcal disease is it can be transmitted by asymptomatic carriers or someone who's sick with invasive meningococcal disease. So asymptomatic carriers are people who have the bacteria colonized in their nasopharynx, and they go about their day, they live their life completely well, no symptoms, no sickness. But unfortunately, in some people, and this is a small proportion of people, the bacteria does invade and it enters the bloodstream and causes quite severe infection. And mostly it's babies or people with weaker immune systems, or living in crowded conditions, or smokers who have the higher risk factors for meningococcal disease. So when we're talking about invasive meningococcal disease, we're talking about meningitis. So those are the really classical neurological symptoms of fever, headache, drowsiness, altered mental status. There's that light sensitivity, and often young children, one of the first symptoms is they start refusing to feed, and there's that persistent crying. And then septicemia, which is the fever. It's a non-blanchable rash caused by damage to blood vessels. And then we've got hypertension, shock, and those classic sepsis symptoms. So MCD can be quite tricky because it can present as just a normal, an everyday flu, or some babies maybe feeding a little bit less, but it can quite rapidly progress to a really severe disease. So, quick diagnosis and putting the case on correct treatment is really, really important. And 4% of cases can be fatal, but even if someone's given correct treatment and they, get through the infection, about 20% of people will have, long-term effects from the infection. So in terms of what we actually do, so we are not too involved with the management of the case. So often the case is actually really, really unwell. So I've gone into hospital to see the family, and baby's really, really unwell. So just recognizing it can be a really tough time for the family, and sometimes it's quite difficult to have, another face, another nurse showing up and, saying that we've got to do certain things and trying to give them advice. So often we are just sort of guided by the family and how they are feeling. But it's really important that we implement public health action as soon as possible. So we don't delay. If we get a notification, we respond to it within a matter of maybe 1 or 2 hours at the most. So in terms of the case, if the case is well enough to talk, and a lot of the time they aren't, or they're babies, we want to verify details, obviously their personal details, where they go to school or early childhood or work, and then when did this illness start? When did the illness start, and when did they start antibiotics which are appropriate to eradicate this bacteria? And those are key dates which guide our contact tracing. And then public health restrictions. We don't fully isolate someone with meningococcal disease. They are restricted from high-risk settings, so that can be like early childhood education centres, until they're no longer infectious. And the infectious period is from 7 days prior to symptom onset until they've been on antibiotics, which are appropriate to eradicate carriage of the bacteria for more than 24 hours. And the appropriate antibiotics include rifampicin, ceftriaxone, ciprofloxacin, and cefotaxime. So a little bit of a public health nurse role is going in, maybe talking to the GP or practice nurse, or the nurses in the ward, and just making sure that the case is actually on the right antibiotics. Okay. Of course, we have a little bit of infection control there, just making sure they're under the appropriate infection control precautions. And then when they're well, we will offer vaccination. But that's not the key priority when we're first seeing a case. A lot of our work is to do with close contacts. So a contact is the household. So normal household, family members, whoever lives at home, or anyone who spent more than one night in the same household as the case. Anyone with intense exposure to saliva, so like, intimate partners, that sort of thing. Or anyone who's had really close, like side-by-side proximity for 8 hours, so if you're traveling in the same car, for example. So it's not everyone. So if you have a case with meningococcal disease who walks into the practice, we wouldn't consider people in the waiting room, or that brief contact as being a close exposed contact. And the work we do for contact management is a lot of education, so just highlighting what is meningococcal disease, what is the risks, and what are the signs and symptoms to look out for. Because if exposed contacts start noticing some of those symptoms, it means they need to get a medical assessment as soon as possible. And part of our work is assessing for symptoms as well. And then we offer chemoprophylaxis immediately. So chemoprophylaxis is to eradicate carriage of the bacteria. So if they have the bacteria that's colonized their nasopharynx, we want to give them a stat dose of medication to help get rid of that and prevent them from becoming sick or transmitting the bacteria. So it's that sort of population level focus that which is where we come in. So chemoprophylaxis is the same antibiotics we'd use to treat. So it's rifampicin, ciprofloxacin, and ceftriaxone. So public health nurses, we work under standing orders, and we do all our medical assessment, and then we give the appropriate antibiotic. And our first line for over 2-year-olds will be ciprofloxacin, because it's a nice quick stat dose. You give 1 dose and it's done. And then we vaccinate as well. So we vaccinate with now Med-Quad-Fi, always struggle to pronounce that, and Bexsero, so just covering those main disease types. Okay, and we always will send a letter to the GP as well, just to link back into their primary care. Cool. Just moving on to viral hepatitis, I thought I'd cover, there's lots of different types of viral hepatitis, as I'm sure you're aware, just covering types, hepatitis A and hepatitis B. So symptoms of hepatitis are those really classical liver symptoms, so reduced appetite, jaundice, nausea, vomiting, abdominal pain, dark urine, pale bowel motions. So it's those pretty classical hepatitis symptoms. And with hepatitis A, I always think of berries and poo because hepatitis A spreads through the fecal-oral route, and it's a really hardy virus. So if you have food or water that's contaminated with the hepatitis A virus, people likely going to get sick. So it's spread through fecal-oral route, contaminated food, water, sometimes sexual contact, but that's not a major source of transmission. And like I said, it is a very hardy virus. It can survive on the hands for 6 hours. It can be frozen. It does survive on food. So a really good example of that is, I think it was mid-last year, we had the frozen berry recalls because there was the hepatitis A, I think it was like 30 to 40 hepatitis A cases linked to certain frozen berries. And I think a couple of years before that, it was the blueberries. So it's a good note just to wash your berries before eating them. And then the incubation period can be quite long. It's an average of about 1 month, 28 to 30 days. And we consider someone infectious with hepatitis A 2 weeks prior to jaundice onset, and 1 week after. Okay, no specific treatment. It's an acute infection. It doesn't become a chronic infection. So just supportive cares. And coming back to what is our public health action, so what do we do when we receive a notification? Our first step is to do what we call an interview, so interview the case, identify where they work, where they go to school, that sort of thing, identify symptoms and symptom onset because that helps us figure out their infectious period. And if they are food handlers, so if they, prepare, if their job is, let's say, working in Subway or something like that, we would refer them to health protection officers because HPOs are really specialized at those food investigations and those risk assessments. So making sure people of the public who've maybe, eaten that food is not, just looking at the risk there. And then source investigation. So if we've got a really clear travel to an overseas country, especially a country with, poorer water quality and things like that within the incubation period, then we'd be pretty certain it's overseas acquired. But if not, we do a really in-depth sort of source investigation. And part of that is asking if they've swum in swimming pools or lakes. And then we do like a food investigation as well, so figuring out if there's any food source we need to be worried about. So if you do have a hepatitis A case come into your clinic, just giving them the heads up, have a public health will contact you, have a little think about what kind of food, where you've gone out to eat, because it's quite exhausting. Like, I can't remember what I've eaten last week, let alone 2 months ago. So just that little heads up is really helpful. And in terms of exclusion, they're not required to fully isolate, but they shouldn't attend work or school or ECEC, early childhood, or have any food handling activities for other people until at least 7 days after jaundice onset. So we do restrict a little bit, particularly if they have diarrhea as one of the symptoms. And of course, have really good health education around reducing transmission, so ensuring they're not preparing or handling food for others. Really good hand hygiene education, because that's the best way to prevent transmission, as well as things like rest and healthy diet, avoiding fatty foods, definitely avoiding alcohol to give the liver some time to recover. Okay. Cool. And then for the contacts are household contacts, ECEC, early childhood employees and attendees. We only really would contact them or do a contact tracing if there's more than one case, so if there's linked cases. If the case is a food handler, especially with diarrhea or maybe not following the hand hygiene guideline, then we would probably contact trace co-workers and people who might have attended or eaten from that place, but that we leave that up to our health protection officers because they have those really good relationships and really good at the risk assessment with that. Or if the case is a child or a baby, then anyone who's involved with nappy changing. So that's our sort of close contact criteria. Oh, sorry. Smell it. top. And then with the contacts, we do another interview and we assess for symptoms and we'll refer to medical care if we're concerned they are symptomatic. But we provide that really solid health education because the idea is to improve health literacy and just make people aware of what this type of infection is. And contacts are not required to be excluded. So if you have a contact come into your practice, they don't need to isolate, but we will get in touch with them and offer post-exposure prophylactic vaccination. So public health nurses will do one dose, and then we refer to the GP if they want to follow up for the second dose, which is quite a big gap between the two doses. And then we'll just check in with them weekly for the next 4 weeks just to see if they've developed any symptoms and refer as appropriate. So that's hepatitis A. And then Hep B, this is a vaccine-preventable disease, and there is the risk that it can progress from acute to chronic. So for public health action, we mostly take action for acute cases, but occasionally we might follow up a chronic case. And the Hep B virus, affects the liver cells, as we know, and it's the adaptive immune response that will sort of determine whether the virus can be cleared within 6 months, and if not, then it can progress to a chronic infection persisting for more than 6 months. And it's young children, particularly babies born to mums who have hepatitis B, who are at highest risk of developing a chronic Hep B infection. Hep B is spread through blood-body fluid, so sharing sharps, needles, birth of a baby to infected mother, sexual contact as well, and close household exposure. Cool. So just moving on to our public health actions. So for the case, it's very similar to Hep A in the sense that we, assess for clinical illness and symptom onset, and then we do a source investigation. So where have they traveled to? Have they had body piercings? Have they had sexual contact with someone who has Hep B symptoms or Hep B positive? So we want to do a source investigation to make sure there's no other, people in the community with undiagnosed hepatitis B or no public health risks such as, tattoo parlors and things like that. And then we provide really good health education around avoiding transmission. So someone can be infectious for 6 months, if not more, with a chronic infection. So we say that someone is infectious from 3 weeks prior to symptoms until public health measures are in place. And those public health measures are things like safe sex practices, ensuring that people don't intentionally get exposed to blood and body fluid, and anyone who might be at risk, ensuring that they're aware of the person's Hep B status. So that's the sort of public health advice that we give, and along with just that usual self-care and lifestyle advice around healthy diet and avoiding alcohol and things like that. Really important that they get GP follow-up, so they have a blood test in 6 months to see if the virus has been cleared or not. And then when it comes to contacts, sorry, it's a very busy slide. The main things we're doing with contacts is around sure symptom assessment, but also just verifying if they're immune or not. So that's documented evidence of immunity and serology, which shows immunity. And if they're fully immune, then that's fine, no further public health action. But if based on the serology result or lack of vaccination, we can give a booster dose or a full course of Hep B immunization, okay, along with just that general public health advice around what Hep B is and how to avoid it and things like that. Cool. And then I'll just briefly touch on tuberculosis control. So TB control is actually a big part of our work as public health nurses. We are case managers for cases of TB, and New Zealand is part of the global effort to reduce and maybe, hopefully, end TB by 2035. Okay, so all the activities we do is around identifying active TB disease, ensuring correct treatment adherence, investigating and managing close contacts, and providing latent TB and treatment to prevent future cases of TB. And people might not be aware that there's pretty steady numbers of TB in New Zealand, and a lot of people who have TB have come from overseas, but there is that inequity there that New Zealand-born cases who have tuberculosis, its highest rates are among Māori, so that is a big health inequity there. And it's a bacterial infection, and people with TB in their lungs or in their throat, they are considered infectious, but people with TB anywhere else, in their body, extrapulmonary TB is not infectious. So if you have someone come into your clinic with extrapulmonary TB, they're not infectious. And with pulmonary TB, if they're on treatment for 2 weeks and sometimes less, they're no longer infectious, okay? So there's not that infectivity period that's prolonged. And just a little look at the epidemiology is, as you can see, we've got pretty steady cases. A lot of them we got notified, I think this is 2022 data, there was 131 notifications in Auckland alone. So Auckland has the majority of TB cases here. And this is just all the things we do as the public health case manager. So when we get notified of a TB case, our first step is, yeah, sure. No, we don't. I was just about to get to the BCG criteria. It is coming, I promise. Yeah, awesome. Yeah, thank you. Thank you for the question. So TB case management, these are all the things a public health nurse will do. I won't go into detail because, you guys probably don't want to hear all our day-to-day work, but the key point to take away is that we're the case manager. We look after the TB case the whole time they're on treatment, and that can be minimum of 6 months, right up to 2 years. So it's a really, really long course of treatment, and we get to know our cases very, very well. And so, we work with the respiratory and the infectious diseases clinicians. We do health, general health promotion, contact tracing, look after their contacts. We'll organize blood monitoring, manage any side effects, deliver treatment, and support them to take their medications every day, because that's the key to treating TB. And TB treatment is very, very effective, very high success rate. The important part is they have to take their medications every day, because that's how they successfully complete the course of treatment and can be considered fully treated. And just to give you an idea of how long TB treatment is, it's 6 months for like a pulmonary case, and that's a really maybe low infectivity pulmonary case without cavitations and a lot of lung damage. For bone TB, it can be 6 to 9 months. Miliary TB, which is TB that spreads everywhere along the body, it can be 12 months, and then cerebral CNS TB is 12 to 18 months. And then we've got multi-drug resistance. This is where the TB strain is resistant to first-line drugs. It can be up to 2 years. So that's a big chunk of their life going on TB treatment. And these are just the first-line medications that I have here on the right-hand side of the screen. Just for you all to be familiar with if you'll have someone who are on these medications. The key point of this is just if you've got a client or a patient who has TB and you're not sure about anything, please get in touch with their public health nurse, their case manager, because they will always be assigned one. And we're always happy to ask questions and work with you guys in the community. Yeah. Did you want to talk about side effects, Romana?
Okay, these are some of the side effects, like Rachel said. If someone who's on anti-TB medication and they come to your clinic with a rash and all those joint pain, dark urine, you just get in contact with us, because each case has got a case manager allocated. But if it's after hours or during the weekend, there's a main number to call. So while they are taking their anti-TB medication, there is a process called directly observed therapy, where a healthcare professional or someone trained, they will be watching the patient or the case take their medication, the full dose, until they swallow. So we do it either face-to-face or by telehealth, meaning that they will go on Zoom, and then we do either live Zoom. We link on the live Zoom and they take it while they are on live Zoom, or they do the recorded Zoom, and then we check daily. So it depends on the level of supervision they are. Level of supervision meaning that if they are sometimes the first 2 weeks, most cases, they have those side effects that we showed earlier on. So we will be monitoring them. Then when they are stable, then maybe they move to the next level of supervision, which is from face-to-face to live Zoom, then recorded teledot. And we talk to them. The most common side effect is orange urine and discoloration of their, sometimes it discolors the eyes, yeah. And I think, Rachel, you touched on that. You want to touch?
Yeah, so I'll just Briefly, sorry, I'm very aware we're running out of time. Just a quick note about contact tracing. As we do contact trace, there's lots of different factors which guide our contact tracing, such as how infectious the case with lung or throat TB is. But it's quite a long exposure period, so it's 8 hours of exposure. So again, if you walk past with someone with pulmonary TB, even if they're infectious, highly, highly, highly unlikely that you're going to be you're going to contract TB bacteria. If someone comes into the waiting room and they're sitting there for even an hour as a one-off, we wouldn't consider that close contact. So just highlighting, it takes quite a lot of exposure. It's not as easy to transmit as something like COVID or measles. So we do organize testing for contacts, and not everyone who has been exposed, even a household contact or a spouse who might sleep next to the case every day, not everyone actually picks up the TB bug. So only about 20 to 30% of people who are exposed have the contract the TB bug, and out of that, most people will be latent or sleeping TB disease. And latent TB is when they're not sick, they don't have any TB symptoms, they just have the TB bacteria sleeping in their body. And in that case, they will have a positive quantiferin or MAN2 test. We'll organize a chest x-ray, make sure that looks nice and normal, and then refer them to infectious diseases for preventative LTBI treatment if they would like that. And then finally, we'll just move on to BCG. So BCG is a live vaccine that's administered just into the intradermal layer of the skin. And it's really important to highlight that you shouldn't give vaccines on the same arm for 3 months after. So there's certain criteria. BCG is given to 0 to 5-year-olds, and we don't give it to all babies anymore. If a baby has been living in a house or had exposure to someone with TB or a history of TB, then they meet the eligibility criteria. If they have both parents or household members who have lived in countries with high rates of TB in the last 5 years, then they meet the criteria. Or in their first 5 years, they'll be living in a country with a high risk of TB for more than 3 months. So the eligibility criteria is all available on our website. Parents can self-book their babies into BCG clinics if they meet the criteria. But generally, we pick them up through contact tracing, and midwives are really awesome at referring babies through. And I've just got a picture on the lower left-hand side. That's a normal sort of BCG reaction. That's what a vaccination site can look like. So a lot of parents get worried when they see this blister forming and they think that something's going on with their baby. Just giving them reassurance that that's expected. That's how the immunity develops. And if they're worried, they can contact public health, and the public health nurse will contact them or go out and see them. But something like that is very normal for a baby. Cool, and I think that's everything. Hopefully I finished sort of on time. That's our contact details there. Are there any burning questions? Yeah.
Yes. Yeah. Yes, they notify on suspicion.
Yeah, that's a really good point. And we do tell our contacts it's not funded, but we recommend if you want to get it, you can get it through your GP. But yeah, we make sure they're aware it's not a funded vaccine. The first one is, though. Yeah. Thank you. Awesome. Thank you so much, guys. Thanks for listening.
Just a little something from us to thank you guys for your time. On my USB. On a laptop, yeah. David Kodaya, the medical director for our mental health and wellness support team.
How's that? Oh, I can hear myself. So nice to see some familiar faces. How are we all feeling? Yeah? Looking forward to the day ahead and tomorrow? It's nice to see some familiar faces. I was asked to just talk about the whole issue of acute mental health presentations. So we've got a bit of material to go through, but also I don't want to just stand here and talk at you for the next hour and a bit. So please jump in, ask questions. Let's kind of have some discussion on the way through. And also, I've got particular points on the way through where I'll stop anyway and give some time for questions. So first of all, I want you to tell me a little bit about, in your own practice, both in the White Cross and local doctors' settings, the kinds of kind of acute behavioural disturbance presentations you see. What are some of the typical scenarios? Yep, so the person who presents feeling suicidal or have suicidal behaviour, yep. What else? Psychosis, yeah. Sorry? Yep, so severe anxiety, yeah. How might that manifest? I say more generalised anxiety. What about the person who's having a panic attack who thinks they're having a heart attack? Yeah. What else? Intoxication? Yes, alcohol and other drugs, yeah. So how comfortable is kind of knowing how to approach managing those situations for you all? I see if mostly shaking of head. Any nods? Well, so look, hopefully at the end of this, because the intention really is at the end of this, it just gives you some kind of, and actually my observation, having worked in primary care for 20 years, is that nurses in primary care know a lot, but don't have a lot of confidence that they know a lot and have a lot of skills in the mental health space. So hopefully what I might do is, rather than telling you a lot you don't know, is reassure you that actually you innately have a lot of both knowledge and skills. So you've kind of also covered the causes. So look, I've got a couple of takeaways really to start with. The first is that it's really helpful because when people present in distress, and particularly with psychosis, or actually none of you mentioned the angry person, the person who's kind of angry and threatening, but in kind of working with or managing people who've got really acute behavioural disturbance presentations, first really important thing to take away is that underlying that, no matter what the presentation is, normally distress. And people express distress in different ways. So if you can connect with the person and support them to reduce distress by just some simple kind of steps that I'll go through as we go on through the slides, the outcome will be better all round. It'll be better for the person particularly, but actually better for the clinic because, other patients, because of the impact, and also better for the team. And the other thing is that there is this kind of notion that is always presented to us in the media and in films and so on, that kind of crazy people or people who are mentally ill are violent. So the other big kind of takeaway I want to just leave you with, which hopefully is not news to you, is that apart from two very specific scenarios related to severe acute mental illness states, the risk of violence from people with mental health issues is actually no greater than the population. And in fact, it's the opposite. People with severe mental illness are more often victims of violence than perpetrators. So I'm not talking about anxiety today, but more about the much more acute behavioural disturbance presentations that are more likely to reflect a mental health crisis. And And really that comes down to 4 main presentations with a 5th element. So the first is that the distressed person who's facing a really major life challenge or trauma, and it may relate to their own life or the impact of a traumatic event. And in recent history, of course, we've had the floods. And I mean, many people presented with those kinds of life challenges will cope and manage well. But for increasingly also for many in our communities, it's been 3-4 years of just one thing after another, hasn't it? And I think a lot more people are reaching that breaking point at the moment than has been the case previously. And the other thing to keep in mind is that if you've grown up in adversity, so if you've grown up, you know, experiencing poverty, crowded housing, various kinds of neglect or abuse, and it leaves people with poorly developed coping skills. So kids who grow up in those environments don't kind of just absorb the kind of coping skills that most of us do. And so those are the people who are most vulnerable to decompensate in the face of crisis or stress or trauma. So that's the first. The second, which you mentioned, was the person who is distressed as a result of severe and or persistent depression and who's become suicidal. So is either having suicidal thoughts, plans, or indeed has made a suicide attempt. The third is the distressed person who presents as angry and threatening. And that can be a result of a number of different factors, but certainly I know it's a not uncommon presentation across many of our clinics that is very challenging for anyone to deal with. And the fourth is the distressed person experiencing psychotic symptoms which are influencing behaviour. And then kind of woven through that, or standing on its own, is the issue of someone who's intoxicated. So that's mostly what we're going to kind of focus on today. So this is just an overview of the session, which is understanding and managing distress in a general sense and some focus on trauma-informed care, and then covering all of those main issues and finishing with a little bit about then the Mental Health Act and when and how that might need to be a part of what your response is. So in terms of just acute distress, there are some general messages here. I think it's really helpful for clinics to have a really clear protocol at the front desk for how to kind of manage someone who presents acutely distressed, because often it is the front desk staff who are the first kind of port of call, and so that's where distress is manifesting. Be it someone who rocks up distressed or who gets really angry or upset about wait times and so on. And I mean, ideally it's this kind of content, really. It's just to remind those staff to take a breath and calm themselves and try and respond calmly with empathy. Because if someone's wound up and we get wound up as well, what's going to happen? What's that? Yeah, it'll escalate, that's right. So the first thing is just that reminder to first of all take a breath and try and calm yourself. And the second, obviously, is to try and get the person safely to a quiet space, offer a cup of tea, involve get triage done as soon as possible. If you have a HIP or wellness advisor, as we call them in the clinic, they can be helpful in supporting you with helping the person de-escalate. But if the person is abusive and threatening, unable to be calmed, I think it's also really clear to have really clear protocols about how to deal with that as a team to protect people from having to be subject to stressful situations, and to also have a clear panic button process in place. And I think most of our clinics now do have that, don't they? As I understand it, anyway. So those are, having that kind of protocol, but certainly for you as nurses to do that, take a breath, ground yourself, to reflect in calm, neutral language. You know, I can see things are not easy for you right now, being a good starter. Try and get the person's attention and invite them to do some slow, deep breathing with you, using that kind of box breathing. Breathe in for 4 seconds, hold for 4, out for 4, hold for 4. Simple thing like that to calm the autonomic nervous system, which can be really, really helpful, especially if someone is in a state of overt panic. And if someone is in that kind of panic, I think I'm having a heart attack presentation, you often need to be quite directive with them to get their attention, to then get them to do that slow breathing with you. But that alone can often bring someone down out of that kind of hyperventilation panic state. And then it can be helpful once you've done that to just do some basic grounding, get the person to focus on the feeling of the floor beneath their feet, the seat beneath their backside and so on. And once you've done that, you can then start that whole process of assessing what's actually going on that sits behind the distressed, behaviourally disturbed presentation. So does that all kind of make sense and feel simple? Is it what you already do? Do you feel comfortable doing it? Yeah, okay. So when we see distress at a level leading to acute behavioural disturbance, what sits behind it? Well, it is one or more of, firstly, people being agitated, disorganised, angry/aggressive, and also presenting with suicidal thinking, deliberate self-harm, and caused, as I said, by intoxication, severe mood or anxiety disorders, psychosis, organic mental disorders. So delirium is something really important to kind of keep in mind, particularly with people who are older. And also this whole thing of people's underlying personality structure, and particularly personality disorder. And so given all that, these are the issues, aren't they, that you face in responding in GP and accident medical clinicians, I mean, in settings. There's the safety of the patient, which is really critical to focus on, but also the safety of others and the not distressing others, staff and patients. The difficulty is assessing, so, you know, the whole issue of, is this someone who is intoxicated or has an organic mental disorder of some kind, let's say delirium, or who's intoxicated versus psychosis, so someone who presents really hyped up, really paranoid, is that methamphetamine or is that underlying psychosis, and so on. There's the whole challenge around how to manage in the least restrictive way, you know, I mean, we can't go calling the police or having security involved every time, so how do you kind of get that balance right between trying to de-escalate the situation but also not put yourself and other people at risk? The whole issue of referral, where and how, and also initiating the Mental Health Act that we're going to talk a little bit about at the end. So look, just to reiterate then general principles of management. First, try and de-escalate, as I've said, and you being calm and empathic is the most helpful thing. And as part of that, just kind of holding on to that notion that no matter how the person is presenting their distress, that underlying it is actually distress in the vast majority of cases. Use of quiet space, so however you can manage that within the clinic environment, but it's about time to calm down and reduce that whole sensory overload. And for many people, that alone is really helpful, particularly if you can then get them a cup of tea. Maintaining that capacity to observe and contain, though, and within a busy clinic, I think that's really, really challenging. I mean, if you've got someone who is at risk, let's say who's highly suicidal, you need them to stay until the crisis team can get there. But within a busy clinic, how can you maintain that kind of observation and containment to ensure they stay there rather than leave? And also, I mean, as a last resort, though, there's the whole issue of use of medication, which I'll also talk a little bit about. In fact, I think that's next. But I mean, I think the thing here is really it's a last resort for cases of really severe distress or risk where nothing else seems to be working. So what is the best approach to that? Well, as I said, last resort. The other thing to remember, and the reason why it needs to be last resort, is that sedating someone who's acutely distressed may help clarify the diagnosis. So, for example, if you give them some lorazepam, and actually things just calm right down, it suggests they may well have been in a state of panic. Or it may cloud the picture in terms of someone with delirium, where actually it can aggravate that. So just really important to remember that is why it's a step of last resort. If it's unclear what's going on from both a triaging perspective and GP kind of rapid assessment perspective, it's really best to look at lorazepam as the best option. And certainly for primary anxiety distress, lorazepam, but for anyone who presents with psychosis with or without mania, so mania being highly elevated mood, then olanzapine wafers are the best option. So you've got an oral lorazepam 2 to 4 milligrams, or for a mania psychosis, the olanzapine wafer 5 to 10 milligrams are the options that are recommended in acute psychiatry. And for emergency sedation, IM, lorazepam or midazolam as options. Now, we've had some discussion at a clinical governance committee level about what you have in your stock in the clinics. And hopefully all of you now, these two options are in there for emergency use. So any kind of comments, queries about that before I go on to talk a little bit about the kind of whole notion of trauma-informed care? Okay. So look, just taking this whole notion of underlying distress further, there has been this whole shift within the mental health field, which I think applies equally in primary care. It's called trauma-informed care. So it's basically recognising that for many people presenting distressed or with acute and or long-standing mental health and addiction issues, that trauma is the fundamental underpinning driver of that, okay? And that applies across the board, including psychosis, and I'll go on to show you some data about that. But I mean, how many of you within your training around mental health were actually taught that things like schizophrenia are primarily genetic disorders? So I expect those more my end of the age spectrum will be nodding, but how about those of you who are closer to your graduation? Were you kind of taught about the impact of trauma on predisposing to serious mental illness? Yeah, I see some nods, so I'm glad. Because, I mean, certainly psychiatry has been very slow to actually acknowledge that. But the research about it is really clear. Early life trauma and abuse substantially increase the risk for all mental health and addiction issues. And in fact, the typical scenario, and there's a direct dose response curve between the number of kinds of neglect and abuse that a child grows up with and their risk of this trajectory. But the trajectory really is of early onset of drug alcohol abuse as a coping mechanism, earlier onset and greater severity of mental health symptoms as well and conditions. All of the things that go along with that, which are about unhealthy lifestyle and so on, leading to earlier onset and greater severity of long-term medical conditions, and dying on average 15 to 20 years younger than the rest of us. So that's the trajectory that early life trauma and neglect sets up for people. And I mean, the evidence about this is so strong that I think there's a really strong case to say that if we could ensure that every kid in this country grew up safe and loved, we would halve the need for mental health and addiction services, for prison beds, for SIF staff, all of these kind of costly government services. So what does trauma do though? Trauma actually, at a brain level, causes persistent overreactivity of the so-called limbic area of the brain. So that's the fight, flight, freeze response part of our brain. And also it leads to reduced volumes and function in our frontal lobes and hippocampus. So those are the bits of our brain that are involved in emotional learning and rational thinking overriding emotional response. So how many of you got kids or have had children? Yeah. So remember when your 2-year-olds had a tantrum? Yeah? So people who grow up with trauma get stuck in that space. And I think that remembering that is really helpful just to actually understand what the hell's going on when an adult comes in behaving like a 2-year-old, okay? So, I mean, literally, when people who have grown up in those circumstances feel threatened, they feel out of control, and behaviour that appears intentional is not. So most of the people who I've seen, who I've been referred, who come into clinics and are threatening, angry, disruptive, this is what sits behind it. And this comes from a big bit of research in the States called the ACE study, the Adverse Childhood Events Study. And for that, they basically mapped out for 12,000 people, their experiences of 7 forms of adversity, being emotional neglect, physical neglect, emotional abuse, physical abuse, sexual abuse, having a parent with a severe mental illness, and having a family member who was incarcerated, okay? If you have more than 5 of those factors in your life growing up, then this is the picture that we see. So, just trying to figure where the pointer is. Oh, is that it? Okay, I'll go over maybe and point myself. So, I mean, it's more than half of what drives alcoholism, misuse of painkillers, problematic drinking, ending up in prison, ending up being a perpetrator or victim of intimate partner violence. But look over here, serious persistent mental illness. At a population level, that is the single biggest factor that 5 or more forms of adversity are a risk factor for. So it really debunks that whole notion that certainly I was taught that psychosis is largely genetically based. It's not that it doesn't have genetic factor, and some people that's a huge part of it, but at a population level, this is the main driver. And I mean, just to really reiterate this whole kind of thing of the impact of early adversity on brain development. So, as I said, you get persistent overactivity of the fight, flight, freeze parts of your brain, and underdevelopment of the think things through and emotional response part of your brain. Hence the backdrop. So why? Why would it be like that? Well, the reality is that back when we were evolving, this was the threat that was always in the environment. So, you know, we had to be wired to actually manage these kinds of situations. But of course, in the modern environment, the threats we face are not to our physical safety, they're more often around our emotional well-being. And unfortunately, in the modern world, the things that we're wired to do when we feel under threat are not that socially acceptable. So, coming back to this notion of trauma-informed care then, this is a quote from one of the recognised researchers in this space who talks about our brains being sculpted by our early experiences. So he talks of maltreatment as a chisel that shapes a brain to contend with strife, but at the cost of deep enduring wounds. So in managing behavioural disturbance, the key is just that, to remember that fear and distress lie underneath, and what often lies behind that is early adversity. So to do those simple things, breathe, calm yourself, and I'm sorry to repeat them over and over, but they're just so important. To act in ways that calm and reassure, to reach out to the person's rational capacity. You will be okay, we'll get through this. We're here to keep you safe and help. Because that's hard to say when someone is kind of, from an outside perspective, behaving badly in various ways. So key aspects of trauma-informed care, and the overarching thing here is the shift from what's wrong with you to what happened to you, okay? Because we tend to think, we're taught to think in what's wrong with you ways, aren't we? But when we're thinking in a trauma-informed way, it's about actually having this whole thing of what's happened to you sitting there as well. So it's a respectful demeanour, communicating that you're important, you matter, seeking to engage through those whole kind of, you know, empathy and the use of language, sharing information, so appealing to the person's rational mind, and also maintaining a hopeful attitude. Things can be better. So, I mean, any comments or questions about that? Does it, when you think about people you see in your day-to-day work, do any particular people come to mind, and does it kind of make sense? Yeah. So, I mean, does anyone want to share a particular patient who springs to mind out of their last week of work?
We got a random guy that actually walked into our clinic. It was not our patient at all, and he seems to be really confused. He was shaking and sweating, and we don't know what is the story. And then the reception just called us. We were at the back, and we came to the front. He seems to be lost, looking for something. So first, the thing is we're trying to obviously calm him. So they didn't think much at that time. Was just thinking quickly what should we do? Obviously, that it's not our patient. We are not familiar with that guy, and he's a young guy too. And but the first impression is that he is not violent. He's not harmful. He's not self-harming. He just seems to be confused, and he's breathing okay. But the thing is, when tried to ask him questions, he couldn't be able to answer us or give us proper answers. He's just not communicating properly, and so. First thing we think was just keep him in a safe space. So we took him to the nurse's room. Three of us, we've got me and a nursing student, and then in the reception, three of us took him to the room, trying to get him to sit down, and we tried to offer help, say who you are, do you want us to call someone, do you need water, are you hungry, or a cup of tea, those kind of things. He's just seems to be like hallucinating or something. He keeps on saying he's scared of something. Then that point we were not sure, but sometimes he's trying to wander off, so we're trying to say, don't worry, you're safe here, just sit down. We don't want him to wander around. And I even called the doctor to come and have a quick look, and doctor says, there's nothing much we can do. We don't know his details, so probably a good idea to just call the police. And so we tried to call the police, but actually at that point, police walked in to find him, because I think what happened was he was apparently chasing some girls outside, and then the public already called the police. And according to the police, he's known to them. He was actually discharged not long ago, that day or day before, from Auckland Hospital with extensive psychiatric history. Yeah, he's also possibly, yeah. Yeah.
So, I mean, the police came, which was kind of fortunate, but in a way, if they hadn't been there, probably the ideal thing would have been, given that he wasn't actually an immediate threat, and if you could contain him there, would have been to actually get a crisis team referral done and call them and get them in, because certainly that sounds like what would have been a great option, and hopefully that's what the police did anyway.
We thought about that, but he couldn't give us his name and all the details. We're just not sure. Even if we call the crisis team, what can we say?
One of the things to understand about crisis teams, and I'll come on to this a bit more later, but they can only respond based on the information you give them. And if you don't know who someone is, if you can at least accurately say, these are the things that are happening. So, which you did a good job of. He's confused, he's sweating, he seems to be hearing voices or something, he's not making sense. We've managed to calm him down a bit, but he keeps trying to leave. It seems that he's probably acutely psychotic. That'll tick their boxes, okay? So you did quite a good job of articulating that, and the really clear thing is to make sure that you tell them all that information, because when crisis teams don't respond, sometimes it's just because they're too stretched and they'll say no. But sometimes when you look at when things go wrong, which I do at times have to get involved in, it's the kind of failure of really good transmission of information that is understood at the other end. And sometimes it's the problem is at the receiving end, but sometimes when I read stuff, I can understand what the GP, for example, has been trying to communicate, but it's not saying it in ways that the crisis team nurses go, I get that, I know what that means, yeah? So any other... So look, yeah, really, yeah. Good question. Yeah, and good scenario. And look, I really appreciate the challenges that it poses. So I suppose this is a psychiatrist speaking, okay? Because I think, I mean, if that person was having a cardiac arrest, what would you do? Yeah. And I think that psychiatric emergencies can be as lethal as cardiac ones, yeah? And so I think that you just have to, but we don't think that way, do we? But I think that it's really important to think that way because that person is probably equally at risk of potentially dying than the person who's had an MI. I think you've just got to prioritise keeping them safe. The challenge is ambulances get there mostly pretty quickly. Crisis teams don't. Yeah, that's why I said these days mostly being... Oh, yeah, sorry, I mean in the MI situation they'll come quickly, yeah. 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 So look, yeah. Well, that's right. Look, I mean, police being the front line of mental health services is far from ideal, but in the current environment, at times it's necessary. Police have got much better at training their staff on how to actually how to manage in a helpful way psychiatric emergencies. And also, if you do ring the police, they have a 111 divert system which will go through to a mental health triage nurse at Whakarongaro anyway. So often what you'll get is a mental health triage nurse who can then actually make a good decision on behalf of the police, unless you're stating it's an absolute life and threatening death emergency right now. So, you know, I think it's not ideal, but if police are needed, and you've just got to do that. And at least what that does is up the ante and get the person to a safe place. Because if you can't keep someone safe in your environment, and they're so actively at risk, so acutely suicidal, then what else can you do? So I don't know if that's helpful, but yeah, I know it's not necessarily an answer, but yeah. And any other situations people want to raise? Yeah, yeah. 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 And I think also, I mean, I'm not sure if you're GP or A&M, but I think it's most challenging in A&M clinics, isn't it, where it's not an acute emergency, it's in the evening, so other services aren't open. Yeah. And I mean, it is really challenging. I mean, I think that during the daytime, having a mental health clinician in the clinic, which most of our clinics now do, at least for a lot of the week, does make it easier. Although they're not crisis teams either, so all they can do is help you and advise you about what's going to be the best way forward. But I do feel for the clinicians who work in A&M clinics where you get these presentations every hours, and what you can do is very limited, isn't it, at the moment? Yeah.
That's where I was about to point out, Dave, because not even sure if maybe it's not so much emotion in the mind as soon as I start to split, it's an accident in emergency clinic. I've just lost count of how many patients come in yelling, frustrated, really angry, and yelling at the staff. And I think it's purely, it's mainly rooted in the frustration of the very long wait times, especially in certain days where we don't just have enough practitioners in the clinic, and that, as you say, that can have a toll on the staff.
Yeah, oh, absolutely.
And just managing that. I mean, you were talking about quiet spaces. I don't remember. And it's so good to have
So, yeah, and in the A&M clinics, do you have anywhere you can take people that is just a quiet space you can sit with them away from the hubbub of, no?
Not many. I'll give you a situation there, because there is a side room in our clinic, and
Yeah.
there's a patient came in yelling at this reception. I heard it from one of the consultants who went out, calmly talked to the guy, got him to a side room, and dealt with him. As soon as I came out, probably spent 20, half an hour, 20 minutes,
Mm.
half an hour with him. As soon as I came out, the other patient yelled out saying, "Oh, I've waited there 3, 4 hours, and then this guy comes in, and then you see him first." So then one thing after another, and it's all really related to that
Yeah.
systemic problem with this. It's just too much of a long wait time.
Well, I mean, what sits behind that, though, is also the reality that a lot of people in our communities we serve, the last 4 years, it's just literally been one thing after another hammering them. So I just think the levels of stress out there currently are as great as I remember them ever being. And that's partly what you're then on the receiving end of, people who don't have well-developed coping skills anyway and who are just at the end of their tether. Now, understanding it doesn't solve it, I know. And I mean, if it is a big enough issue, then maybe it is something to take up at a company-wide or an organisation-wide level. Just if that is such a predominant need presenting in A&M clinics, to be better equipped, at least in terms of facility, to deal with it. Is any of the CGC members here? Where's Natasha? Can you just make a note of it as something to have a discussion with Nikki and Alistair about? Sorry. Or so just send me. By the time another half an hour or so goes, I'll walk out here and I may have lost it from my addled brain. So if you can just send me an email as a reminder to pick this up with Nikki and Alistair. I'm not saying that magically anything's going to happen, but I think at least it needs to be flagged, and I presume they'll be aware anyway. Left field's good.
Most of our waiting rooms are fairly uncomfortable places, right? They're either too hot, or stuffy, they're full of people who are stressed, as you say. They're austere. There's nothing nice about them, really. Nothing nice. And it's like this cauldron of emotion that you can't feel when you go out. And I've done some reading on biophilic kind of design and, health outcomes with having, sort of wanting to put plants or
Yeah.
make it a nicer, sort of just a nicer experience. And I think we were fortunate to be given a series of big bouquets from a patient. This never happens, right? It happened once. And we had a series of these beautiful bouquets that sat behind reception that the clinicians could see from inside the clinic and all the patients could see. And it really did make a difference.
Yeah.
I felt it did to me anyway. And I'm just like wondering if you have any sense of that.
Oh, look, there is really good evidence that if you're distressed, environment has an impact, positive and negative. I mean, probably a bad thing for me to admit, but because my time is most often in the GP space, not the A&M space, it's not something that has ever really been in my kind of mind. But I mean, if there are simple things that you can do in terms of just what's on the wall or plants, those kinds of things, that does tend to calm things down. It's not a total solution, but it's certainly part of it. So I don't know what degree of autonomy as individual clinics you have to kind of soften your weight room space, at least in terms of the feel of it, but it would certainly be well worth putting a bit of time into doing that. Yeah. Okay, well, let's move on to the next bit. God, we've been talking so long, it's gone to sleep. That's it.
Does anyone have any more questions?
It seems to have frozen. Oh, there we are. Okay, so let's come on to the whole thing of the particular needs of people presenting with suicide risk. So again, just to start with some questions, is suicide preventable? I know it's a bit of a leading question. If you don't think so, you're not going to feel very safe saying it here, are you? But it's an important point to stress. I mean, suicide is preventable. We are never going to be able to prevent every suicide. But as a nation, we put our minds to reducing the road toll, and we've more than halved it over the last 2 decades. So on a 10,000 population basis, the suicide and road tolls were about the same, and they're now very different. Suicide, if anything, has bumped along up and down, but hasn't really changed. Road tolls reduced dramatically. And, I mean, should we try and prevent all suicide, and if so, why? I mean, are there not times, and you know, I mean, globally I would say the answer is yes, but as human beings, sometimes people's lives are just in such a dire space in terms of, you know, physical health, well-being and so on, and suffering, that you can kind of understand it, can't you? So, you know, I mean, I think there is always that little dynamic sitting behind it, but the reality is that for the vast majority of people, no matter how bad things are at that time, if they can be got through that time, they will go on to have a life of at least some quality where they're not. So overall rates did slowly decrease from the 1990s until about 2014, but since 2014 have actually increased again. peaked at 2019 at 681, highest it's ever been, and then dropped, and last year was 557. This year's data has just come out, I think it's about 583. So we're kind of bumping along pretty steadily though. Is that working? No. But as I said, the thing that it is compared with is the road toll, which in 2022 was 378 in comparison. So what do we know about suicidal behaviour? Suicidal thinking is common. Now the stats are 1 in 6 people at some point in their life. I actually think that's probably a dramatic representation. Suicide attempts are rarer, 1 in 20 people at some time in their life. Completed suicide is thankfully very rare, at a lifetime prevalence level, 1 in 10,000 roughly. So what's the problem with that? Well, the problem is you've got a very common thing, suicidal thinking, a very rare outcome, completed suicide, and any predictive test has to be so reliable to be better than tossing a coin that it will be impossible. So we don't have any means of actually predicting. If someone comes along saying, distressed, you ask, they say, yes, they are having suicidal thoughts, they've even had thoughts about how to do it. Are they the many who are not going to go on and do it, or the very few who are? So we kind of have to behave as if everyone is that one person at risk, or we're going to miss. And the particular problem is that if you look back retrospectively, those most at risk are those least likely to tell you unless you really, really ask them in a very pointed way. So mental illness and suicide both have multiple complex causes, mostly shared. There's a lot of controversy about this. So there are different theories around what drives suicide, and certainly there is an element which is very much about social factors. So for example, suicide in Catholic countries, and I think also in Muslim countries, is lower than in others. Now, is that partly about the protective element of faith, or is it partly about the protective nature of a forbidden behaviour if you have those faiths? I don't know, but on the other hand, if you look retrospectively at people who died by suicide, over 90% had clear symptoms of a mental illness at that time and or addiction issue, okay? I mean, what caused that is up for conjecture, but in terms of pure symptom presence, it's also clear that interventions that improve the recognition of and treatment of particularly depression lower suicide rates. So there was some really interesting nationwide research, I think in Denmark or one of the Scandinavian countries, where they had a nationwide push to actually educate GPs about recognising depression, treating it, screening for suicide and managing it, and their national suicide rate went down. Now unfortunately it gradually climbed back up. So what that demonstrated is that we can do things to reduce suicide, but a one-off intervention is not going to actually sustain that change. It's got to be an ongoing one. The exception to that, though, is youth. And I think that, again, when you look back at what's happened when young people die by suicide, you often do see a bit of a different story, where it's a young person who most often has grown up not developing good coping skills, and who maybe has also tended to misuse drugs and alcohol as an unhealthy coping mechanism, but who then hits a life event like a relationship breakup, and that night they die by suicide. And you just get this feeling, if that kid could have been got through that night, they'd have probably been fine. So it's not that they've clearly had symptoms of clear mental illness in the immediate preceding, and it's that whole thing of not coping, impulsivity, the role of drugs, alcohol, and of relationship breakup, particularly as the things that create vulnerability. So what do we know, though, about help seeking in this context? Well, if of every 100 people, so 20% of the population in any year, and that'll be more now because this is from 2002, will have symptoms of a significant mental health or addiction issue. But of those, only 40% will receive any kind of assistance. That may have increased with the work that's gone on around primary mental health-based mental health services. But at that time, at least, it was only 40%, but most of them, 28 of the 40, it was through primary care. And what we do know about completed suicide is that most people who die by suicide have seen their GP. More than half have seen their GP in the month prior. But those most at risk are least likely to disclose it voluntarily, okay? So that's the kind of foundation on which to really then, also, yeah. There was a reason that was in there, but I can't think of it right now. What do we know then about treatment and suicide risk? Addressing means to suicide also reduces risk. So if someone presents, you ask them, are they having thoughts of suicide? They say yes, they have a plan, they have the means. Be it, let's say, they're thinking of hanging themselves and there's a rope in the garage, or they're thinking of taking an overdose and they've bought, 6 boxes of paracetamol. If you get their agreement to remove access to that, that is another thing that has strong evidence of reducing completed suicide. We in New Zealand have a structured safety planning app called Manawa, which can be downloaded off the App Store. And using that structured safety planning process has really good evidence of reducing suicide. So I really want to promote, if you're seeing someone in your clinics who is suicidal, and all of the wellness advisors have this structured plan and use it when needed as well. But particularly in that A&M out of hours context, taking the time just to actually go through a safety plan with someone, fill it out, get them to download the app and use it, will reduce suicide rates. And again, I'm using that analogy of a myocardial infarction deliberately because we tend to treat that seriously, but to kind of think of suicide somehow as being a bit different, whereas it's not. Talking therapies, generally, access to those reduces risk of suicide. If people have severe depression, having that medically treated does. So there was some really good analysis done that showed that regions with the highest rates of antidepressant prescribing, at least back in 2005, had the greatest reductions in suicide rates, and that was that period when suicide rates were coming down nationally. So what are the roles of health services? What we need to do is to screen for, when people are distressed, to screen for conditions like depression and addiction particularly. So within the long-term conditions A form, for example, there is that 2-question screen for depression, which really needs to be used because those people have higher risk as well of depression. To ensure more effective treatment, which also includes handoff to your wellness advisor. So anyone with any kind of distress, depression and so on, they're there to help with that. To get them to see the GP and so on. But also be aware of the wider psychosocial issues. And most of at least our GP clinics now, have an NGO service working in with them, providing peer and community support. And you as nurses can make those introductions directly. You don't need to wait for other members of the team to do it. It's a simple outbox form that's in the PMS. You can ask your wellness advisors, they'll know, or the health coaches, they'll know how to access it. And if we do all that, we can be confident that we'll contribute to reducing suicide rates. But I mean, there's no point in providing good treatment if the person dies. So the other bit of this is you've really got to be comfortable screening for suicide risk. So hopefully most people are kind of familiar with this ladder up notion of asking a series of increasingly pointed questions. And the thing here is to start very generally. If you just go straight into someone and saying, are you thinking of killing yourself? They're probably not going to necessarily give you an honest answer. So it's starting off, do you see any future for yourself? And if the person is feeling a bit hopeless, then going on, do you feel you'd be better off dead? When you're at worst, have you thought about actually ending your life? Have you thought about how to do it? Have you had periods of wanting to act on that plan? Do you have access to means? And last and most importantly, because the further down that list you go, just notwithstanding what I said about prediction, the more serious it's becoming. But if at the end of that, the person has a plan, has extra means, but most importantly, they feel everyone will be better off if I'm not here, then those are the people who are at greatest risk, okay? So there are people who, when depression becomes very severe, flip from that feeling of if I die, my kids will suffer, you know, and my family will suffer, I can't leave them. But there is a point in that kind of trajectory into severe and severe depression where that flips around and people get to a space of literally believing that everyone important to them will be better if they're not around. And that is a very significant marker of risk of actually acting. So, so if people answer yes to thoughts and to means and plan and have access, it's also really helpful to go beneath that, not just accept it at face value, but to actually ask them about what the things they've been thinking about are. So, you know, so if someone said thoughts of hanging themselves, have you planned a place to do it? Do you have a rope? Have you gone so far as to go to that place with the rope and so on? Getting that far into it can feel uncomfortable, but just really digging into and uncovering the extent of it is really critical. Likewise with thoughts of an OD.
Just asking, do you think it's better and do you think you'll get more honest answers if you have a form that you can send them to do on your own, read the questions, and then test will know, give you a scale from 1 to 5?
So there are screening tools like that. There's one called the Columbia Suicide Rating Scale or something. There's a lot of controversy about how accurate they actually are because they're a combination of markers like that and a predictive element. But we kind of know we can't predict, so there's a lot of controversy about that. The other thing though is that the sense is that asking and digging into yourself, you are more likely to elicit an answer. Particularly, so you know with, I don't know how you ask people about how much they drink, for example, but I'll tend to exaggerate to get the person to tell me an honest answer rather than ask how much do you drink. So if they drink beer, I'll say, well, how many boxes would you drink in a weekend? And so for some people, that's actually what it is. But for others, they'll at least then pull back, whereas if you start below, they'll respond, okay? So, you know, saying, you know, being really explicit along the lines of, you know, well, did you actually get the pills up to your mouth, for example? Going, if anything, over to get then an honest response. It can feel uncomfortable, but it's really important because those most at risk are those who are least likely to be honest unless you really push down. And also asking about other means as well, because it's not uncommon that people actually who die have said in an assessment that they're thinking about this and they end up doing that. And sometimes that is of a greater lethality. So the other thing though, as part of safety planning, and this is really strong evidence of reducing rates of completed suicide, is reducing access to means. And that's why asking those questions is so important, because if you can, as part of a plan, get a family member in who agrees to actually go and take the pills away or take the rope away and so on, that then in that moment of impulsivity will remove the access to the means. Look, I'm not going to go through this because it's mostly pretty well known, but the first 3 questions with the digging down, that's the kind of, if you get no from there on, that's the space where actually we can mostly safely manage this in primary care. It's actually the second set of questions that are the point where actually we're digging down, finding more out about it. This is most often going to be a crisis team referral. Sorry, I did it the wrong way around. These are the crisis team referral ones, sorry. I should be reading the slide. So, you know, I mean, people who have a plan, have intent to act on it, have got the means, who feel others would be better off without them, anywhere down that scale, they're the people who really are likely needing a crisis team response. Whereas it's these, if you don't get any further than this in terms of positive answer, then that's the space in which, you know, managing in primary care, getting a safety plan, giving people the 1737 number, instilling some hope you'll get through this and so on, we can safely do. And Natasha will have these slides for you, but this is just the safety planning template that's used and where to get it on our system. So look, the last thing about suicide risk is really, our predictive ability is really terrible. If in doubt, then actually, if your gut feeling is not right or if you're not sure, really take notice of that and consult a colleague, you know. Don't shoulder this burden alone. Because if you have, worst thing is, because, you know, you do your best, we have a death. If you've taken that on yourself, you have to shoulder it alone. Whereas if you've shared the burden by consulting, it's protective to you, both medico-legally as well as personally. Okay, and document well. And then there are some notions around suicide that kind of really piss me off. Excuse me. People talk about someone choosing to take their own life. Yeah. You'll have all heard that. You maybe even have thought it. Suicide is actually probably the thing in life which most exemplifies people being in a situation of no choice. So people who die by suicide die because to them there is no other choice or option that they can see ahead of them. Okay? So it's not a choice. And it is also an ultimate act of alienation. People who die by suicide in that state are completely disconnected in reality or in their own minds from those around them. And so it's in that space also where people are able to cut the tie to life. So that's the piece about suicide. Any kind of comments or questions? I'm just going to very quickly then talk about the distinction between suicide and self-harm. Pretty somber stuff, isn't it?
Just curious what the symptoms are for the mental health symptoms when they come in. You said 90% of the people commit suicide.
Yeah, so the common kind of diagnoses that sit behind that, mostly depression, but also addictions, people have high rates, borderline personality disorder. So people who self-harm, what I'm going to go and talk about, they also do have a high risk of eventually dying by suicide if they're not provided good care, and that's tough. And psychosis, so be it bipolar form of psychosis or primary psychosis like schizophrenia. So people with psychotic syndrome are at higher risk. People who have mania and depression are at higher risk, depression alone, and addiction is often woven through, but as a standalone risk factor as well. Okay?
Thank you. And is the app, that's for the patient to do with?
Yeah, so you can get people to download it from the App Store and just fill it out with them on their device. Yeah.
Do you know why the rates of suicide in New Zealand is so high?
Yeah, no, that's the answer. I mean, we can all conjecture. Like, the rates of depression in young people in this country from 2012 to 2022, so I'm not talking about diagnosed, but screening for significant symptoms, went from 12% to 22%. Why? Yep, I think the COVID lockdown undoubtedly had an effect, most pointedly on teens. Social media, yeah. And there is, not in New Zealand, but internationally accumulating evidence about the risk of, you know, so there's a bit of a dose-response curve between the amount of time spent in social media and well-being. Yeah, absolutely. Yeah. So young people are most vulnerable to that whole contagion plus the, yeah. Yeah. Look, I mean, generally, what you need to do is be able to be open about it. Because also, there is this real dilemma around talking about suicide. So, on the one hand, what's really clear is that particularly talking about suicide identifying needs can increase the risk of that contagion effect. But on the other hand, not talking about it is also unhelpful. So it's a delicate balance. And also, if you are going to acknowledge in the school environment, particularly, you've got to put really good support around that school population. In Auckland, all 3 districts have suicide prevention and post-prevention coordinators, and they can activate support. Hopefully most schools through their health teams know how to contact them, and certainly if you, in your contexts, have concerns about that, then we have the contact details for them across the region as well. Okay, look, we've got to move forward. So you do see the situation of people who come in either as a one-off, but often repeatedly with self-harming behaviour, particularly self-cutting. And I imagine, particularly in A&M clinics, that's not an uncommon scenario. People who've cut themselves and who come in and need to be stitched up, basically. So there is this distinction between acute suicidality, which is someone who has become, let's say, depressed and in the context of that becomes suicidal, and people who have often experienced adversity growing up in varying kinds and who develop elements of what's kind of thought of as chronic PTSD versus borderline personality dynamic, and whose response to distress is to actually harm themselves because physical pain kind of somehow relieves the emotional pain. So treating those people as if they are acutely suicidal tends to inadvertently reinforce that behaviour. So if you're seeing people like that in your clinics, ideally what you need to do is work with your local community mental health team to actually get a plan in place around how to respond more productively to that, okay? The thing is that it's a risk to take as a clinician, as an individual, and even as a primary care team. So it's something that really needs to be done in collaboration. And often, where this is really severe, it's a plan between ED, the community mental health team, and the primary care teams. So it's just to make you aware of that distinction, because it is an important one just to have in the back of your mind. And I guess this is just to underpin the fact that, you know, we tend to kind of see physical scars, not emotional ones, but a lot of people who do this, you see the physical scars, but actually you can guarantee behind it are greater emotional ones. So look, I think we've had plenty of discussion about the risk thing. So the next thing is the distressed person who presents as angry and threatening. And you know, I think it's just reinforcing this whole thing that underpinning it is almost always distress. So as a broad generalisation, so there are 2 ways people manifest distress. They internalise it into emotional distress, anxiety, depression, or they externalise it into unpleasant behaviour, anger and so on. As a broad generalisation, men more tend to externalise and women more to internalise, and so you know you'll be aware that it's more often men than women who are behaving badly in clinics, isn't it? So I guess it's that understanding the person is suffering. It's bad behaviour, but it's not necessarily willful. It's their own kind of suffering and lack of ability to regulate emotions and to allow their rational mind to override their emotional brain. So angry threatening behaviour is more likely, as I said, childhood trauma, but also other things to think about are the neurodevelopmental conditions or neurodiversity, so autism spectrum and ADHD and so on. If there's an underlying personality disorder, which can strongly relate to the first particularly, to a degree, but sometimes the second, and occasionally, particularly in men, depression manifests as primarily irritable mood rather than sad mood. And so sometimes a man who is not traditionally someone who is angry, externalising in their behaviour, if that starts, it can actually be a manifestation of underlying depression. We've talked about all this stuff though. Try to de-escalate, de-calm yourself, use the required space, capacity to observe and contain. If necessary, I know, you know, I mean in White Cross, I don't think you routinely have security on site, do you? No. So it's EDs that do, but so I mean really if it comes down to it though, it's about bringing police in if that's what's needed to keep everyone safe. My observation in some of our clinics is that people get kind of into a bit of a hot frog thing with bad behaviour, or with angry, threatening behaviour. So the whole hot frog thing? If you put a frog into a pot of boiling water, what's it going to do? Jump out. But if you put it in a pot of cold water and heat it up gradually, it'll cook. And I think we easily get subject to that, where we just tolerate more and more and more. And I think it's really important not to. So, if you're not feeling safe, you need to kind of, try and calm yourself, but if you can't, don't kind of feel you've got to kind of continue tolerating. So just a little bit about neurodevelopmental issues, because, and this is not universal, but it's just something to keep in mind, that for some people, particularly men more often, but with ADHD, do struggle with impulsivity, irritable mood, poor frustration tolerance. Can sometimes be a manifestation of this. There is much greater awareness now of this, so we're much more seeing people help seeking to access the kind of diagnosis and treatment they need. And also autism spectrum, so particularly this space where anyone on the spectrum is easily going to be overloaded in a high stimulus environment and be prone to meltdowns and can often, that can manifest in angry behaviour and so on. So, if in your kind of classifications you're seeing any of these things, then it's just something to keep in mind, because treating them will actually result in reduced distress.
I just
Yeah.
have a question and an example. We had a patient who was put on the queue for the doctor requesting for a repeat Ritalin for his ADHD. Is there a requirement for him to have to come in and see the doctor for the doctor to ask him the general questions? How are you feeling? What is your mood?
So
That really triggered him. He got
Yeah.
so mad.
So look, there-
Medicine's running out.
Yeah, I know.
Yeah.
So we have to review people on repeat meds 6 monthly,
Right.
okay? It used to be that you could only get a month's prescription. We can now do 3 monthly, just like any long-term condition. So I think that's,
6 months.
yeah. But I mean, the thing to do is just, if that happens, to remind your GP colleagues, because they won't all remember, because, they're in the habit of only giving 1 month prescriptions. So just remind them that we can now do repeats for ADHD meds as well. Because the problem is, getting in every month to get a script is quite a hassle, really, particularly for someone who may be, have run out, and then they're kind of, back to having all the symptoms,
So it's
including.
just me knowing what is
Yeah.
able to happen, so I
Yeah.
can send it back to the
Yeah,
doctor.
yeah.
No, the patient doesn't
Yeah.
really send it.
So if they've been seen within the last 6 months, then all they need is a repeat. Okay? But also remind about the 3 month now too. Okay, so moving on then though to the more focused thing of violence and severe mental illness, what do we know? Because on the one hand, the generalisation is that people with severe mental illness aren't at greater risk, but there are 2 situations /3 in which risk is greater in an acute sense, okay? So the first is that some people in the face of acute symptoms of psychosis will get into a situation where they feel that their safety is threatened by others, okay? Now if that's a general them out there, like the CIA are following me and trying to assassinate me, as distressing as that is, if that's your reality, there's no identified person or group of people in your environment who you're at risk from. But if you actually believe that your neighbour is a CIA plant and that he's there to assassinate you, people get into this situation where the extent of the perceived threat overrides their normal controls on their behaviour. And that situation, the neighbour, is at significant risk, okay? So it's something to be aware of, first thing. The second thing is, and I can't remember what order I am. So the second thing is the situation of severe depression, where people can get into a space of depression with psychotic symptoms. So their thinking is so distorted that it's actually tipped over into overt delusional thinking. And in that context, if someone becomes suicidal, they may also get into a state where they feel the world is such a terrible place that killing those they love is an act of mercy, okay? So not all murder suicides are this, but there are some that are. So it's again something to be aware of if people are severely, severely depressed. Now if someone's got psychotic depression, that's an acute mental health referral anyway, but that's the second situation. But again, it's acute, not enduring risk. And the third is people with command hallucinations. So voices telling them to actually harm or kill someone else, and who actually feel that they can't control that the force behind those voices impels them to act on it, okay? So that's the whole thing around why if people are hearing voices asking them if they're getting commands to harm others is important. So just to be aware of that. More generally though, younger men are most at risk of acting on, in the face of severe mental illness, on drivers to violence. But as I've said, mentally ill are more often victims than perpetrators. The other big thing though is the intervening impact also of substance abuse. So, I mean, abusing / being addicted to substances is also a significant driver, and when you add the two together, it becomes a kind of 2 + 2 equals more than 4 situation. All of these substances do overall increase risk. Comorbidity is increased risk, but actually the biggest risk is actually people who are substance abusing and have severe personality disorder, particularly antisocial. So I guess the caricature of antisocial personality is the gang member, isn't it? So, I mean, just to highlight that whole thing though, that you kind of take a reasonable person and put alcohol in the face into them and it can completely change the way they behave. And actually, we tend to kind of think of methamphetamine as being the demonised drug of our era, and God knows it is, but actually at a population level, it is still true that the greatest harm, including driver of violence, is alcohol, which is available pretty much, you know, in place of the old-fashioned corner store now, isn't it? So I'm going to run through this quickly because it's really not stuff that you should be expected to really do as a day-to-day thing, but it's just to be aware of it. That the best predictor of future violence is past violence, as with suicidal behaviour. Family history of violence, of growing up in normalised violence context, is also a significant factor. History of impulsivity, so impulsive people are much more prone to both commit violence against themselves but also others. Childhood abuse and trauma, head injury history, male sex, younger age, lower IQ. Those are the static risk factors. So prediction of violence is about thinking about the static factors, the things that aren't necessarily amenable to actually change, and also about the dynamic factors. So in terms of dynamic factors, current substance abuse is actually the most significant one. So obviously addressing that is an opportunity to reduce risk of violence. Access to weapons, as with access to means of suicide, untreated psychotic symptoms, and or people with psychosis who aren't good at actually adhering to treatment. And as a general thing, believe it or not, unemployment. So unemployment is a risk factor at a lower level across the board. I didn't talk about it with suicide, but it's a risk factor for, you know, lower levels of well-being, greater levels of mental health symptoms, of suicide and of violent behaviour. But you know, the determinants of all this are really complex, and I guess just to acknowledge that it's seldom one thing, it's often a whole constellation of things. The important thing here is to be aware that these things do relatively amp up risk, but there are some, like substance abuse, that if you can get agreement to do something about, are going to reduce it. So I've kind of covered that, haven't I? But again, it's that same thing though. You know, have a very low threshold for consulting someone else in your team, and trust your gut instincts. If you feel worried, you probably should be, and document. I mean, the other thing, I've kind of covered all that. The other thing also though is it's very easy in life to treat a presenting kind of situation as if that's all there is to it. But particularly in terms of people who come in behaving aggressively or who are, you know, seeming at risk to others, it's often just important to be aware that there's often a context which makes it more understandable. So just asking people what else is going on in life. So if someone is at significant risk, there are two different pathways here. If they are in a state of acute mental health symptomatology that's resulting in impaired judgment, so for example, the very severe depressed mood with psychotic symptoms risk or the delusion-based risk, then that risk needs to be contained if you can agree a plan by implementing the Mental Health Act, okay? So mental illness plus risk and inability to agree a way of keeping everyone safe, Mental Health Act is the road to go down. Whereas in the instance of there being no clear mental health symptomatology, but other factors at play, let's say substance abuse, personality disorder, then that's when police involvement is the appropriate path to go down. So let's say you see someone who has a history of coming into the clinic and shouting and yelling, and who on this day also says that they're so mad with wins that they're going to go down and kill their case manager because they've had their benefit cut off here. But they're not depressed, they're not psychotic, that's police business. And again, it's the other context, so risk to self, risk to others. In both police and mental illness, it's the one situation in which the Privacy Act provisions are overridden. Lower risk is really, as with suicide, about a plan to address, and often, you're never going to be in a situation of having to do that yourself. But if you're uncertain, again, just getting an opinion from a mental health service or a mental health clinician can be really important. So, how are we doing for time? Oh, I've got overtime. Look, the acute psychosis stuff is much more straightforward, so I might actually finish there. The slides are there, but I don't think there's going to be a lot of news in there for you. I think we've covered some of it already. So any final comments or questions before we draw the session to a close? Well, thanks anyway. Great questions and case scenarios. Yeah.
Oops. Do you guys need a 5-minute break? You guys okay? Addictions Coordinator for Tamaki Health.
So good morning, hello, kia ora, and if you're from my neck of the woods, hey up. So, I promise I'll do my best to keep to time. As a wellness advisor, we used to cramming everything in 20 minutes, so I'm just going to put a timer now. She says taking 5 minutes to do that. So thank you for being here. Now, what I meant to say to start off with, I'm going to change completely, because literally a funny thing happened to me on the way here this morning. And as I was leaving my township to come here, there was flashing lights from a police car that sped in front of me sideways. 2 coppers jumped out the car, assumed the position over the bonnet on one side, one policeman, yeah, and another one ran round the side, and I'm like, what? Then I noticed a person on the pavement who, thankfully, they were directing all of this to. So, because I was thinking, I must be mistaken identity here, you know, and this going, oh no! And I noticed that this person was carrying a crossbow as well, so that's what they were trying to get him to drop and to get. So meantime, I'm sort of backing up, reverse, even though there's people behind me just trying to get out of the firing distance. So I thought, well, if that doesn't increase my anxiety, I don't know what will. So yeah, and it's a true story, I promise. So usually what I am is quite nervous about actually my pronunciation with my pippy har, but now I'm just wondering about actually being able to speak coherent English. And for those who know me, probably say that I don't speak that coherently anyway. Now, also I just want to say that I was being quite optimistic when I put the presentation together, so I've got quite a few slides. What I won't do is talk my way through all of them. Hopefully I've covered everybody's sort of learning style, so I've got some writing, pictures, and hopefully moving pictures as well. And know that we've got morning tea coming up, and no pun intended, because now I realise I'm at a race course, that I know that you'll all be champing at the bit to get to morning tea. Seriously, it wasn't. Now then, where's the clicker? Okay. So, Core, Ben Lomond Monga. Next one. Core Loch Lomond Hour. Core Irish Sea Hour. And Core Southport Aho. So if you look between on the map on the right hand side, you'll see Blackpool. Underneath you'll see Liverpool. Right in the middle of those two is a place called Southport, which is where I was born. Core McLaren Walker. So my great-grandfather would have laid his eyes on both Ben Lomond and Loch Lomond from his hometown, and he was a McLaren. Unfortunately, I don't think it's from the same level of the family that own the racing cars, but I live in Hope. So yeah. I always forget to say what my name is, so Lisa Forshaw. Don't know why I put the full Sunday name there, but also added a couple of things that are non-work related there, just to hopefully make it a little more interesting. And as you can see, my cat Marley's very thrilled by it all. So, what am I going to talk about? I'm not going to read through all of this. I'm going to let you do that while I do some breathing. And you'll notice at the end I've got other service from the wellness support team, which I cleverly didn't put into the presentation. But what I will do is I'll have a pack together that I'll give Natasha to send out, so you've got information. Okay, so Primary Mental Health and Addictions Coordinator. It's quite a jazzy title, just rolls off the tongue, doesn't it? Now, this picture I thought was a good example of what usually I'm like Wednesday to Friday, because there's places to go, people to see, things to do, never-ending lists. But actually what I do feel the role is on like the bridge between primary and secondary care, and support for my colleagues in primary care with anything mental health, and also the bridge for secondary care services that I'm the link between, so that if secondary care mental health services have got a patient that they're looking to transition to full GP care, then I should be involved so that I can help with the liaison. And if that doesn't happen, let me know. And always come to me now, because I've not looked at any of the cards. But it's one up from the last presentation I did, because I stupidly threw all the cards on the floor deliberately and then spent the rest of the presentation desperately wanting to pick them back up. So I've done that. Okay, what else? Any queries, talk to me. Now that you know who I am, I do come round the clinics, and I plan on doing that a lot more so that you get to see me regularly. Okay, so why mental health? I believe that mental health is everyone's business. We can't distinguish really, between mental health and physical health. I guess an example would be if we've got chronic pain, we know that it will have an effect on us mentally and our mental well-being. Okay, next one please. So we're all familiar with the Barry-Tappafar model, and I think I put this in just to show really that if we're not attending to all of our walls in the roof, if one of those is taken away, the fire will crumble. Okay. So the PHQ2. So during Mental Health Awareness Week, we set a challenge for you to use this as business as usual, and I don't know if anybody took that challenge up. Hopefully some of you did. And I guess it is really important. If we don't ask, we don't know. And if we start to use this, I know at first it can feel quite uncomfortable. Might be about actually starting the conversation off in how you would usually make it as part of a conversation. How have you been in yourself for the last couple of weeks? And then going on to this. And I know that the more we do, the easier it gets. Okay, so it might surprise you, because it did surprise me, not necessarily it'll surprise you as well, but approximately 280 million people worldwide have got depression. In fact, it's probably more than that, because as we know, if those that haven't been to the doctors or have come to the attention of services or talked about it. And in New Zealand, there was an Ipsos survey, and 1 in 2 people in New Zealand reported that they'd either been stressed or depressed. Okay. And again, I guess as over from the Mental Health Awareness Week, we use the 5 ways to well-being. And as we know, this is evidence-based, that if we attend to these 5 ways of well-being, then it will improve our quality of life. And this is maybe where we start, with patients, just for the patients to then take control and decide on which area they'd like to start with. Okay, now, integrated team. Who are they? Hopefully at this point the video will start, because we've got a video from the Auckland Collaborative that can explain to you the different roles in about 2 minutes rather than 10 from me.
Kia ora. If you're like me, life can get a bit stressful sometimes, and I need some help to get back on track. I've been to a new wellbeing service at my local GP clinic. You can too. It's free, and you can use it as much as you like. They help me get my life back together by providing practical support and helping me focus on what I can do to help myself and my partner. Let me tell you how it works and share a bit about my experience. Just go to your local GP clinic and talk to them. Tell them about the problems you're struggling with and how you are feeling. You will get to see the well-being team at the clinic. The team includes a health coach, a health improvement practitioner, and an uppy order community support worker. The whole team is there to support your well-being. The health improvement practitioner and health coach work with your doctor and nurse at the clinic, and the uppy order community support worker can provide support outside the clinic. You can see the well-being team by yourself or with your partner or father. The well-being team will work with you to understand what sort of help you need. I was feeling tired a lot and a bit stressed out with work and money stuff. We had a chat and worked together on a plan which made me feel much better about things. Many people get what they need from a single session with the health improvement practitioner or health coach, but it's also common to need more than one session. Your health improvement practitioner, health coach, or any member of your clinic team can also introduce you to an uppy order support worker. They can come to your home or meet you somewhere in your community and help you to work towards your well-being goals. My community support worker kept supporting me for a couple of months. There was someone I could talk to and trust, and they linked me into other services and supports I needed. My niece is also seeing the health improvement practitioner at our clinic to help her cope with the netball injury which she is struggling coming to terms with. I tell you, the well-being team can help you and your father with all sorts of challenges. So, if you have a frown and are feeling down, my advice is come talk to your local GP clinic and ask about the well-being service.
Of course I did that.
Oops. That's what usually happens to me. Okay, so, and I'll romp through this. So health improvement practitioners were known as wellness advisors within Tamaki. If there's one thing that you remember about the wellness advisor is we see anybody, any age, with anything. It reminds me a bit of a UK Martini advert actually years ago where it was any time, any place, anywhere. Sorry. And we're known by the acronym GATHER. I won't go through all of this. I will say that the high productivity part is actually now changed to high impact. I always thought it was helpful because we ask everybody that we see how helpful have you found the service. And just to mention, I guess, about the routine pathways as well, both the health coach and the wellness advisor, we set up pathways appropriate to the clinics. For instance, I work for Seddon and we've set up a youth ADHD pathway. With what? I'm going to skip through. And of course, we had a competition, I don't know if it was last year. I did a video for Dr. Zakia and Don, and of course it's all about me, so we'll put that on. Next one, please. And I guess in practice, of an example, and again I won't spend time going over, just like if you can skim read it really quickly. Okay. You can always come back at another. So health coach. And again, I guess just for a couple of things, but the health coach to determine, distinguish between wellness advisor and health coach. Health coaches will focus more on patients with long-term conditions, those wanting to make changes, healthy lifestyle. They can also go in to see the GP with a patient, and as my colleague from Seddon, my health coach Ricky, how he describes himself in his introduction to patients is that he's like a cheerleader without the pom-poms, which I think's great. I'm going to get him pom-poms then. And again, because we love acronyms, for a health coach it's HEALS, and with what we'll skim over, because again you can come back to. So how to introduce? One way of introducing is when you're with the patient, I've got a colleague that can really help in this kind of situation, and he or she can be available right now to let me introduce you to them. And don't ever be scared of actually knocking on the door and disturbing us at any time. We're used to that. That's why we've got on the sign, actually, anytime, knock on the door. Also, if you needed any tips or strategies that you can use with patients, always ask your wellness advisor. We're there to help and educate, and we're very happy to share resources as well. So, AFI Aura, and that's our community support workers. And as I described them, they literally walk alongside supports. They're based in the community, and they can come on board for up to 3 months. Now, you can count, yeah. Again, no wrong introduction. And as David mentioned, everybody can make those introductions. Wellness advisors and health coaches will be happy to, for the different clinics of how you do that introduction. In Seddon, I have the AFI Aura support workers coming in regularly and making themselves known to everybody, including, nurses, so that you know who they are and when they come. And so when you do make introductions, they'll be able to give you the feedback. I guess as well, the importance is, it's like being right at that time rather than waiting, so that if you feel that somebody would benefit from that support, it's about being able to do the introduction there and then. And the same as, knocking on the door, just for the warm handover to ourselves, so that they can at least put a name to the face. If we're not actually in the clinic, then you can put the patient into one of our scheduled slots. On our template, you'll notice that we've got scheduled in the same day. So obviously, when we've got the warm handovers for the same day slots, it means we can literally see that person sometimes, and we'd hope that they'd only need to wait half an hour for us. Okay, so, romping right through. Again, next one. Right. We're nearly there. Morning tea's in your sights. Okay? Now, have a case example. As you know, part of my role as the coordinator is to come out and help them do education. I did do some education for my own clinic for Seddon, attended our nurses meeting, and those of you who are in the county's Manukau catchment will be familiar probably with the term CCM wellness. And so that's what I was doing some training on, and again asking the questions of, how are you, what's going on. Now, a couple of days later, there was a gentleman who came into the clinic. He was seen by one of my colleagues, one of my nursing colleagues. He came into the clinic because he thought he had a UTI. This gentleman, sorry, I forgot to give you his details. He was a 44-year-old South African gentleman. He thought he'd got a UTI. Whilst my colleague was talking to him, she took the opportunity to actually ask him a little bit more and ask him, what was going on. And she found that he'd recently split up from his partner, and he was really struggling, feeling really overwhelmed. And he reported he hadn't really eaten or drunk anything for 4 days. So she took the opportunity then to hand over to me straight away. I had about 10 minutes that day, so obviously I did my introduction, I spent some time with him, we got a plan for overnight, and he came to see me for a longer consult the next day. Now, during the next consult I found, he put an awful lot of weight on fairly recently. He did have high blood pressure. I wonder whether he was actually pre-diabetic as well. He had had a difficult couple of years beforehand and was feeling really overwhelmed. So we agreed that we'd work on some strategies for him. But because he also wanted to make changes and healthy lifestyle changes, I then did a warm handover to our health coach. Now, I saw him just one more time after that, and I know my health coach worked a couple more times after. Now, Ricky came back to me a couple of weeks ago just to give me an update for this gentleman, because he was, the patient was really proud that he'd lost 23 kilos. He'd changed his job, found a job that he absolutely loved and has moved up north to do that. it let Vicky know that actually he still used the strategies that we'd worked on and found them really useful. But I think the most important thing for me was that if, and I always get emotional this bit, if my nursing colleague hadn't asked him the question about how are you, what's going on, the outcome could have been so different. And that's why it's so important just to have that conversation. Okay, that's it, I'm done. Now my colleague has got a presentation on the mental health credentialing. Unfortunately, she can't be here, and I know the time limited, I'm 2 minutes over, which is not bad considering I was 5 minutes late starting. So, I guess key points for the mental health credentialing, obviously you can read the presentation at your leisure. Just know that this is a fabulous, it's a fantastic course, it's free. It really helps to upskill and for us to build the confidence in being able to work more and ask the questions regarding mental health and well-being. And again, one of the wonderful nurses that I've met on my rounds had done the mental health credentialing course, and she gave me an example that was quite similar to the one I've just actually related to you all, in that she learnt some skills and ways of asking that she wouldn't have used before. And again, the outcome for one of her particular patients was completely different to what it would be if she hadn't asked. So that's it in a nutshell. We always come back to me if you've got any questions. And this will be online for you. Also, I've got a chart that actually tells you about, the integrated team, who we are, what we do, how to introduce. So I'll get that sent out to you as well if it's not around in your clinics. Thank you very much.
Does anyone have any questions?
Oh, good.
We will take a 10-minute break. There is food all sorted there now. If anyone has messaged me about specific dietary requirements, there are labels to specify.
appointment and feeling about this big. And I was horrified that I felt that there was that much of a power imbalance. So I'm articulate, I'm educated, and I'm well familiarised with our healthcare system. And if that's how I felt, then I really felt for people who aren't in that privileged position. So I'm not joking when I say this is about a person's voice. It's about a person having autonomy, authority, and being able to ask the questions they need to ask to get the information they need to make decisions for themselves, and to share those decisions with the people who are important to them so that they can be honoured if they can't speak for themselves. The guide is sort of in two parts, really. One half of it has got sort of pink bits. Please don't think that you have to go through that and answer every question in the pink bits. They're just a guide. There's some ideas to the questions you might want to think about, or the questions that you might want to pose to some of your patients. The white side, again, is a template that people can write into, but they don't have to write into every section. And honestly, if they really want to, they can write it down on an A4 piece of paper. It's just a template. We're just about to take a revamp of this to make it more user-friendly. But the Commission has decided that with all the restructuring going on, we just need to focus on where we're going to be in this system, and they will get back to this hopefully next year. A lot of people come and write this in pencil first. And a lot of people don't want to write into it at all because they're afraid that if they write it down, they've set it in stone and they can't change their minds, and that we will follow it to the letter of the law. Please reassure people that this should be used as a platform to start a conversation to make sure that their preferences that are written in the guide are still current and correct. I have to say, in my own personal clinical practice, when I've been able to pull and draw down an advanced care plan and go into a room with a person and their family and say, thank you very much for completing this, it's invaluable information. Is it still current and correct? Can we talk about it? It has been a huge icebreaker. Often because when I have to go into a room with somebody, they are in a crisis, they're clearly feeling sick, and they might be under the influence of any number of medications, pain relief, whatever, and they're sedated. So it just eases some of the conversation. It's not a panacea, so it's not a cure-all. Some of the conversations can be quite challenging, and for some people, they will have family, whānau, who do not agree with the decisions that they make. So it can be difficult for them to have those conversations and to engage family. What I will say and what I have found is that even if people can't or don't agree with the decisions that person has made, they are grateful that they have known what that person wanted or wants, so that when they're in the position of having to make those decisions themselves for that on behalf of that person, they at least knew. It's almost like muscle memory, if you like. And when they're in crisis, they could pull that information back. What I've also had as feedback, and not just me, but in research, is that when we've asked people who are in the grief process because somebody has died, what they've said about advanced care planning is that it actually has made that process easier, because they did feel that they knew what was what and that they had honoured the person who had died. So it has benefits both while we're alive, but also for those people after we've passed as well. Why am I making an advanced care plan? Really, as I say, to encourage the conversations, which is the big grey space in the egg. You may never get past conversations with people, and that's just grand. If we can talk more openly about what's important to people and how that influences their healthcare, perfect. That's great. That's what it's all about. If they want to write an advanced care plan, please help them. Remind yourself and remind them that it's about them. The advanced care plan is designed so that it is person-centred and owned by that person, and they can write into it themselves. Anything they like, anything that's important to them. Please, if somebody is coming to you because they want some support around writing advanced care planning and advanced directives, and they have some very firm beliefs on what they do or don't want, ask them to write it down quite specifically, particularly for an advanced directive. I would encourage people to date an advanced directive and an advanced care plan. They don't have to, but I would encourage it. In the case of an advanced directive, I would encourage people to be quite specific about what they would or wouldn't want as far as care and treatment goes, and what circumstances, and anything else that might have influenced that decision. There are some really good guidelines, just if you Google up Advanced Directives New Zealand, and some examples around templating as well for people. An advanced directive is not a legal... An advanced directive has got legal standing because it's been tested in a court of law. But it's not a legal document, if that makes sense. So they don't have to go to a lawyer to write an advanced directive. People have that a wee bit mixed up, and I think quite often it's because when they've gone in to write a will, they've gone to a lawyer, and oftentimes they'll be offered, do they want to do an advanced directive at the same time? So just keep that in mind. For an advanced directive? Nope. No, again, because it doesn't have to be written down. But that's a really good point. You know, if you want to have it witnessed, please do. Just the same as with an advanced care plan. If you want to have it witnessed, please do. There's a page, I think it's page 12 in the guide, which has got spaces for the person to sign their plan, and also for a health professional or practitioner to sign the plan as well. Look, I would, having said that they don't need to be signed, I would encourage people to sign them and date them, and also to ask a healthcare professional to sign and date it as well. And the reason I say that is that what that indicates to me and my colleagues is that that person has had a conversation with a healthcare professional, and I would hope from that conversation they've clarified any unrealistic expectations that somebody might have about care and treatment options, but also that it's the opportunity for them to have asked and been given information that they need around those decisions that they've made in their plan, so that what's written in the plan is consistent with their current healthcare conditions, and that they are aware of that even though what's written in their plan and in advanced directives does not have to be followed by a healthcare professional if it's not clinically appropriate. So I have a lot of people who say, yes, please, do CPR on me. But in the clinical setting, if you've had a respiratory distress, the clinician will say, this person really may not be appropriate for CPR, because it doesn't matter how much I compress their chest, they don't have the oxygenation because of their respiratory condition to do any good. In fact, we might do more harm because we might actually just be puncturing their lungs. So just be aware, unrealistic expectations and everybody on the same page. I'd also really recommend that people, you do go through somebody's advanced care plan, because we use jargon and so do we in day-to-day practice. So what I use is day-to-day clinical language. I would never use if I was a patient, because it's not the language I use as a patient. I have had a number of plans that say, please don't do this, this and this if it looks like I'm going to be a vegetable. I don't know what a vegetable is. It's not professional language. I wouldn't use it if I was going in to speak to somebody, but knowing that it is our jargon that we use day to day in New Zealand, if somebody comes to me with that in a plan or says it in a conversation, I ask them, well, what do you mean? What does that look like for you? Can we write that down in your plan so that I can hand it on and people know what that means for you? So that's really important. Any questions? How much time have I
I was
got?
just wondering if we can, we got advice or tips for us working in primary care.
Yep.
And say, for example, a patient comes in and she says, look, I want to do some advanced care planning, and what would you do in that situation?
Okay. I think it's like every conversation, find out how much they know about it. Yeah, please don't shut the conversation down, is my first ask of you. If you don't know enough about it, say, look, I've heard about it, but I don't know enough about it. Can we find out about it together? Find out what they want to know. Find out how much they know. Quite often people just want permission to actually have those conversations, which in some respects surprises me, but actually probably generally doesn't. We have sanitised our healthcare system, and we've almost made it a wee bit elitist in that we are in a really respected position, and a lot of people do not want to offend us by questioning our clinical recommendations or by asking if they can have something different. So when somebody has had the courage to ask about it, please acknowledge it and ask them and support them in it. Look, you can always phone me. My contact details are on the front of these. If you are ordering directly from Health Quality and Safety Commission, or you pick up information that hasn't got somebody's contact details on them, go onto the Health Quality and Safety Commission's Advanced Care Planning website, and there's a map there that shows you who the lead is for the region that you're in. And please contact any of us. And if you can't get hold of the person in your region, try the next region. We're a really close network in New Zealand, so we know each other well. So yeah. Does that answer your question? Yep. Where's the tricky question? So they're two separate, completely separate entities. So in New Zealand, legally, we cannot bring up assisted dying with somebody. We have to wait for them to ask us. It's not included in the advanced care plan because it's not considered to be a treatment option. Does that make sense? Now, that said, I have had people say that they want it known that they are or are not in favour of assisted dying, and that's just so that we know that that's part of where they're at. You can write anything you like in your care plan. Where it needs clarification with somebody is that I've had a couple of people write it in the likes of an advance directive and say, I would like assisted dying, and I have to go back and say that wouldn't be able to be on it, if that makes sense. Because in New Zealand there are very specific criteria around when you can receive assisted dying, and one of those criteria is that you need to be competent up until and on the day that you choose to die.
So you couldn't get someone who was experienced dementia at a very early stage say, I want to get assisted dying?
Look, I really recommend that you go to the official website for assisted dying and look at the criteria. They've got a really good website and some e-learning around that. That person has to be confident. And they have to meet that criteria before they can even engage in that process. So, as I said before, you could be in the early stages of dementia and still be deemed competent, but the reality is that you may not be competent in that next 6 months. Yeah, so, yeah. The other reason why it's not included in advanced care planning is that advanced care planning is designed to be used when you can no longer speak for yourself, whereas assisted death, you have to be able to speak for yourself right up until the day. Does that make sense? Yeah. Yeah, so I mean, I say to people, look, you know, if you want me to know about it, you want me to know about the context that is in which you're forming, you know, the decisions and making decisions in, then if assisted dying is part of that, then it's important for me to know that context. Okay? But it won't be offered as a care and treatment option. It's not something that I can honour as a care and treatment option. Okay. Yeah, I hope that makes sense. Yeah, yeah. But yes, it's certainly, you know, when you think back to the egg, that's that grey area where I learn the context over and above the decisions. Yeah? Okay. Yeah.
You said this is not a legal document, so the health professionals can override the decisions.
What's always really important to remember is that in New Zealand, we have a cascade of decision making, if that makes sense. So ultimately, at the end of the day, it's up to that attending clinician to decide what care and treatment would be appropriate at that time for that person. But we have a cascade, it's a sliding scale, if you like. We would initially look for, if somebody's competent, we'll talk to them and we'll make that decision with them. That's easy. If somebody is deemed incompetent for whatever reason, we would look for an enduring power of attorney. That's somebody who can figuratively step into that person's shoes and tell us what that person would have told us if they could, which is different from that person thinking that they can make decisions on behalf of somebody. Does that make sense? Yeah. If they don't have an enduring power of attorney, we would look for advanced directives, advanced care plans. If they don't have either of those, we would look in all of our clinical files and notes to see if there have been any conversations. And I say that with a but because that could be hard to access, but we would look for them. And of course, we talk to the family whānau spokespeople as well to find out what's going on. And then that attending clinician would make the decision about the care and treatment that would be appropriate to offer. Does that answer your question? I'm pretty good at going down rabbit holes, so if I don't answer your question, hold me to account.
I'm just thinking that what is the purpose of writing everything down there, you know, in the end of the day, decide to override that decision that you made.
Because they might be in perfect agreement with what they've written down. Okay. And if you have been having those conversations with your GP, your healthcare team, if you see specialists on a regular basis, then hopefully what happens is that what you are writing in your plan and in your advanced directive aligns with the care and treatment that is ongoing as a process, if that makes sense. So, as I say, said before, people worry about writing it down because they think it's set in stone. It's a process. So every time you have a conversation, update your advanced care plan, update your advanced directive if it's applicable. Keep it current, you know. We encourage people to review them annually, and we used to encourage them to write it, review it on their birthday. I've got better things to do on my birthday than to take advance care plan. So, just set a time, and you've got a bit of time to review them and keep encouraged. And usually I find that people do that either after they've had an appointment with somebody and things might have changed. And it might not be that their health particularly has changed, but some of their care and treatment options have changed because things are changing pretty quickly in our world of healthcare. Sometimes it might be that people come to us and say, hey, look, I've heard about that study, and I'm going, never heard of it, what's it all about? They can tell me. As clinicians, I don't know how much you get in your email box, but I get heaps. So, it's hard to keep up with stuff all the time. Dr. Google is another one. People always come in the door with Dr. Google and you go, wow, haven't heard about it, but we'll check out the validity of it, those sort of things. Sometimes people do change it because they have had a change in their healthcare condition. And people often review their advanced care plans after an episode, a health episode, as well. So if you're in counties and you're a GP, you might be lucky or unlucky enough to get a letter from me every time somebody with an advanced care plan comes into hospital, and I'll let you know that they've come into hospital. Please review their advanced care plan is my last line. Don't know how often that happens, but I live in hope, perpetual hope.
How do you balance what the patient has put in their advanced care plan and what the family are kind of wanting?
At the end of the day, it's not about what the family wants, it's about what that person wants, okay? That said, though, everybody's different. Everybody's family and whānau are different communities. People have spokespeople, they have different decision-making processes, they have, it can be a collective process, it can be an individual process. So you have to go with what that person and their family would like. Ultimately, it's about respecting that person's choices and preferences, but acknowledging that there might be other influences. I think the benefit that I've found with advanced care planning is that having compassionate but open and honest conversations tends to clarify any misunderstandings or differences in expectations. And even if somebody isn't fully on board or comfortable with somebody's decisions, at least they understand the reasons why they've made those decisions, and I think that's really important. I always ask the why. If somebody gives me a statement, I ask, can you tell me why? So that I understand it, and I think that usually is applicable to family as well. One of the other resources that we have, it's a relatively new one, is the Whenua Kiri Whenua. And what it is almost like a gift to family and whānau, if you like. It can be really hard to introduce a new concept to somebody in your family and to explain it maybe as articulately as people would like to. So that just basically explains what advanced care planning is to family. Does that make sense? Again, that's free from the Commission. We are currently trying to get resources completed for our Pacifica communities, particularly Samoan and Tongan communities. We have, through POI, through Hospice in Auckland, some resources translated in Chinese, Hindu, Arabic, Samoan and Tom, but it's very limited. So if you've got a resource that you want or you need, please let us know. The more feedback I get from you, the more I can hand on to people. You're going to just, oh yeah, oh, good. Okay. Yeah, does that answer questions? Sorry. All right. How much time have I got? Where are we at? 15 minutes? Wow, okay. I'm not sure what slide I'm on to. Okay. Talked about capacity enough, I think. Capacity does become important though when you are doing things like enduring power of attorney. I would really encourage people to look into setting up their enduring power of attorney in New Zealand. Enduring power of attorney can be for health and welfare and or financial affairs. Now, it's not my realm of expertise. I'm certainly not a lawyer or legally based. So if you want some more information on that, community law is very good at that. Age concern is also very good. And you can Google it up. There's lots of information on EPO in New Zealand. As I said, an enduring power of attorney can step into the shoes of somebody and represent them. They cannot withhold life-sustaining treatment. And an enduring power of attorney needs to be set up while somebody is competent to do so. And we activate medical or health enduring powers of attorney if we need to when somebody is incompetent. Okay? So there's your enduring power of attorney, and that's the Age Concern website. Age Concern does, they're really proactive in engaging our community, and they do a number of talks and sessions, and they usually have about 4 or 5 that they do on a rolling basis, and one of them is around enduring power of attorney, one of them would be advanced care planning, and a number of others. So if you're wanting to find out how your community can engage with that, just find out who your local Age Concern representative is, and they'll let you know when they're doing their presentations and where they're doing them. And if you have, a number of people who want to attend and they haven't got something set up, let them know. They're really flexible about setting up in your community as well. Okay, so when I'm dying, I quite often get, I don't need to do an advanced care plan because I've got my will, it's done. Well, I'm afraid your will doesn't get read until after you're dead. So you can write all your preferences you'd like for your healthcare in your will, but we won't see it. So please let people know that nicely. People do it with best intent, but I don't think they realise that we don't have access to it and we won't see it. Fundamentally, what my role is about supporting people and educating people. When it comes to people having a better understanding of their healthcare and future healthcare and treatment options, in our jargon, that's health literacy. And in New Zealand, it's not great. So please don't assume that people do know. We write most of our documents in New Zealand to the age of 9 to 11-year-olds. So when you get information on the internet and when you get information in leaflets, it may be well over people's heads. And I'm not saying that in a condescending manner. I'm saying that the words that we use and the way that we present it and the assumed knowledge that we deliver that information with is often incorrect. So just think about that when you're thinking about what's available. People are often really afraid to ask about what's available as well. It's I don't know what it is. Possibly it's part of our New Zealand culture is that we don't like to be asking for things. Possibly it's that people don't want to be disrespectful because you've offered them something and they're asking for something else, or something different, or the alternatives. I don't know, but just be aware that we don't tend to ask. And certainly our older generation don't tend to ask either. Planning today, living for tomorrow, or living for today and planning for tomorrow. So my analogy usually when I start off is that I had a fabulous birth care plan. It's brilliant. I had birth care plans for all of my kids. wonderful. I should have published them, frankly. And then I showed my obstetrician, and he very kindly gave me a wry smile and went, and if it doesn't go to plan A, what would your plan B be, and what would you like me to do or not do? And I was exceptionally grateful to him for that, because I came in with my baby just about to be born. I said, just give me the epidural. I don't care about breathing this baby out with music and all the rest of it. And then my kids went to school and they had their immunisation plans, and we did their dental care. And then they got to about 16, 18, and it was like, you're adults now, off you go, good luck, have a sweet life, hope nothing happens. But we don't know what's going to happen. We know that in this world we pay our taxes, but other than that, and apart from death, we don't know much else. So go into advanced care planning for yourselves and with the people that you look after and serve, asking them what a good day looks like for them, asking them what they would like out of their life, and encourage them to think about that as part of their journey through life, and also as part of their journey to think about death and dying, because we don't talk about death and dying very much in our society, and more and more, sadly, people aren't aware of what ageing looks like. Maybe they don't look after our older generation to the same extent that we used to, possibly in our own homes. And a lot of people never encounter somebody who's dying until somebody's dead and they may be at the funeral. So just to be aware that, we've almost created a few taboos and discomfort around that. And a lot of people are very uncomfortable about talking about it. When we introduced advanced care planning into New Zealand, we actually did introduce it in the end-of-life space, which was completely appropriate for those conversations, but I and my colleagues really encourage you to think about it as a lifelong process. Advanced care planning in New Zealand is for adults, so 18 years old and up. Our paediatric services, both at counties and at Auckland, do have advanced care planning, but it's in a slightly different format. And I have to thank them, because it was really from their, they kicked it all off, really. It was from the work that they did that we could set up a lot of the templates and systems that we have for adult advanced care planning in New Zealand. For a lot of people it is really important, and please don't get me wrong when I talk about people's wills. It's really important for people to know how people would like to be treated after they have died. So things like who's going to receive the body, who's going to make funeral arrangements, if funeral arrangements have been made. That's quite often actually where, when we talk about families having different ideas, that's where the conflict comes up, frankly. And for a lot of our community who may have immigrated to New Zealand, just being aware of whether or not they want to be repatriated or to remain in New Zealand is really an important issue. There's also space for writing things like wills, and where the will and where the important documents are on that plan. And also right at the bottom, additional notes. There might be things that people want to write down that just really don't fit into any of the gaps in the plan. So if people want to write that, please let them do it. Probably got about 5 minutes, huh? So just going back to the fact that really please share that information. Make sure that you've asked people's permission to do that. Don't assume that just because they've come to you with a plan they want it shared with all of us. I can speak to counties. What we do at counties is either from a GP practice, you can e-refer it into me, and what I do is transcribe that into the template that we have in our system. That's e-shared care whanatahi at the moment. I don't know what that would look like in the future, but that's a system we do. Auckland used to scan it and store it in their medical records reciprocal, which is called 3M. and Waitemata also scans and stores it as a medical document as well. I think all of us generate what's called a National Medical Warning Alert that shows up on somebody's regional clinical portal patient demographic front page. So when somebody comes into the hospital, clinicians should be looking for that alert, just like they should be looking for, you know, the likes of medication alerts or alert allergy, those sort of things. But then we all have different ways about how we document it. I write a letter to the GP, so it sits on the document tray for people to see. In Counties Manukau, we also have what's called a shared care form, and that has replaced the standard CPR form. That's also current in Waitemata and Auckland. And I write in on our electronic document that somebody's got an advanced care plan. And if I know that they've got an enduring power of attorney, I put that in as well. So that's about it. Thank you all very much for your time and your attention. As I say, you know, I'm a one-man band, and that one-man band is going to get stretched a bit over the next wee while. So please, you know, have a look on the website. Give us a call if you want some information. I will certainly, in my new role, be looking at how we make advanced care planning more accessible to yourselves as health care professionals, how we get that training to you, how we can support you to support your people in doing their advanced care plans, and how we make a system that talks to each other so that we can share them well as well. All right? I think that's it. Oh, just quickly, this is the website. This is what the new website looks like, Health Quality and Safety Commission. And there's a serious illness conversation guide, which is a guide for clinicians. It's literally just a template that people can read verbatim to help guide conversations. That's what it looks like. It's available on the website. That's the shared goals of care form that I'm talking about. Some tips and tricks there. There's e-modules for e-learning. They're a really good start. I go back and I do them often just to refresh myself. These are the resources we've got, and those are the websites. More than happy for you to share the slides with people. Okay, awesome. Thank you.
Thank you. Does anyone have any last questions? Amazing.
Cool, thank you. So I will, shall I leave all the resources with you? Or you didn't need to do that. It's so gorgeous. Thank you. Thank you very much. Enjoy lunch when it comes.
Two more presents.
Two more. Oh.
If you just see the my team at the back, that would take
Yeah, perfect. Okay.
Yeah.
Thank you so much. So, hey, oh my goodness, that's incredible. Lovely. Right, so if I pop those there, I won't crush them. I hope that made sense.
Yes, it did. Thank you so much. Yes, definitely so.
I get into my own little space and it's like, oh dear Lord, I don't know what I'm doing. No. Yeah. All right.
Yeah. Right.
Have a good one. Enjoy the rest of the day.
Okay, so I wanted to present our next presenter, so Deborah Somerville. So she is one of our, oh my God, associate head of postgraduate nursing in the sports sense for Auckland University. Okay, catching my words.
That's right.
I do have a clicker.
Oh, yes. Okay. Yeah, sure.
Good morning. Kia ora koutou. Thank you very much for having me along for a discussion on postgrad education. I don't want to focus too much on the University of Auckland. There's lots of providers where you can get postgraduate education, but that can't be my focus because that's where I work. What I thought I'd start off with is just a hands up in terms of who is already embarking on or has done postgraduate education. Like a lot of you. And for those of you that haven't put up your hand, are you considering it at all? Lots of shakes. Yeah, fair enough. It's a lot of work. But what I want to do now is really sort of go through the process of where it sits. It's a little complicated. Sometimes people go to enrol and they're not sure where to start. So I want to focus a bit on that. I also want to talk about what is available in terms of education at Auckland University. And we'll spend a little bit of time on the prescribing pathway and the nurse practitioner pathway, but that is by no means everything with postgrad education, and it's had a pretty strong focus over the last few years. So I will talk about it, but there's lots of other pathways that you can follow in study that take you down a different route than that. All right, please, as I go, if you're unsure of anything, you know, just pop your hand up and we'll keep it pretty informal. Right, so in terms of where to start, well, you have to enrol, and obviously some of you are already enrolled at universities. Going on and enrolling online can be a little bit of a process, so you always want to kind of do it a little bit of time before you're ready to study, because sometimes there are complications like finding transcripts that you might have from 30 years ago from when you studied and information and that to prove residency and that, so always give it plenty of time. But in terms of where you want to start, anyone studying, you really want to begin by enrolling into a postgraduate certificate. You might think, I want to do my master's or I want to be an MP, but starting with a postgrad cert is gives you a lot more time and keeps things a lot more flexible. So don't sort of think, I've got to enrol in the whole thing, you don't. So a postgrad cert is 2 30-point courses. A 30-point course runs across one semester. So to complete a cert, you complete 2 30-point courses, and you've got 4 semesters to do that. So you don't have to do them back to back. You'd never want to do them together in one semester. We definitely don't advise. That would make you a full-time student, and for most of you, I'm sure you're working plenty of hours clinically. So generally, it's part-time study. So one course, one semester. For a postgrad cert, you've got a couple of semesters where you can go, actually, I want to have a break now, or maybe the course that you really want to do is not running at that time. So you can work it out over 4 semesters. So once you've got your postgrad cert, you've got that forever. It's recognised overseas. It's more and more being not often a requirement, but often an expectation or a desire that someone has a postgrad cert within moving jobs, within looking perhaps at more senior jobs. Some of the hospital systems are stricter than others, so some will require further postgraduate study than others. It's a bit of a moving target at the moment. But once you've done that postgraduate cert, it doesn't expire, is yours forever. If you do think, okay, I'm into this now, I'm keen, I want to keep going, you can then enrol into a postgraduate diploma. Again, it's a real step by step, so you've got up to 5 years before you enrol to a postgrad diploma. Some people just keep going, they're in that mode and they want to keep going with their study, but in fact you could stop for 4 or 5 years and then go, okay, I'm going to do another 2 30-point courses and complete my diploma. Same as the certificate, you've got those 4 semesters to do it over. When you finish that, you've got your postgrad diploma for the rest of your life as well. If you do leave it more than 5 years, and that's not that uncommon, particularly through the COVID years, you really do have to go back to the postgrad cert, so you've got to kind of be aware of that time frame. And that's pretty much relevant for all the universities that have postgraduate studies. So in Auckland, you've got the University of Auckland, but you've also got AUT, you've got Massey, Waikato University now have a small postgraduate program as they've just opened an undergrad program. You've got Victoria, Otago, Wintec, Whitireia, there's lots of providers. So it's good to look across because some providers might target a little bit more of what you particularly want when you study. And you can switch between universities at the ends of these qualification steps like postgrad certs, postgrad dip. Once you've done a postgrad dip and you're still thinking, yep, I reckon I can keep going, the next step would be to complete your master's. So that is a further 120 points. There's no time limit to start that, so some of you might have a postgrad diploma that you did back in 2010. You can still enrol into a master's with that, providing you've got the B grade average. which is a grade point average of 5, which is fairly standard across most universities in terms of going from postgrad diploma into a master's program. The master's, again, you've got 4 years to do it if you're doing what we call a taught master's. So a taught master's is either by courses, so you do 4 courses. A couple of them are compulsory because they're at a different level. So most of your postgrad education is at level 8. When you're in your master's, you have to do 60 points at level 9. So there are some courses you have to do, or alternatively you do a 60-point dissertation. Or you decide to do a research master's. And over time, we have noticed fewer people do a research master's because the word's got out that it's probably harder. Maybe it is, but not necessarily. But it is very research focused. You want to have something that you want to focus on for 2 years and work away at it. You've got to have a question that you want to answer, that you're going to do some research on. You're going to go through the ethics process. And maybe further in your career, you've kind of got that research interest. Then it's a great reason to do it. But probably for 90% of our students, they choose the taught pathway because they want to do more courses and they don't want to miss out on not doing something. But both options are good, but really individualised in terms of what you feel like you need. So in terms of where to start, the University of Auckland, I was counting them up in our handbook today. We've got 60 courses. So it's quite, when you first look at it, it's like, I don't know, what would I do? But there are some courses which are much better to start with than others. And there's some courses that are more aligned to primary health care than they are to the emergency department, for example. So I'm going to talk about a few here. There are lots of others. It's good to look at the postgrad handbook and talk to someone about what you're thinking of doing. But a good place to start is the Advanced Assessment and Clinical Reasoning course. Has anyone done that course in the room? A few of you? So it's quite practical. It's really looking at doing a more advanced assessment on your patients. So it's getting confident with the stethoscope. It's feeling an abdomen and really thinking about what is it I'm actually doing that for? What am I listening to the abdomen for? What am I percussing it for? It's doing a neurological exam, maybe on that person you think may have had a stroke, but really getting a better understanding of those cranial nerves and motor and sensory and so on. It's looking at our common diagnostic tests, so it's getting a good idea of looking at the full blood count and really being able to interpret the white blood cells and a little bit more around the hemoglobin and what could have caused this drop in the hemoglobin and understanding anemia at a greater depth. It's a little bit on looking at rhythm analysis and ECGs and urinalysis. But the main point of the paper is to take you from a patient that perhaps enters into a primary care service and maybe they have abdominal pain, and really taking you through that process of where the diagnosis comes from. And it's very much a step-by-step process, you all know it, but it really breaks it down into that really thorough history, the questions that need to be asked of any patient that comes through the doors. Then thinking about, well, what could be going on, what are the various things that could be going on for this person, bringing in some diagnostic tests to support or refute what you think is going on, and thinking about the clinical exam that goes with that. So it's a diagnostic reasoning process is kind of pulling all that together and coming out with something that gives you more confidence that actually this probably is appendicitis, this is probably something that does need to be moved along more quickly. So it's not about learning to diagnose or anything else, but it is definitely around thinking more critically about patient presentations, how to triage those people, and how to go a little bit further than maybe sometimes you would in terms of getting hands in and actually doing that physical exam. That can give you a heap of information. So that's a course that's really highly recommended early on. It's also quite a good one to start with because it runs in different parts of New Zealand, and I'm not sure, are you all Auckland based? You are all Auckland nurses? No, whereabouts are you from? Christchurch. Well, it doesn't run in Christchurch, but it runs in different places in the North Island. So it'll run down in Tamaki, Bay of Plenty, Gisborne, Northland, Waikato. So if you're after different areas. But it's also quite a nice course to start with because it only has one written assignment. And we know that a lot of people that are coming back to study, they haven't been doing any writing for a long time. One of the biggest sort of concerns is I'm going to have to write 3,000 words about something, and that's a lot of words when you're not used to doing it. So it's a good course in that respect because it has one assignment opposed to maybe three. It has a test to run those diagnostic tests, and it has a clinical exam at the end. That probably sounds horrible, but it's actually not as terrifying as it sounds. So a good course to start with. It's a face-to-face course, so you come into the university. The next course there is biological science. Anyone done that one? Harder or easier than the assessment course? Different, yeah. So this is an entirely online course. It's looking at pathophys, in-depth pathophys, but relating it to clinical diseases like diabetes and cardiovascular disease. A lot more writing, a heavier course in that sense. I generally say to people, don't start with that course, but it'll add a really nice complement along your study, so maybe in your postgrad diploma. And it does run entirely online, so if you need a little bit more flexibility, it makes it easier. Another good course is the Principles of Medication Management. I studied at AUT back in a long time ago, back in the late 80s, and I don't remember pharmacology. I don't really remember learning much about absorption and metabolism and drug interaction and half-life and that. And I think it's the same for a lot of nursing schools still. It's at a better level now, but we're still not really getting that good understanding of management of medication, and yet we're giving out a lot of medication. So that course kind of brings all that in, like, okay, that's, you know, the reason we give that long acting is because it's absorbed this way, it's fat soluble, and things start to make a lot more sense. And I think it's a good course to make us safer practitioners in terms of being the ones to dispense medication. That also now has a face-to-face option, and then it has another stream that runs online. So some people prefer online, some people prefer face-to-face, so it just kind of depends how you want to work. The one at the very bottom here, working with people with long-term conditions, really good for primary healthcare area because I'm sure many of your clients have more than one condition that they present with. That's a course that runs face-to-face. It's run by a lecturer called Mia Carroll. So some of you might remember back from Auckland Hospital. She was the director of nursing there for a number of years. She's the most passionate speaker, and she has so much to give in terms of managing patients and really practical things around the management of long-term conditions. So a really good course. Only runs in the first semester, that one. Biology of Aging, online course, really very much that, around how we age. So if you are working with a population of older people, a good course brings in some pathophys. So if you are not wanting to do the other pathophys course, this would be another one instead, and that also runs online. 701, Mental Health and Addiction for Health Professionals, is quite a new course. It is designed for people that don't work primarily with mental health. It's designed for people that work in primary health care, where you're seeing a lot of mental health coming in. It's designed for nurses that work in the emergency department, where they're seeing a lot of mental health. So don't sort of run over that one and think it's not for me. It's a really good course, and again, gives some very good practical advice on the management of people with mental health problems, as well as perhaps the physical problem they came in with. And just finally, to touch on one more course, Whānau Ōrātahi is just starting to run next year for the first time. Unfortunately, it's only running at Northland. This is replacing our pure primary healthcare course that we used to run. And it's really, at the moment, going to be targeted more from right through the lifespan, so not just at the adult. It's going to start with the baby. It's going to have a very rural focus. It's also going to have a lot on te tiriti and our obligations to managing and looking after Māori in a way that is better than what we're currently doing. So it will have that focus. It will be run on the Noho Marae up in Northland. After next year, it is likely then to come down to Auckland, and I think it's going to be a really interesting course. So there's a whole lot of nurse, what we call nurse prac courses. So these are the specialty courses. So we don't have a specialty course per se for primary health, but the ones in there that would be probably relevant would be the palliative care course, which it kind of sounds like you were touching on in the previous session. Diabetes, because I don't have to ask, but I know you'll see lots and lots of diabetes in your practice. And probably the frailty and aged care. The other ones and the pain specialty. The other ones you really have to be working, ophthalmology, you really have to be working purely with eyes. ED, you have to work in the emergency department to do it. So they're a little bit more limited, but certainly the other ones, you know, they're good practical courses again. They often require you to really think about a patient with something that fits into those specialties and either write or present or deliver that information. So there's different pathways, and if you're interested in older people's health, there's 4 older people's health courses. So you might think, that's really what I just want to learn more about. I just want to focus on the older person, what courses can I do? I don't want to be a prescriber, I don't want to be an MP, I just want to learn more. So I'd be sort of focused around those 4 courses. It doesn't have the assessment course in there, so you might think, well, I want to learn a lot more about older people, but I also want to be able to do more with older people. I want to be able to get my stethoscope out and have a listen if I'm working in a rest home and actually think, I think they might have a pneumonia. So you can switch in and out. The palliative care options, again, the very first one is a specialty course that I had on the other list, so that is just for nurses. The other 4 actually don't come under nursing, they come under population health. But they're in our handbook because we recognise them as really good courses. They come up with a different number, they come up with a pop health number, and that means that other health professionals can do those courses. So you might have GPs doing the courses, you might have occupational therapists doing the courses as well. So the main focus isn't nursing, it's the palliative care aspect of it. But you could do an entire diploma in the palliative care courses and still be within a nursing framework. There's a couple of education courses, and again, you don't have to do both. You could go, okay, I'm going to do an assessment course, I'm going to pick up that pain course because that interests me, and I'm going to do an education course because I'm doing a bit of teaching now and I want to have a formal look at that. And likewise with the leadership courses. You might not be in a leadership position, but you might think, well, kind of one day I'd actually quite like to be the manager of this, or I'd like to be in a higher leadership role. Then you might think, oh, I'll do one of the leadership courses. That went really well, actually maybe I will do the other one. Maybe that'll give you a big enough step to think I actually can move to something else. There's lots of courses around mental health. To do these courses, for the most part, you need to be working primarily in mental health, so I'll kind of brush over those. RN designated prescriber. I don't know how your funding works, but I do know that for ProCare, they get a lot of their funding through the DHBs. And they tend to fund the RN designated prescriber for primary health care nurses. And I don't know if you're having that experience or not. Is that are people RN designated prescribers in the audience? I kind of missed that last bit of what you said.
So we run a scholarship program for our university educator that's specifically
Yeah. So it's great if you can be an RN prescriber and not have to rely on a GP to fill in some of the scripts, and that may be a really big benefit to your practice. But you really want to make sure it is going to be a big benefit to your practice and to your patients, and what will it mean? Because although it's under the Nursing Council, you have prescribing rights, it's a very tight little pathway. And if you only do those 4 courses, you actually miss some of the really rich courses available. So you pick up the assessment course and the science course, then you do a very advanced pharmacotherapeutic course, which is teaching you how to prescribe. And then finally the practicum, which is getting the support from who you work with and getting an academic mentor to support you through that. So really good pathway where more and more nurses are going through it. But just think it is quite tight, and sometimes you miss some of those really valuable courses like the long-term conditions by sticking just with the pathway. It can be incorporated into the masters as well, so you don't just have to do those 4 courses. All right, nurse practitioner pathway. I do a lot of course advice. We have about 3,000 students a year coming through the University of Auckland, and I don't think I talk to all of them, but I feel like I talk to a lot. And I talk to a lot of new grads and a lot of new nurses that are not long out. And I'm like, so what are you thinking? What do you want to be an MP? Okay, so you're in your first year of practice. Where would you like to sit? No, I want to be an MP. That's where I want to be, what I have to do to be an MP. And so there is a direct pathway for an MP. But if you think about the number of nurses in New Zealand, and at the moment we've got just over 700 MPs, no one, not everyone, is going to be an MP, ever, no matter what. And in fact, probably we won't have more than 10% of our nursing workforce as MPs. So although it's a great pathway to consider, and it's a great opportunity for nursing to have it at the end in terms of that autonomy of practice, it's something only some people do. And in terms of its pathway, yes, you want to start with the assessment course, you want to fit in that science course early on, and then you need the pharmacotherapeutic course. Within your masters, you've got to do the research project. You get a free course along the way, but it's quite tight if you only follow that. So I say to new grads, like, you can finish this in 4 years, but then you've only got 4 years practical experience, and generally you really want at least 5. And you've done this really tight pathway. You haven't looked at some of the more creative papers, which are really going to give you the information and that's going to be helpful to be that nurse practitioner that does need to know a lot. So more and more are coming to the MP program. This year I think they've just gone with 120 new MPs for next year. So it's going to go up pretty quickly, which is fantastic. But you know, it's a role that you can think about, do a couple of papers, maybe try and stay on the pathway, but don't worry if you want to do a course that doesn't support the MP pathway. You can always come back and onto it again. So why do postgrad study? Some of you obviously are already doing it, and you might be questioning why you do it. It's a lot of work. It's a 30-point course equates to about 300 hours in terms of time at your desk, reading, assessment, study days, presenting, thinking about it. But I think for most people that are studying, or I should say maybe most people who have studied and have finished, it does change something. It opens up an understanding that you might not have seen without it. It's not everything. There's other really good courses in that change us. But I think in terms of really continuing to grow, it does offer that. It offers your mind to think a little bit differently, to look at the same problem through a different lens. And you're around other people that are in a similar situation of being exposed to new information and challenges, and you get to challenge back, but really thinking about how to use the literature that's out there, which is so massive now in terms of what supports our practice. I think it opens up your own learning potential. I think it suddenly makes you perhaps think a little differently than what you may have. For most people. Some people I know I've talked to, they're like, they wish they'd never started it. But, you know, they need extensions, they hate the whole thing, they've never been under so much pressure, they're stressed, and they're in a clinical job that's really busy. But I will say that I do think the general department is extremely empathetic around what happens in our lives on an everyday basis as nurses, that lots of you in this room, in fact, I think I've only seen two men, you know, lots of women working full time, bringing up families, looking after elderly parents. Lots of things happen in the life of the nurse, and then on top of that, there's some expectation, or you decided that you're going to do postgraduate study, and halfway through you just think, why did I do this? Because now I don't have, you know, my social life is gone completely. And there will be that side to it, but I think it is usually outweighed by the positives and by the benefits. But certainly, if you're thinking about going into it eyes wide open. It will be a lot of work, it will be busy, there will be time frames where you have to get things in. But you know, there's extensions, there's a lot of flexibility as long as the communication's kept up with your course directors. So in terms of where it can lead, I mean, I think, you know, a lot of positions now, Counties Manukau is probably one example of a hospital that's made a decision to not, if you apply for a management position, you have to have a master's. If you apply for a nurse education position, I think they're up to postgrad diploma. So that they're trying to give a pathway for those more senior positions to have the postgraduate support behind them. Other places are not so rigid or strict. Over time, will it completely change? I don't know. I think in the end, you do postgraduate study for many reasons, but hopefully you do it really for yourself, to learn for yourself. But overall, it does create more potential for opportunities to go into other areas of nursing if you think, I really want to change, I want to be a nurse educator now, then this is going to certainly give you a lot more potential to reach those goals. All right, I've got no idea what the time is, but are there any questions? Hi there.
Just at one stage there was thought that there might be a pathway from nurse prescriber to nurse practitioner.
Yeah, well, I mean, there is a pathway already, really, because...
Without doing a whole
yeah.
another diploma.
Well, the additional course you do as a nurse prescriber is that practicum. So you've already done that practicum, but if you did the 4 nurse prescribing courses and then you said, okay, now I want to be an MP, then you can do that within the next 4 courses to complete your masters. Because the only courses you haven't got that are compulsory is evidence-based, which is actually not compulsory, it's just highly recommended. 701, which is part of finishing the masters, the level, and then the nurse practicums.
Because I've got a master's.
Well, then you don't, you see. So with the masters already, potentially you can just do the nurse practicums, the MP training program courses, which is 60 points. Yeah.
Sorry, I don't know if you've talked about it at all. Is there any papers that we can access that are pediatric focused that
Yes.
previously were blocked off for kids and all?
Yeah, so the question is, do we have paediatric courses? I didn't put them up there, we do. Our one sort of pure paediatric course is the assessment course, but for paediatrics. So that would be the primary one. The other paediatric courses now come under the paediatric department, but they support nurses going into them. The main problem with them is the 15 points, and it's quite off-putting to do only 15 points over a whole semester. They have an algorithm where they suggest you do this 15 points and this 15 points together to make 30 points. They're mainly focused at youth, so they're adolescent courses, but they are in our handbook now. So if you do them, you can keep them within the advanced certificate in nursing. Yeah. Yes.
I know it's about close friend pathways, but there'll be questions in this room about bridging
Yeah, I don't, unfortunately. I think, I want to say Unitech was looking at the bridging, but I'm not 100%. Yeah, so the question was bridging from enrolled nurse to RN. What I do think is they're going to start making it easier again. After making it difficult and making it impossible, as the enrolled nurse starts to come back, I do think they'll start to look at that bridging again. Yeah. All right. If there's no more questions, thank you very much for your time. I'll just put that last slide, just gives the details. To be honest, I just go Google postgrad nursing handbook 224, and that will give you the digital handbook and all the information you need to enrol.
Thanks. Oh, thank you very much. We'll swap clickers. Thank you so much. Okay. There's a fire there. Yes. Oh, yeah, this one.
Perfect. So introducing our next speakers, which is Bex and Karen, who are from New Zealand Fire Department.
I think this is the clicker. Put that to this clicker. Just that one? Yeah. Okay. Where do I have to point it at? Just in the air? That should work? Yeah. Okay. Are you ready for us to go?
Yes, go for it.
Okay.
Kia ora koutou, rau ko Bex Tukuinga. This is my colleague Corinne. We are here from Fire and Emergency New Zealand, and our presentation covers zero to do with nursing. So we're here to talk to you today a little bit about fire safety, particular home fire safety. So this is information for yourselves, but also will be really pertinent if you are out in the community and going into community homes as well. We'll just get a bit better awareness about what to look out for in terms of fire safety. So a little bit about what we do, and this is in terms of Fire and Emergency New Zealand. So we are the fire service. 2017 we changed from the New Zealand Fire Service into Fire and Emergency New Zealand. But effectively to the public we're the same organisation. You ring 111 and a big red fire truck will turn up. But we basically encompassed all of the urban and rural fire services together under one organisation. So we obviously attend fires, but increasingly so we attend motor vehicle accidents, the natural, the weather events and things like that we're big in. We go to medical emergencies, so we have an MOU with St John that a fire truck will respond to any purple call, so any cardiac or respiratory arrest, you'll get a fire truck turn up at the same time as an ambulance. And that's often the fire truck, they're placed, there's more of them within the kind of outer community, so a fire truck will get there faster to start CPR than an ambulance might. So don't be surprised if a fire truck turns up if you've got a cardiac arrest. Any hazardous material incidents and animal rescues as well. Everything from, yes, cats in trees and birds in trees actually, to large animal rescues as well, with involving horses and cows and things. We do a lot of community education and community events. We kind of do the school firewise programs as well. So we've got ECE programs and Year 1 and 2 programs that are delivered by the schools, and we kind of consolidate that learning. We do a lot of public fire safety advice, things like talks to community groups and people like yourselves. Fire investigation, so Corinne and I are both qualified fire investigators, which is going in after a fire and figuring out where it started and how it started. And then our team as well is responsible for kind of building fire safety as well. So it's quite varied. I've got to get it, otherwise she'll talk the whole time and I'll just be standing here. Who's been in a real fire?
Anybody been in a house fire? No one. Big numbers in the room. Oh, yes, maybe. Yeah, would you like to share?
I was in a little ward fire once.
Sorry?
I was in a little ward fire.
Little ward fire.
Oh, yeah, okay.
Yeah.
How was that? How was that for you?
It was,
How was the experience?
I realised the fire extinguisher couldn't do such damage to the person. To be truthful.
Yeah.
Someone had set their rubbish bag alight, just like a jury, and they set the curtain alight, and then I blasted the curtain. And the curtains, flew everywhere.
Did you put the fire out?
Yes.
Well done. Well done. Oh, you down the back?
You take the pharmacy and the fire damage took about 2 minutes repair and the powder extinguisher a week.
Yeah.
But did it put the fire out?
Yeah.
How many people here know how to use a fire extinguisher? Just before we talk about them. Cool. We'll talk a little bit more about that later. Hey, thanks for sharing about your experience. So just to let you, give you a bit of an insight, so it's not like the movies. Fire gets real fast. So you know you see those movies, I don't know what the Towering Inferno and all the rest of them are, and you rip off your shirt, you run in and you're taking everyone out, you know, Superman and all that, and your heroes, and there's all this wonderful music playing. It's not like that at all. Okay, so we're going to help you understand what it is like, and there's a couple of key points here which will help you get an idea for it. So it's hot, it is very hot. So us humans, as you all know because you're all probably nurses, we can breathe up to sort of 100 to 120 degrees for a short period of time, not very long. Fires, house fires especially, can get up to temperatures in excess of 600 degrees and often up to about 1,000 degrees Celsius. So most of you probably know how to use an oven, you probably do roast veggies, whatever it might be, 180 degrees. So if you think of humans, 100 to 120 that we can breathe, it's not for very long. So if you can imagine being in a fire and you're breathing temperatures above that, and then you get out, it's still doing damage. So you're still cooking from the inside out, a bit like sunburn does. You know, you're out in the sun, you get sunburn, you get out of the sun and you end up feeling like you're still burning for hours afterwards. It's very similar to that. So once you've got that really hot temperature that you've breathed in, it's pretty hard to not do damage. So it's super hot. You just got to look at it like, you know, you want to get down and you want to get low. Have you all heard the saying, get down, get low, get out? Yeah, well this is why. I'm going to tell you exactly why. So as you know, temperatures rise. So in a fire, all the hot stuff goes up and then it starts working its way down. So the lower you are, the get down and get low, to get out the better. So you want to get as low as you can to get below the hot stuff. Dark, it's pretty dark, so fires these days, you know, with all the synthetics, let off really black, thick smoke, so that really quickly fills up a room and it makes it really dark really quickly, as well as it being loud and popping and banging and darkness, and then if it's a decent fire, your power goes out, so all the lights go out, so it can get really disorientating. It's not like the movies with all this lovely music playing with all this bright lights so you can find your way out. It's not like that at all. It gets dark real quick. So like the heat, smoke rises, hits the ceiling, starts working its way down. So the lower you can get to get under the darkness, the better you're going to have to be able to see your way out. It's super disorientated. So you've got to get down and get low to get below the heat and to get below the darkness, and you can see. Fast. How many people know how many minutes it takes for a house to be fully involved in flames and smoke? Fully on fire. How many?
Too fast.
Too fast? Who thinks 10 minutes? Who thinks 7 minutes? 5? 3? Yeah, so it's around about that 3-minute mark, 3 to certainly 5 minutes. Most of your house is on fire. If it's a normal fire, as we like to call it, then you've got 3 to 5 minutes before it's fully on fire. So not very long, so it's super fast. And a lot of that has to do with the materials we use, you know, in the furnishings. Synthetics, they burn a lot faster. Back in the olden days, it was what? Natural fibres, wood, cotton, half an hour maybe till your house is fully on fire. Nowadays, because of what we use, it's so much quicker, so it's so fast. Yeah, so you don't have time to get anything, to get out. You just have to get down and get low, below the hot, below the dark, and get out as quick as you can. Toxic, I won't talk too much about that because you probably all know about carbon monoxide, which is obviously one of the things that gets let off in the fires and the smoke. A lot of carbon monoxide, and as you probably know, that they like our body. Carbon dioxide lights our body, gets in our bloodstream, takes up all the spaces where the oxygen should be, and it's really hard to get it out. So you don't want to be breathing in that stuff. So that's another reason you want to get down and get low and get out quick because of the toxins. Yeah? Not like the movies, is it? Go to the next slide.
How do I make the video play?
Oh.
Do I just push the one?
We have a little movie for you. Just to show you it's not like the movies.
Is it playing that enough? Yeah.
Firefighters don't like fire movies. They make you think you've seen house fires, but you haven't. That's why you think you'll have time to escape. Movies are all about the big orange flames. The black smoke that kills in real house fires isn't as cinematic, but far more deadly. It means you can't see or think clearly. You find scratch marks on wardrobe doors mistaken for exits. We've heard the howls of parents whose children are trapped inside the flames. There's no sound like it. In a real house fire, you have less than 3 minutes to escape, or you die. And the difference between those two endings is this.
We'll try and get the lights for the next one. Cool, so that leads in nicely to our number one. So we're going to just cover briefly our 5 rules of fire safety. Number 1 being our working smoke alarms, and 2 making your home fire safe, being prepared, again getting out, staying out, and calling 111. So what a lot of people don't know is when you go to sleep, your nose goes to sleep as well. So you lose that sense of smell. Hence why our smoke alarms are so important, because that's what's going to give you the earliest warning of a fire occurring in your house. So we recommend that you have a smoke alarm in every bedroom, hallway and living area. From November this year, that's actually going to be in the building code for any new builds or any renovations that trigger consent, but it's always been our recommendation to have them in every bedroom, living area and hallway. Not in the kitchen and not in bathrooms, and that's just because of the smoke and steam setting them off and things. But yeah, we do recommend to have heat alarms in the kitchens. That's also coming into the building code. It's not that frequent, especially in newer homes in New Zealand, but if you have a kitchen that can be closed off with a door, then it's actually going to be part of compliance for a home to have a heat alarm in the kitchen. If that's the case, so that's quite new. At the moment, it's the very minimum you would want is 1 alarm sort of within 3 metres of the bedrooms, and that's again at night you're sort of at the greatest risk of not knowing that there is a fire. So that's why the smoke alarms by the bedrooms are so important. We recommend the 10-year long life photoelectric alarms, which is pretty much all you can get on the market these days anyway. They only came in 5 years ago, maybe. So pretty much now all the old ones are phased out and you can only buy the 10-year ones anyway, but still worth knowing. We do recommend testing your smoke alarm once a month. We have our big kind of campaign pushes around daylight savings as a good time to test your smoke alarms, but we do recommend testing them once a month. And then, yeah, also giving them a bit of a clean. So quite often dust is the cause of the sort of false alarms, dust and bugs and things like that. So you can just give them a bit of a clean with a vacuum, and that helps prevent some of those false alarms. For any rental properties, it's the landlord's responsibility to install the smoke alarms, but it's the tenant's responsibility to maintain those smoke alarms. So that's just something good to know as well.
Just while we're on that topic, how many of you here have smoke alarms in your homes? Anybody not put their hands up? Sorry.
It kept alarming, so I had to take it down, but I'm back to it.
So we can give you some information on that as well. So obviously we can get a fire truck round to give you a hand if you have any issues with your smoke alarms. So really important. So if you've got them, how many of you have tested them lately in the last month? Yeah.
Photo of everyone that's got them.
How many of you are going to go home today and test your smoke alarms? Well done. Okay, rule number 2. Make your home fire safe. First thing you're going to do is test those smoke alarms. So obviously there's a big thing with cooking, yeah? So a lot of us get very distracted very easily. It might be that we've just got a lot going on in our head, lots of tabs open, lots of things to do, busy parents, all that sort of stuff, you just get sidetracked. So we want you to try, if you can, to keep looking while you're cooking. If you do have to wander off, say you've got young kids, like Bex here, and you get distracted, you've got to wander off, just turn the stove off or something like that off, just so that you don't risk forgetting about it. So yeah, keep looking when you're cooking. A big thing too, question for you. We're cooking our eggs, like frying our eggs on the stovetop, and it catches fire because we've forgotten about it. Are we going to throw water, or are we going to try and put it out some other way? Who put your hand up for water? We're going to throw water on the fire? Oh. Or are we going to put like a lid on it to put it out? Who's not sure? You'll see a video shortly. So yes, the answer is we're going to try and put a little lid on it. So we don't want to put water on oil or fat fires because they don't like each other, and so there'll be this massive argument and there'll be this big ball of fire that goes with it. So we don't want to do that, we want to be putting a lid on it, and that could be a chopping board, it could be just even a damp tea towel, not dripping wet tea towel because we don't want obviously the water, or it could even just be the lid from the pot. So we want to try and starve it of oxygen, and that's how you're going to put out a fat or an oil fire. Okay? We're not going to chuck water on it, which is what obviously naturally that's what we want to do, but we don't want to do that at all. If you get a fire extinguisher, you might end up blowing it everywhere. You just got to be careful. Don't drink and fry. Obviously that's similar to the distraction type of thing, yeah. So we just want to make sure we're onto it while we're cooking, and if we can't be onto it while we're cooking, then we don't want to be doing that, or we want to be turning it off or using a different means of cooking, like air fryers, for instance. Heater meter rule, heaters, fires, anything like that. If you've got something hot that's designed to warm the home, heat pumps either as well, you want to try and keep everything at least a metre away from it, yeah? So I know the old school sort of oil heaters, you used to throw your towel on it to dry or your clothes. Just sort of be a bit careful about that. You just want to try and keep things a metre away just so that they don't catch fire really easily. Electric blankets, hopefully you've pulled all those off your bed now, we're getting a bit warmer, so we want those tested if we can. Lots of us, who has electric blankets? Anybody got them? Yeah? Yeah, cool. How old is your electric blanket? 5 years old? Yeah? Before I was in this job, mine would have been, I don't know, about 10 years old, and then I got a bit more in the know and it went in the bin. So if they're over about 5 years old, roughly, I think it's about 5, you probably want to look at getting a new one. You get some good sales these days and pick them up pretty cheap, or you at least want to try and get them tested every sort of year or every couple of years by an electrician. Okay, don't just expect it to be all good, especially if when you take it off your bed, or you might not take it off your bed, but if you do, you don't want to fold it because they've got little wires inside it, and if you're folding wires, they break. And then there's your weak point, and that's your point that you might start a fire. So you want to try and just roll it gently. If you're going to store it, roll it gently so the coil will stay rolled rather than folded, and pop it in your cupboard that way. And when you get it out for winter, turn it on before you cover it up, before your bed sheets. Just have a look, make sure it looks fine, and then you're good to go. Don't jump in it like I used to do and fall asleep with it still on full ball, and then wake up half an hour later because you're sweating. So make sure you turn it off before you hop in bed, yeah? Just a bit of safety there. Multi-boards, we've probably all got them. And how many of you go, oh, we need a few more, so we plug a multi-board into the multi-board, into the double adapter, into the extension cord, which goes into the wall. We all do that, right? Just try and remember, if you've got a multi-board that's got 4 holes in it, that means 4 appliances. Yeah? If you need more than 4 holes, just go and buy a multi-board that maybe has 6 holes or 10 holes. Every hole is designed for one thing. So as soon as you plug in a double adapter, you've made that one hole 2. Or if you plug in another 4 multi-board into that one hole, you've then made that one hole 5. So just bear that in mind. One hole, one appliance, yeah? So not only do we want you to go home today and test your smoke alarm, just have a quick look at your multi-boards. We've all got them behind our TVs, Sky Decoder, all that sort of stuff. Just have a quick look and just Do I need to get another multi-board, perhaps? Most likely, yeah. They're designed to, if they overload, they're designed to just pop their little button on the side. So if it keeps popping and you keep having to reset it, that's trying to tell you something. It's trying to say, hey, hello, go and buy a bigger one. So if you keep popping that little fuse on the multi-board, just
sellotape it down.
Yeah.
People do. Keep popping.
Yeah, that's the little thing going, hey, it's like the smoke alarm going off. It's going, excuse me, wake up. Yeah, so it's there for a reason. Keep an eye on that one. Charging, yeah, that's a good point. So iPhones, scooters, laptops, we all charge them. Probably, how many people leave them on charge overnight? Yeah, a few, eh? How many charge them and then turn them off before you go to bed? Yeah, so it's a bit of a mix, eh? So 99% of the time, the devices are designed to just shut themselves off when they're fully charged. It's only when there's something wrong with them, potentially from dropping it loads of times or breaking a little wiring or something like that, that it's a little bit upset, and that's when it might have a little bit of a hissy and catch fire. So we want to look after our items, and if we can, especially the the e-bikes and even your cars and that, if you can just charge them while you're awake and while you're there, it's better, because if anything goes wrong, you're going to be there to see that happen and to be able to deal with it quickly. So yeah, just charging, make sure the cords are nice, they're not frayed or they're not bent and crooked and all that sort of stuff. Just make sure they look in good condition, charging into your phone and all those things. Just make sure it's all right. If you notice there's something wrong, that's your little indicator again. So you might want a new charger, or you might just want to change the way you're charging it. Don't do what a lot of kids do and pop it under your pillow at night. So you put your phone on charge and then you slide it under your pillow at night. Probably wouldn't do that. You want to try and charge things on hard surfaces, not on soft furnishings, yeah, because it blocks that little bit of ventilation, starts to heat the device up, catches fire. So just a bit of housekeeping around charging devices, yeah. Make sense? Yep, trying to rush on it, yeah, all day. Nighttime check. We do. My kids are in a good habit. I've got a little bit older kids than Vex. Mine are 10 and 7, and my daughter runs around the house and shuts all the doors before we go out, and she does things like, is everything turned off? And yes, everything's turned off. Yeah, have you turned that? Yes, I've turned that off. So she's a bit more paranoid than I am. But do a bit of a nighttime check. You just want to make sure things like the oven's not on, stuff like that. Sure, don't expect you to turn your Wi-Fi off and things like that, but stuff you don't need on, just flick it off. We turn our oven off at the wall, just a habit. We don't need it on, we turn it off. So just do a bit of a nighttime check. Make sure your electric blankets are off. Make sure your heaters are off. Things like that, yeah. Leave the essentials on. Anything like my husband, and I'll turn the Wi-Fi off. Wouldn't want to do that. So, yeah, I won't waffle too much longer. Oh yeah, this is why you don't throw.
No, this is not the right. No.
Oh, it's not.
No.
Oh, no, it's not.
Kia ora. It's our job at Fire and Emergency New Zealand to keep our communities safe. And we would like to help you and your family stay safe from fire. The most common cause of house fires in our communities is kitchen fires due to unattended cooking. A kitchen fire can spread to become a deadly house fire in just 3 minutes. Don't leave pots and pans unattended while you're cooking. If you have to leave the kitchen, remember, turn off before you walk off. And very important, if you've had a few drinks, don't start cooking. Alcohol and cooking is not a good mix. And remember, when you have finished cooking, make sure the stove and the oven are both turned off. Thanks everyone. Stay safe. Mate wa.
So the reason why we push our kitchen fire safety a lot is it's, for as long as I can remember, it has been our leading cause of house fires. Yeah, that's why we're pushing that. This is our kitchen fire demonstrator. Some of you might have seen it at events we go to, but this is why we don't want to put water on a oil fire.
Oh, can you push play? Can you push play? I can't push play. Just tried, like click on it.
that's only really about a cup of oil, probably not even that, in the pot, and about half a cup of water. So it really doesn't take much to have that, and you can imagine if that's in your kitchen, especially in the older homes that have net curtains and things like that in the kitchen too. So the way to put out one of those fires is smothering it, like Lynn said, either with chopping board, pot lid, oven tray, anything, basically putting it on and leaving it on.
Did you hear how loud that was? That was just loud. It's quite loud.
Cool, so our rule number 3 is all about being prepared. And that is, who's got an escape plan at home? Has anyone talked about with their whānau, with their kids, how you're going to get out? A couple? Yep. So that's another thing we want you to do when you get home after you've tested your smoke alarms and you've checked all your multi-boards and things like that. Sit down with your family and have a think about how you're going to get out. We use what we call a 3-step plan. So that's having a primary escape route, so the preferred option to get out. A secondary option, so if you can't get out the first one for whatever reason, what's going to be your second way of getting out? And the third point is, where is your safe meeting place going to be? That's really important if you have got young kids, and it's really important to drill that into them so that if they wake up before anyone else, they know how they're going to get out and they know where they're going to go and wait for mum and dad. Numerous fatal house fires are because someone has gone back into the house. So they've gotten out of the house and they've gone back into the house to get a person, to get a thing, to get something. Often the person might have got out the back door. So if you have a designated safe meeting place, that takes away the risk of feeling like you have to go back into the house. So Escape My House is a website that you can do. It is quite cool with kids because you can do it online together and with your house and come up with a little plan. So that's quite cool, escapemyhouse.nz. Who's got deadlocks at home with a key? Yep. Do you leave the key in it? Yep. So really important if you've got one of the older deadlocks that actually has the key, not just the little knob, to leave that key in there. The last thing you want to do if there is a fire and it's dark and it's hot, like we've already talked about, is having to fumble around in a drawer or something to find a key, because every second counts. So if you have got the deadlocks, just ensure the key is in there. If you're worried about security, have it on a hook that's literally sort of right there next to the door, so you're not having to fumble around in a drawer for it. We do, every fire station across the country will do home fire safety visits, and that's completely free for anyone. So all that's needed for that is to ring your local fire station, and they'll arrange a time that's suitable for you all, and they'll come around, they'll test your smoke alarms. If you've brought some more and you want to put up more, they'll put them up for you, they'll talk through the escape plan, they'll have a look at anything you want. So just be aware, and again, in your work, if you are coming across families, that's a good one to remember. It's completely free, doesn't matter who you are or where you are. If you own, rent, doesn't matter. It's just available to anyone. Like we've already talked about too, we're testing our smoke alarms regular. Fire extinguishers, who's got fire extinguisher at home? Quite a few. Do you know how to use it? No? Cool. So then you might. If you have a fire extinguisher at home, make sure you know how to use it. Fairly easy, just to look it up on YouTube. It does have little instructional pictures on the extinguisher itself. Another thing to note, if you have extinguishers, they do expire, so check that it's actually in date. If it's a pressurised one, make sure it's got pressure, otherwise you might as well just throw a rock at the fire. So if you've got one, just make sure you know how to use it and you're confident in using it, and that it's not expired and things. As a general rule, we recommend if the fire is any bigger than about a rugby ball, then don't bother, it's not worth it. You don't know necessarily if it's the right extinguisher, or you don't know if the extinguisher is going to be able to actually put the fire out. So if it's any bigger by about the rugby ball sort of weight paper, don't bother, just get everyone else out and call 111. Fire blankets are quite good as well for in the kitchen, especially if you do use oil for cooking and enjoy a lot of frying and things, they're just another helpful to have as well, and that's doing the same as what a lid or anything is doing, and that's smothering the fire.
Get out, stay out. That's what it all comes down to. So obviously, like Beck said, if there's a fire that's a little bit too big for you to be trying to extinguish, you just want to get out. Don't go back in. We have cases all the time where people go back in and they don't make it out, or they do make it out but not very good state. So that's the key, don't go back in. Get down, get low. We talked about that, why we do that earlier, yeah? So that's your key, get down, get low to get out. And then obviously we don't want to go back in at all. If you're stuck in there for any reason, then you want to make sure that you can do the best to alert the emergency services that where you are. So essentially, if you're stuck in a room, you can't get out, you want to shut your door, you want to try and stuff a blanket or a towel or clothing, at the bottom of the door to try and stop any cracks where any smoke could sort of get in, where any heat could get in. You want to open the window. If you can't get out the window, you want to make as much noise as you can. You want to get on the phone if you've got your phone on you and just let emergency services know that you're stuck in the house, because our priority as fire service, fire emergency New Zealand, when we get there, it's life first. So if we know there's someone stuck in the house, we're going to do what we can. Even looking after ourselves, we're going to do whatever we can to get you out first before we worry about your house that's on fire. So if you're ever stuck, you're ever trapped, do what you can to let everyone know where you are, and that's make as much noise as you can on the phone, and hopefully we'll be able to get you out of there. Only attempt to fight the fire, like Beck said, if it's small. If in doubt, just get out. Get down, get low, get out. Rule 5. Keep going. Coming over time. Call 111. Yeah, so that's obviously in New Zealand we use 111. So that's the key. So call 111, ask for fire. 111. Ask for fire, not ambulance, not police. You just want to ask for fire if it's a house that's on fire or any sort of fire. Ask for fire. Tell them where you are. Know where you are. Know the address that you're at. If you're visiting homes, you want to try and know where you are, so that if you're ever in that situation where you phone 111, you're able to tell them where you are. They can zoom you in, track you down on your cell phones, but it's a lot quicker if you can just state your address. There's a text service for those that are hard of hearing or deaf, so there is that option available, so you can go online and you can register for that, but you have to have been registered for that to be able to use that. Otherwise, yeah, know your letterbox number, know where you are, get out, stay out, and don't go back in.
Yeah, I think the letterbox number is a big one too. The bigger and easier readable that is, the faster the fire truck's going, or ambulance, any emergency service is to kind of identify your house. So it is quite important to make that quite visible, and this is quite pertinent at the moment to our most recent fatal house fire just on the weekend. The deceased, the victim, did everything but ring 111, so to try and alert somebody that there was a fire. So she came out of her house, she went back into her house, pushed her medic alarm, rung her nurse, didn't ring 111. So it is actually, a lot of people and a lot of the older generation are scared to ring 111. So and kids as well. So it's another quite cool thing to role play with children, is ringing 111 and making it less scary. And if they know what questions they're going to be asked, it's less scary. But just never be, even yourselves, just never be afraid to ring 111. Yeah, I think we just end on the video.
Wow. 5 minutes over.
That's right. Probably 5 minutes over.
One of the most important things you can have in your home is a smoke alarm. Smoke alarms save lives by giving you early warning that a fire is occurring. You need your smoke alarms in every bedroom, hallway, living area. Have them throughout the house so that a fire that occurs somewhere other than where you are, you know about it early. Have a home escape plan. That's a plan to get everyone out and meet at a safe location. With plug boards, multi-boxes, whatever you want to call them, it's really important only one plug in each of the sockets. That way you won't overload it. A lot of fires occur in the kitchen. Keep looking. Don't drink and drive. You can be distracted by kids, you can be distracted by the phone. If you have to leave it, turn it off. If you're using candles, make sure that they're out before you leave the room. Never leave them burning unattended. Matches and lighters are tools, not toys, and we need to keep them out of the way of young and quiet minds. Any type of heater that you choose to use, keep it 1 metre away from anything that can burn. Get the chimney swept prior to using it each season. The ashes that you clean out from the fireplace can remain hot for up to 5 days. We recommend you put them in a metal bucket and store it outside away from the house. Make sure you have your electric blanket tested each year, and if it's over 5 years old, we recommend replacing it. As always, our call takers are ready to take emergency response calls through the 111 system. Thanks for watching.
Cool, so just to recap again, number one rule is to have those working smoke alarms. They are what is going to save your life. You're 4 times more likely to survive a house fire if you have a working smoke alarm. Go back home, have a look around the house, make it a little bit more fire safe if you can. Being prepared, have a think about how you're going to get out. It's sort of ingrained in us. I don't know about you guys, but do you know how to get out of this room if the alarm was to go off now? Yeah, cool. That's something we just do naturally. Anywhere we go, it's just so it's good to be a little bit prepared. Getting out and staying out is really, really important. Again, numerous fatal house fires have happened because someone has gone back inside, and calling 111 to get those emergency services on the way as fast as possible. Any questions? Yep. We have fire doors in some of our clinics. How do we utilise them properly?
Ensuring they're always closed, unless often in hospitals and things they'll be on a hold open device which is linked into your fire alarm. So if the fire alarm was to go off, they would automatically release and close. So those are okay to leave those doors open. It's not okay to ever leave a fire or smoke door wedged open. That, depending on the building, might break the fire cell. The building might be built up into fire cells, which means the fire won't spread from one area to another, or the smoke travel is going to get through the building, and the fire development would happen a lot faster. So really important not to wedge or hold open fire or smoke doors that aren't purposely designed to stay open. Any more questions? Can do about anything? No? Cool. Yep. Like in a hospital setting type thing? Yeah, they've usually got pretty well designed evacuation plans, and that would be almost triaging who has to get out of the building, and they, if it's a newer building, will have fire cells, which means some parts of the building can stay in there while the fire alarm is going off. And it might be a staged evacuation, so if the fire wasn't brought under control for whatever reason, you know, this room would be evacuated, and then if it was still growing, then they'd evacuate the next, and if it was still growing, they'd evacuate, yeah, so it's sort of a stage. Particularly in dementia units, they, you know, for obvious reasons, they can't just open the doors and let everyone go, so they will often have dedicated fire cells where they're can remain safe but away from the fire. Yeah. So if you were in that situation though, and you had to evacuate, you're gonna just have to carry on doing your resus on the way out the door. Yeah, because if you're not gonna die from that, you're gonna die from the fire. So yeah. Yeah. Cool.
Thank you. Thanks, everyone.
No, we're good.
Oh, thank you.
That's lovely. You didn't have to.
That's okay. Thank you so much. Thank you. Enjoy the rest of your day. Perfect. We'll break for lunch for half an hour. Can I please just get everyone that's got any special dietary requirements to go first so they can make sure they get their meal? And there should be everything labelled, and we'll meet again at 2:40. Recommence, introducing Rodney, and we've got Mandy and Lisa from our PNC team, and they're going to present to us about the engagement survey that we have completed and what the results were for the nursing team.
Thanks, Natasha. Hi, everybody. I'm Rodney. I'm part of the PNC team. I'm looking after the organisational development part of the PNC team. We've got Lisa over there, who's our Chief People Officer. And we've got Mandy, who's one of our PNC business partners. And we've got Pam, who is here. She's presenting after me on risk and well-being. So thank you very, very much for having us here today. I think it's a great opportunity for us to come and talk to you about the employee engagement survey that you mostly completed in August of this year. I'm keen to just take you through a little bit of the mechanics of the survey itself and then move straight into the results. And we've really been very fortunate this year because we've had such a great response rate that we've been able to sort of slice and dice the results across the business. So we're able to get a good view from our nursing team as an exclusive group in terms of what you're telling us, and that's what I'm going to be sharing with you today. I'm going to keep that talking from my side to a minimum, although I enjoy talking, so that'll be a challenge, but I'm going to break us up into groups because the important thing is that obviously we give you the opportunity to have a look at the information, dissect it, and answer 4 or 5 questions that I can then consolidate and take back to have some further discussion about. So in terms of timings, the presentation will take about 15 minutes. We'll do about 20 minutes of breakout group and then about 20 minutes of feedback and then just do a quick wrap up at the end. So in terms of the survey, as I said, most of you will remember we kicked it off in August of this year. We had 754 respondents across the organisation, which was a 74% response rate, which was a really, really brilliant response rate. Previous years we've done this, we've had sort of within the 30% response rates, so we doubled that, which was really great. So thank you very much to everybody here that took the time out to complete the survey. The good thing of having such a high response rate is that the information we're getting is really good data. It's really taking us straight to what's important for our people. And it's ensuring it's keeping us focused on the things that we need to be giving attention to in order to assist our people in the workplace and to raise the engagement of our teams. 36 clinics of the just over 50 achieved over an 80% response rate. So again, that was brilliant. We were overwhelmed with those responses coming through. So and we had quite a few reaching over 90%. So that was a great to see. And then if you'll remember, we asked 7 Tamaki Health particular questions about the organisation. We had 4,300 comments that came in to those 7 questions. So that was really brilliant. The team at Gallup really consolidated all of that. It was obviously put through a few different ways of looking at it, but themed that all up, so I'm able to share some of that information with you here today too. Just as an indication, how many of you attended the town hall? Okay, so a lot of this information will be, it would help if I had the clicker, right? Will be new, and that's all good. Some of this was covered off in the town hall, but the specific nursing information will be new information today. Let me go back to the manual way of doing this. Yep. Not working in here either. Okay. Let's try this one again. So this is just pretty much what we're going to cover off today. So a recap of the engagement principles. We're going to go through the actual results. We will then look at the themes that came out of the verbatim questions, and we'll then go into an activity in terms of getting some further feedback and information from you. So this was this came through, this comment came through on one of the verbatims that was asked from one of our people here at Tamaki, and Gallup kind of presented this to us when they brought the results firstly through to the ELT, and it's really captured it really, really neatly here. So it can compete on price and product, but it's people that makes the point of difference, and that is so true. That's come through overwhelmingly throughout all of the responses that we've had, is that actually the strength of our organisation is our people, the opportunities of our organisation is our people. We look after our people, they look after our patients. So it's really been a consistent theme coming through, which has been really great to see. So this is just a little bit about why we look at engagement. And essentially, it all comes down to the more engaged people are, the better service delivery they're going to, in our world, deliver to our patients. So you see lower absenteeism rates, better well-being in terms of our own people, and Pam's going to be talking to that a little bit later. Lower turnover. In some of our work groups, we have some fairly high turnover. So that obviously indicates that there's some challenges there with engagement. Better customer metrics and higher productivity. When we look at when you see the results, we really categorize people into 3 categories, and it's from engaged employee to actively disengaged. So when we're getting good response rates, we're able to then say what percentage of our population is engaged and what percentage is not, and what percentage is actively disengaged. The interesting thing here is when you look at your actively disengaged group, that's really your group that Gallup explains this really well. If you're in a boat, the actively disengaged people are the ones rowing in the other direction. So if you look about trying to move your organisation forward and deliver, your actively disengaged group are the team that are perhaps not helping as well as they could be. In terms of focus areas, we'll be focusing a lot of our time on our not engaged employees and trying to work on areas that have been raised through the survey to move them to the engaged area. For those of you who completed the survey, you would know there were 12 questions. This is pretty much how they are categorized. So this works pretty much like on a hierarchy of needs. We've got our basic questions, our basic needs at the bottom, which is sort of your bread and butter things. So do you clear on what your role is, what's expected of you, do you have the tools to do your job? And then as you move up through the various levels, you get to the top one, which is growth, progression, having conversations around career trajectory, growth, and what have you. So the view is that if you address your areas at the basic needs first, you build up from there. These are just some points that you'll see in the slide when you get the results, the engagement mean, and we'll come back to this. That's really just the average of the 12 questions that were answered. The engagement index, I think that measures your engaged employees compared with disengaged. If you remember, I showed you the slide of engaged, actively engaged, not engaged, and disengaged. And then we talk about mean percentile rank. So that just gives us some comparisons, because a lot of this information is not very helpful without context or without being able to do comparisons. So we will regularly compare with other organizations within the Gallup survey group to see how Tamaki or how the group within Tamaki rates. We'll go straight to the results. So this is how it comes up, and I'll go through each one of these things. I think the important thing here is the metrics are important, but we must be careful not to get too hooked on them, because it's actually more about focusing our attention so that we are working on the right thing. So it's actually more in the action planning that we want to be spending our energy. This just helps focus where we should be spending our time. So if we start here, we had 105 respondents. So this is for the nursing team as a group. So that's really a good response rate. It's just over 65%. So we really did get a good number of responses from our nursing team members. You look at the engagement mean there. So for the nursing team, the engagement mean came out at 3.71. Now that's a score out of 5. If you compare that to the company's engagement mean, it's slightly lower. The Tamaki Health engagement mean was about 3.84. So what we're kind of seeing there is that our nursing team are probably not as engaged as the rest of the organisation. And as we go through some of those questions, we'll be able to dig a bit deeper into that. The mean percentile rank, this now says, well, where do we rate as a nursing team in comparison to other organisations that do the Gallup survey within New Zealand, Australia, and Oceania? And it's sitting at the 27th percentile, which is, again, is quite low. We would like to be seeing our organisation and our teams being sort of at least the 50th percentile, moving up more close to the 75th percentile. So again, that shows that we have work to do there. This is probably more interesting, is that engagement index. And this shows us our engaged, not engaged, and actively disengaged. Now in our nursing group, we've got 14% of our nursing team have rated as actively disengaged. Now, compared with the Tamaki Health as a whole, that was 11%, so it's slightly higher in that group. Not engaged is 58% and engaged 28%. So that not engaged of 58 is really the group that we want to try and address in terms of the issues that have been raised to move them into the engaged group. Because that's over 0.5% of their population are not engaged, which is not, as you can imagine, a good result. There were 12 questions asked. The question 0, which is actually gives you 13, talks about the overall how satisfied you are with Tamaki Health as an employer, or as a place to work, and we rated 3.35 as a nursing team here, which again, compared with the company overall, is 3.56, so it's lower there. So certainly it looks, we have work to do with our nursing teams in terms of addressing some of the areas that have been raised to try and move some of those, but ultimately to get better engagement from our nursing teams. We then just go and look at the two lowest scorers, and see a lot of similar trends here. In the last 7 days, I've had recognition or praise for work done. We've rated fairly low there. I can see a few people nodding to that. That's consistent with what we've heard at Tamaki. If we look across the Tamaki Health organisation as a whole, we've rated lowest in that space in terms of recognition of our people. So it's an absolute area. If we start looking at what we're going to do in action planning as an organisation, that's something that we'll definitely be focusing on. The second one is that we've rated fairly low here is in the last 6 months, someone at work has talked talk to me about my progress. So this is the whole piece of what is the career trajectory here at Tamaki, what is our development opportunities, are those conversations happening? If they are, how are they happening? How can we do that a bit better? Where we scored really well, question 1, I know what's expected of me at work. So that's a foundational question. And we've rated higher than the norm there, which is 4.43 against 4.4. Again, consistent to what we saw with Tamaki as a whole, is that generally our populations at Tamaki are clear on what's expected of them. And again, we're working with professional groups of people, so we would expect to see that. But it has rated high, which is good to see. This is now taking the verbatim comments, as I said, that 4,300, and summarizing the 8 areas that came up from there. And Christine and I were just having a conversation before we started this about technology, so you'll see it's number 1 up there. Outdated technology. So recurrent challenge, it came up time and time again, is the technology is not working for us. It's cumbersome, it's problematic, particularly we're hearing that back from clinics. Our people are telling us they're eager for more training, more development opportunities, for growth and for recognition. People feel Tamaki's managers need to show more care, so there's a leadership element coming through here that's being raised, how they feel cared for by their colleagues, which is really enthusing to see. So we've got good culture in terms of people looking after each other and supporting each other, but at a leadership level, we need to be doing a little bit more in that space. When asked about our biggest strength, as I said earlier, overwhelmingly it was the people. That just came through time and time and time again. So it's, as I said, it's a strength and an opportunity to continue building on that. People recognize the need for retaining staff and seeing a correlation between turnover and negative customer experience, which certainly, if you look in some of our areas, medical receptionists as an example, new people to the organisation, big job to learn. Obviously that is going to impact on customer experience as people are turning over and learning the job and leaving. So that made sense. Recurrent themes, more staff, better pay structures, specifically for senior members. Now, we've been able to address some of that with our latest round of negotiations, and we continue to work on the recruitment to try and improve or increase the number of people that we bring through the organisation. I'm very happy to say that, I hope everybody's be able to hear me all this time, that as we stand this month, when we reported our vacancies, we had about 46 vacancies, and that was against about 94 last year. So we're starting to make good progress in the recruitment space, and we're able to start filling some of those areas which have been problematic for us in the past. But there is still more work to do in that space. People have an incredible passion for the job and the industry. Again, that came through overwhelmingly through the results. And really, if these are the 4 areas for us to focus on: materials, recognition, care, and development. And if we as an organisation focus on those, we'll be able to address the majority of the things that came up through the survey. I want to stop talking now and move on to an activity. And the purpose of this is really just to do a little bit of a deeper dive into some of the engagement principles. What I'd like to do with this too is the team over here will help facilitate each group and capture that information right at the end. And we're going to be running a session with the executive leadership team. We've run a few of these sessions, so it'll be great to be able to take feedback directly from the nursing team in terms of what we're hearing to further corroborate what's come through in the survey. So there's 5 or 6 questions there. I would want you to break into 4 groups, and we can just talk about how we split that up. And if you could just work through each one of those questions as a team. And we'll have about 20 minutes for that. And then we will take feedback from each one of the teams, and we'll consolidate the information we get back. And we can do a wrap-up at the end of that.
I'm going to split everyone into groups of 4. Can you hear me? So 1, 2, 3, 4. So we're going to have our team in different corners of the room. Joanne is number 4 over there. Reshmi, number 1 here. Navdeep, you can be there, number 3. And Mandy, if you want to come here, number 2. So 1, 2, 2, 3, 4. 1, 2, 3, 4, 1. 1, 2, 3, 4, 1. 1, 2, 3. Did you hear a number? Yes. 4. 1, 2, 3, 4, 1. 1, I'll leave you where you are. 2, 3. Okay. Yes. And 1, 2, 3, 4. 1, 2. Forgotten which tables I've gone to. 1, 2, 3, 4. 1, 2, 3. So 1, 2, 3, 4. 1, 2. Cool. So number 1's over here, number 2's over there. Nev, can you go that way? Number 3's there and number 4's there, please.
So which one is 3?
3 is over there with Nagdeep.
Are we just giving them one each? Or, and others then?
I will just.
Okay, great. Okay. Guys, come have a seat and then you can all huddle together and have a seat. Get a seat.
That's right.
Kirsty, have you got a seat? We're gonna Okay, so you all done the engagement, right? And so based on what Rodney has said, there's a couple of questions that we have to work through.
Actually do the survey here? Yes.
You all did the survey, right?
Yeah, well, that's a good start.
So, one of the first questions, let's start and just talk about it because generally you are driving this and you need to give us some feedback and your thoughts and being quite honest and transparent and so that we can have all this feedback collected and give it to Rodney. So the first question is, could you please give us a general description of morale now over the last 12 months? So if we could just think about it and talk about it.
Before I start, is anyone else here White Cross? Okay, you are. So you're affected by clinic closures as well? What are you feeling about that?
So hold on, Christine, we're just going to go according to the questions, okay?
Right, yeah.
So can you just...
I'm just trying to see how many White Cross, because we'll have different problems. Yeah.
Okay, but we're going to focus on the questions that we have, okay? Right. So we're talking about morale now, and over the last 12 months, could you guys just give us a quick description? What's your thoughts about your morale within the clinic?
Well, that's what the question is. It's because of White Cross and the last 12 months, lots of clinic closures has affected morale dramatically.
Okay, is that your point of view? Okay.
That's the point about that.
Okay, great.
It's having to shift clinics, short notice, closures.
great. Thanks.
Yeah.
I'll just put
I'll
this.
just follow you around the corner.
Yeah, it's perfect. That is good. I just need. I'm going to need Natasha to.
It's just Tamaki one.
I'm going to leave that with.
It's just Tamaki one.
Oh yes.
I'm sure you do. That's why
Legacy manager, she's just amazing.
Yeah, well, so is that. Just so is that. So I said, think it's feels
Really good leaders.
Yeah.
It's yours. I'm just sitting here for decoration.
Where were that great leaders?
And what makes them a great leader? Yeah, it'd be keen. Because if we could distill that, then we would. Yeah. Okay.
Did you say having show? Oh, yeah.
Oh, as you see, so.
Admin support as well, because Michelle's talking about a really, really good product coordinator.
Is she a practice manager? I thought she was a practice manager.
Jill. What's her official title?
So yeah, and this has come up. I think.
Coordinator.
Yeah. There's a bit of a confusion of whose role's what sometimes, which is a challenge in our organisation.
I mean, Kate's got a fantastic clinical coordinator person with a slightly different title.
How's it going?
What are we doing for time? I wasn't timing you.
No,
I was trusting.
and I didn't keep track of the time either. We'd probably it's another 10 minutes maybe.
No, 10 minutes. Okay.
Do you want me to tell them?
I'll
Is 10 minutes
count
okay?
down at 5 minutes.
Okay. How's it going here?
Yeah, how much more can I do?
Probably another 10 minutes.
10 minutes.
Yeah.
Just like, you know, our research, she organize everything for us. We don't have to worry anything. Everything's inside. She keeps an eye on the front.
Oh, well, maybe we can leave that for the last part.
We can
What
another,
do we see?
10 more minutes, yeah?
10 more minutes?
Yeah.
Okay, on the other hand.
10 more minutes. Yeah?
All right, 10 more
Thanks.
minutes.
10 more minutes, right?
10?
Yeah. Cool. Natasha, I've just gone round and told them 10.
So at least when they come in, we know their names.
We don't even
We have a few times we don't have anything like
new people. There's just
Sorry.
I'm sure.
Are we on floor?
so action plan.
I love this.
What does it say? Morning huddle? Yeah, I just say hand, some sort of handover and, you know, connection with each other actually.
Do you get lunch together? No. What's number of choose a couple of words
All right, what about number 5?
I'll go proaction.
Get any student
Number 5?
Oh, right.
Start a conversation.
Go Bruce or
Work in progress. Yeah.
I'd want to put listening in there as well, some more listening.
Yeah, that's a good thing. And what did Lloyd say this morning? He's optimistic. So I think we're optimistic too, aren't we? Well, I'll speak for media, but
I can feel the vibes.
yeah.
Nice, good feedback. Put it in the paper.
Yeah, the last one.
Did you capture that about the acknowledgement piece? Acknowledgement for skill acquisition.
Skill acquisitions, it's crucial to patient care and management. It's who has the most contact? Nurses?
How do you spell acquisition?
Oh, I don't know.
A-C-Q-U.
A-C-Q-U-I-S. Quiz.
What else? We've got about 7 minutes to go and we've got 2 more questions to do.
Oh, security.
Security?
Yeah.
Yep.
At night time.
Yeah.
Nurses working one-on-one with doctors.
Yep.
And also when they're going into the car, like my hospital has the parking downstairs.
we're 24 hours a day, so we're closed when we don't.
If your team was as engaged, next question. If your team was as engaged as it was possibly be, what would you do? Anything else in terms of health? 1 more minute, 5 minutes. You nearly done it.
Thank you.
Happy, show up to work, teamwork.
5 minutes, Pam. Thanks.
Show up to work with a better attitude.
Tasha, when they present, they can just present back here, right? They don't need to go back to there.
I think just get them to do it in their little groups at the end.
Yeah, I mean, so they can just
walk around with the microphone?
Yeah, yeah, and then he'll probably film it, and then I can wrap it up, and that should be okay. Yeah.
Like not getting paid on that. 10?
4 minutes. 4 minutes. This group's almost finished. That group's almost finished. That gone all right? There's a lot of interesting conversation coming out.
So what are you wanting to take back the sheets, please? Or?
Yes, if I can. So what I thought, if they just do a quick present back, maybe 2 per group, 2 minutes per group, and then I'll just do a wrap up in terms of what we're going to do with it, what they can expect to see moving forward, and we can wrap it up. That all good? Thanks.
Tamaki, not with a Mecca, because obviously we're all under a Mecca, but is there anything that's recognised? You know, some of us work a bit harder or do want to put ourselves forward, or some of the pictures that's disengaged. You know, is there anything there that we can incentivise?
So that's the recognition piece coming through, the reward piece. Yeah.
Is there anything, or will there be anything? Because we're all under a Mecca.
Yeah. And there's various ways of doing that too, isn't there, in terms of rewarding people. So it could be development opportunities or...
Query incentives. I remember when I went for my job interview, and because we weren't under Tamaki Mecca at that time, and the boss said to me, oh well, pay's not up for discussion, you're under the Mecca, and I just sort of thought, yeah, well thanks so much, I know what I'm coming into. You're already in, that's what you're getting, and that's it.
Can each of the groups please nominate 2 people that are happy to talk to their presentations?
progress, will you two people to talk? Well, can you work with your group that two of them talk feedback? Two of them feedback. We'll just go around the tables. I don't have to.
Oh, yeah?
And just talk to the points that they've raised, and then we can consolidate it all and wrap up.
So they will talk. Okay. They will talk.
Will they talk?
Yeah.
Okay, cool. Thanks.
One of them will speak.
One or two. Yeah.
Yeah, one or two. One or two. Yeah.
Okay, cool. Sorry, which clinic are you from?
I'm in Christchurch.
Oh, okay. Which clinic? Oh, okay. All right. Okay.
So it's quite a big dynamic, really.
You've got the person's going to talk?
Two people.
Oh, thank you. Thank you.
And
Thank you.
Sarah.
Cool.
So we all
Thanks.
done. I loved it. It was so good to thank you.
So they're done.
Rather than 2 days.
Are you guys?
Okay, anything else we need to capture on that? And so then we're going to do support from the team. Nice. Anything else that we want to quickly capture about the culture? Because the next safe space. Is it a safe space?
The next one's the big one.
Yeah, that's right. Anything else? Okay. What messages have you got for Lloyd? Lloyd was he was here this morning, and did you have a burning thing you just wanted to go? Lloyd?
Just throw the words at the board and then we'll bring up
Thank you. They're almost all done apart from Joanne's group. It was good. Thank you. You did really well.
I love those sorts of things.
Good. Good. It's good to know. It's good to know he enjoys that, eh? Yeah, Joanne's group.
Maybe we'll do them last.
Yeah. Trying to take this off. Like, are we ready to come back and all good? Can we start with your group? So do you want to stay in your groups and then we'll just go around and you can give us a quick update? Okay, cool. Oh, thank you. Thanks. Okay, can we come back to the group? We're going to start at this table. Okay. Okay, so if we're going to start with this group, so just question one, could you please give a general description of morale now and over the last 12 months?
A little bit low, but better than 12 months ago. Consistency with staffing.
Good. Anything else to add to that, or is that... what are some of the things that Tamaki Health is doing right in terms of employee engagement and well-being?
Improved EAP, transparency, and staffing of, like the rosters are done better.
Cool, thank you. And question three, what are some of the things that Tamaki Health could do better to improve employee engagement and well-being?
Stability of staffing, so we want stable teams, people staying, retention, more recognition for nurses that have done in-house training for new staff, more engagement from head office staff, sorting out payroll issues and incentives for nursing achievements.
Thank you. Question 4. If your team was as engaged as it could possibly be, what would that look like? Who would like to take that one?
So it would be full staffing, daily basis, open lines of communication. For example, morning huddles to start the day, if there is something important to discuss, and getting and taking proper breaks.
Nice. Do you want to take the last one? Because that looks very positive. So if you had a message for Lois, what would it be?
The message would be, thank you, keep up the good work. You are realistic, which is good, open-minded. Yeah.
Thank you so much. So do you want to just... Any questions for this group? All right. Thank you. Thanks. Okay, who can thank you? I'm not going to read all the questions. We know them well by now.
So we had a bit of a mixed bag for number 1. Morale at the moment is quite affected by clinic closures and short staffing, and then communication on top of that. Obviously, poor staffing often led to poor morale. The morale improves with moments of calmness. You know, when we kind of get to the end of the tasks, we might have a moment. And yeah, that increased with better communication.
What's number 3? On the other end,
2.
So some of the things that we're feeling like we're doing right here in Tamaki Health is increasing the training and development and education for nurses. There's always opportunities for that. And management are trying to find out what's not working so we can fix that. And payments for change of shifts. More support for clinic coordinators due to previous staffing leaving. And what's this one?
The EAP program being available. Huh? Yeah. Improve on. So some areas that Tamaki Health could improve on be communication with all staff, rather than messages being passed on and through, and kind of keeping the team as a whole. Lack of accessibility to things like rosters and knowing who's on at work, obviously staff retention, and some more like team building activities. Obviously, it's often quite good with like Prezi cards for competitions, so maybe some more like in-work competitions or things like that. And one little comment I wrote is just less separation between White Cross and local doctors. Often you feel like it's quite two separate teams. Okay. And next one, if your team was engaged, possibly be what would it look like? So less negative comments, knowledge of staff and who's on and knowing the other people that you're working with, having a good staff mix in general, and obviously less sick calls and more people around.
So for words or sentences that we think that Tamaki Health represents Tamaki Health is that they're very culturally diverse and inclusive and friendly. So no matter who you are, where you come from, we treat all sorts of people. We all feel like, I feel like that as well, that, we all fit in, doesn't matter, where we come from. And 6, what we would say to the CEO is thank him for his enthusiasm and appreciate his medical background, and a very approachable guy, people person, not task focused, and thanks for visiting the clinics.
Thanks very much. I think that's great feedback. The communication one is one that's come up quite a lot, particularly in the other focus groups that we've done. So what we'll probably do when we start working through actions as an organisation, we'll probably start reaching out kind of how do people want to be communicated with, because certainly it is one of the burning topics. So thank you very much. Any questions for this group? Thank you. So who will be speaking here? All right.
That's what happens. You come, really late in the day, and suddenly you are speaking on behalf of all the nurses. Not quite sure how that works, but anyway, thanks, guys. Oh, thank you. So, thanks. We had a bit of fun. Just by way of introduction, our team is local doctors and White Cross, and people who've been here a long time and a short time, and people who are in clinics that have recently been acquired, so have a different perspective, as well as clinics that have been recently integrated. So we had quite a diverse range of thoughts. So anyway, kicking off, number one, how does engagement compare to last year? Well, more staff and better morale in most clinics, but not everybody agreed. In some clinics it's just the same because they have small teams, and so there's not been a shift. Doesn't mean it's positive or negative, it's just not been a shift. Better pay, everybody was really excited about that, said it could be better, but they see that as recognition for the mahi that they're doing. And some staff have had no pay rise yet, so they're looking forward to that happening. Moving back to more traditional care now, so away from that focus on busy, corporate, do, and focusing more on patient care, which is what nurses traditionally want to do. Better training for new staff. That came up several times in our conversation, and also the recognition of better pathways for a nursing team. Last year was pressurised, still chasing management. Oh, sorry, this is still number one. People feel like they're still chasing management for answers last year. That's still happening a bit, and not always clear about the roles and responsibilities of different people within management. We had a bit of a conversation about who's management? What is management? Is that the MSO or is that in the clinic? Who's management? And the answer was that it's just unclear about who does what and who's responsible for what, both in the clinic and within the MSO. Last year it wasn't easy to take leave. You had to negotiate and just about fight to say I'm at the end of my tether and I'm just going to fall over and I need to take leave. And it was discouraged, and there's been a move towards encouraging people to take leave and look after themselves. It's very positive from where I come from. Number two, what are some of the things that Tamaki Health is doing right in terms of employee engagement and wellbeing? Better pay, better engagement, better focus on wellbeing, more training, focusing on family, and there was some chat around the Christmas celebration including family. Improved access to the MSO, so rather than being, that office that's tucked away somewhere miles away, there's more people coming through the MSO, so more people are familiar with it, which makes it easier to come back, which is a really good thing. Improved PDRP program. Being asked about wellbeing, so that was a real positive. Yay, people actually care, they want to know about what's going on for us. Improved recruitment, better support to cover shifts and more flexibility to take leave. So back to that conversation about last year it was really difficult to take leave because everybody was short-staffed. Everybody was exhausted last year, right? And so moving towards looking after ourselves. Number three, what are some of the things that we could do to improve? Better equipment, sort out IT. Who agrees with that one? Yeah, keeps coming up, doesn't it? Focusing on retention of staff, so we've got really good at getting them on board. Can we make sure that we retain them? It's quite a lot of effort goes into training them, so can we make sure that we retain them? An acknowledgement of skill acquisition, so nurses are trained and competent people, and making sure that those skills are acknowledged. Security at night is one of the things that people said gets in the way of feeling safe at work, and some of the clinics that are upstairs with dark car parks downstairs, it's not a nice thing to have to go down to your car at night time. Number four, what can we do? Oh, lost my questions. What can we do? Number four was about, if your team was engaged as could possibly be, what would that be like? It would be, people would be happy, they'd show up to work with a better and brighter attitude towards the work they had to do. We'd have open communication, so not just with patients, but with each other and also with the people that we report to. Next page, please. So we had a conversation about, this is an interesting one, so the idea that Tamaki Health is quite doctor-centric, and that in some of the teams where they think engagement and wellbeing is working very, very well, it's because the doctors are part of the team, they're not the boss. And so everybody understands that they have their role to play, and a doctor is a doctor, and he's just as important as the nurse. Nurse is just as important as the doctor, and the receptionist is just as important as well, because you're all in a team. So that was a pretty clear message, is that we've been a very doctor-centric organisation, and it's time that we came into this century. That wasn't from me, by the way. Just saying, none of these are from me. Just in case you think they were. Okay. The last question, so number 5. If you had a couple of words or sentences about the culture, what would it be? Multicultural, patient-focused, oh yes, doctor-led organisation. Supportive team in our clinics, and our clinics are generally a safe space. Messages for Lloyd. All right, sort out the IT, sort out the pay, keep on with what you've started, you're on a good journey. Make sure people are being appraised and rewarded for what they do, and keep up with the training, because the training, people see that as a really positive thing, and the progression, so people being able to see that they are, if they want to, progress further within the organisation. That's it. Round of applause to this team. Thank you very much.
Thank you very much. Yeah, that technology piece does come up time and time again, so it's definitely cool. Any questions for this group before we move on to the last group? Thank you.
Thank you.
So, a description of morale. This group thought the morale was overall improved, and with the exception of one clinic, which morale was difficult because of a big staff turn.
Have we got it turned on?
Okay, sorry. Morale was good, staffing levels were better. One clinic was feeling low because of a big staff turnover and just getting that team back up. Better staffing levels. A number of the clinics said they were pleased with the staffing levels, and increased educational opportunities and a pay rise. Yay. Made people feel happy. Some of the things that Tamaki Health could do.
Yeah. For number 2, we had the nurse doing. Yeah. Our nurse conference, wellness advisors, and Christmas functions. Thank you very much. Letter that they've got out, Lloyd's blog. Increased engagement from office in some clinics. Hope I'm reading this right. Yeah. In-house training back on track. Great leaders, really supportive nursing clinical leads and admin staff. Good admin support. Good culture in teams, plus regular peer reviews. Good communication in clinics. When you've got closed.
That was around the clinic closure. They were pleased with the workforce, how the workforce were sending out the
staff and resources.
Yeah. For number 3, what could Tamaki Health improve? A lot of people didn't know about the platform for nurse recognition, which is happening tomorrow. So nurses would like to see that more often and be more widely publicised, so that they could nominate their peers or each other or anyone they chose to. So just having a bit more formal recognition in that, not quite employee of the month, but something along those lines. There was some talk about RNs feeling not listened to when patient numbers were too high, and felt a bit unheard about that. There was also some discussion around when a clinic was closed, or more than one clinic was closed, but the remaining 24-hour clinics did not get extra staff redeployed to them, and felt really under the pump about that. Also, there was some discussion about having regular team meetings or staff meetings within the clinics. Maybe a huddle at the start of the shift, a bit of supervision, feel like people looking after each other, and payroll issues have been an ongoing issue people have been worried about.
And if you had to choose a couple of words and sentences to describe the culture at Tamaki Health, I have one. Okay, we're just going back. If your team was as engaged as it could possibly be, what would it be like? And we thought people happy to come to work, less people sick, enjoying breaks, or actually taking breaks, less errands, no complaints from our patients, from anyone actually, and good Google reviews. With a smile. With a smile.
Words for describing Tamaki Health, we didn't have much to say. We were all pretty agreed that we think it's very customer focused. We feel proud of the care that we give. But there was some talk about there being a disconnect between more senior management and the clinical staff at the clinic on the front line.
And our last one about what we would like to say to Lloyd is we really enjoyed meeting him in the clinics because he came around twice, I think. Good luck, and thank you for the opportunity for education, and thank you for our increase in pay. We're all really happy about that, and being open to recognising our value in the future.
That's great. Thank you very much. I think I'm going to wrap up now because I think I've run over time. But I think thank you very much for everybody's input. It's really, really great to, we've read through the results, but to actually hear directly from people. Just in terms of next steps, we will be consolidating all this information. We're having a session with ELT around kind of what the corporate actions are going to be. So it'll be great for us to feedback some of this information that's coming from the group. Whilst you go back to your clinic, expect to see we've distributed all of the individual clinic results now. So over the next 2 months, your clinic leaders will be sitting with you and working through what those results show in your clinic, as well as looking at action plans. So that'll be happening towards the end of the year. So thank you very much for everybody's time, and I will hand over to Natasha.
Cool. Awesome. So we'll move on to the next presentation. So Pam is super organized and has a bio, so I'm going to read that out. So Pam has originally trained as an occupational therapist, but her love and learning led to her to graduate with a Master's of Business Studies while juggling motherhood and running her husband's surgical practice. Following his accidental death and that of their 2 eldest boys in 2002, followed by the Christchurch earthquakes in 2011, which impacted most of her immediate family, Pam's experiences compelled her to continue her studies with a graduate certificate, followed by a postgraduate diploma in emergency management. These days, Pam undertakes some contract OT work and works 4 days a week for Tamaki Health. 5 days a week, sorry. She also undertakes a number of voluntary roles, including working with young people in the Seasons of Growth program for those who have experienced loss, grief, or change. Pam has been representing Occupational Therapy New Zealand Health and Safety Association of New Zealand governance group since 2017. Today she is going to discuss self-care and creating a mentally safe workplace and cornerstone and the support the nurses can kind of do to make sure that it's run well.
Can you hear me if I don't have a mic?
There's people online can't.
Oh, okay, so I have to have a mic, that's painful. So just the idea of doing the bio was just so really you knew that I came from a clinical background. So I know that for nurses, and I have 3 male nurses in my family, so I've grown up around nurses and grown up around male nurses, which was, you know, when I was 20, that was quite unusual to have male nurses in the family. So, but it just helps land me, probably, hopefully you go, oh, okay, so she might have a bit of an idea about where we're coming from. I've been in and around the health sector for pretty much all of my career, doing different things. So that's kind of the idea about it, the bio. Today we're going to talk about creating mentally healthy work. So the focus is now shifting to you, away from patients. Can you cope? Yeah, no. Jenny says no, can't cope. It's much safer talking about wellbeing than patients. All right. The thing I like to start with is trying to get an idea of what you think wellbeing is. What is it to you? Because we throw the word wellbeing around a lot, don't we? We talk about wellbeing and we talk about mental health and we talk about mental illness. What's wellbeing? We've talked about it today. What are we actually talking about? Yeah, so feeling satisfaction at work and home. Yep, nice. What else? Sorry, I missed that. Balance. Yep, wellbeing's about balance. What else? Contentedness. Yep. What else? What do you guys reckon wellbeing's about? Healthy relationships. Yep. Connectedness. Yep. Come on. All right, so what's mental illness? Is it the opposite? What do you others think? What was that? The absence of wellbeing? It's interesting, isn't it? These are words that we talk about all the time, but we have different ideas about what they are. So wellbeing, you'll see up here, is not just the absence of mental illness. We know it leads to better physical and mental health, but it is actually different to mental health. Wellbeing is a subset of mental health. We know it helps us recover from mental illness, but it's not the same. Mental illness, by definition, is when you have a diagnosis for a mental illness. So that's what mental illness is. It's actually a diagnosis of some psychiatric disorder. So we talk about mental health, we talk about wellbeing, and we talk about mental illness, but we could be talking about all sorts of things. So when I talk about the subject, I like to get a feel for the room and what people think it means for themselves. We know that wellbeing is dynamic. It moves. So this morning you might have been feeling energetic. This afternoon you might be feeling sluggish. Hopefully you're still awake. But it changes, right? It changes according to what life throws at us. It's subjective, so what you think a high state of wellbeing for yourself is, oh, hello Alice, didn't see you before, might be quite different from what someone else thinks is a high state of wellbeing. It's holistic, so wellbeing impacts our whole life. So we heard about the work me and the home me. Wellbeing impacts all of that. So wellbeing by definition is feeling good, functioning well, being satisfied with life, generally having positive feelings about what's going on, doing things that give us meaning and purpose. Now, nurses generally are in their vocation for meaning and purpose. It's about being connected. So if we have a strong sense of connection, we're much more likely to have a high level of well-being. And about feeling valued. So when those things are missing, it impacts our well-being. Why should we care about well-being? Why should we care? As an employer, why should we care? As team leaders, why should we care? As nurses, why should we care? So we can work properly? Yep. Who's our biggest asset in the organisation? People, yeah. Yeah, so if we don't care about the well-being of our people, then what happens to our patients? Do they get better service? Poorer service? No, they get poorer service, right? You know this stuff.
they get poorer service. So it's really, really important that we focus on the well-being of our team members. It's you, it's me, it's the people that we work alongside. People are our greatest asset, all right? That's why that is at the top. This business is based on people, for people. That is how you will improve the health of the people that you work with in your enrolled populations, and for those of you who work in urgent care, for the people who front as casual patients. Looking after people is the right thing to do. People are the solution. So often we get focused on that's the problem, that person's the problem, but people are the solution, which is why engagement is important. Because if we don't engage with people to understand the issues, in health and safety we talk about work as planned versus work as done. If we don't understand the difference between work as planned and how work is done, then we're actually going to make a mess of it. Healthy people are productive people. So last year when you were tired, exhausted, wanting to go on leave, having your leave turned down, how did it make you feel? Great? No. Did your productivity go up? Did it go down? Were you working to rule but not telling anybody? Were you getting, see someone's laughing over there. Well, that's when we start to get presenteeism, right? People turn up to work, they do the job, but they're actually checked out. So healthy people are productive people. You can have all the knowledge, experience and skills in the world, but if you're exhausted, your output is going to be very low to no productivity. Low, and then if you get ill, no productivity. And of course, because I work in health and safety, I'm bound by legislation, so the Health and Safety at Work Act, but I always put it at the bottom, because in actual fact, if we look at all the other things in terms of wellbeing, if we do all of those things, then we'll be taking care of the requirements in terms of the Act. So you'll see there, and we've had quite a lot of conversation around this already in the last few months, leadership and culture impact productivity. So with a change in leadership, you're starting to see a shift in the culture, and that's starting to impact productivity. So the converse happens as well. If you have toxic leaders at the top, or leaders that don't care about their people, that impacts the culture, and that also impacts the productivity. So we have to, wellbeing starts at the top of an organisation, and you're starting to see that now, is that we have leaders in the organisation who are focused on making a big cultural shift to benefit patients, but by looking after people. Indicators that things are not tracking well in terms of wellbeing. Sorry, you see, just realised you were looking at that screen. You have an increase in turnover of people. We've seen all of these things, I think, haven't we? So you get an increase in turnover, increase in unplanned leave. People just don't turn up to work. And we've seen that, haven't we? The last couple of years, got lots of people, they just hit the wall and just go, I'm done, I'm not going. Changes in work patterns. So you might see if someone's not actually doing well, they might come to work more, they might stay later, they might come to work less, and they might be away more often. So it's not one size fits all, we're all different, and we react differently when our wellbeing is impacted. You have a number of errors, so when people are tired and fatigued and wellbeing is falling off, then you have an increase in error rate. So someone picked up about complaints. We know that if you have lower levels of wellbeing in an organisation, the correlation with complaints goes up. People don't have a clear purpose. They don't understand what the purpose of the business is. We understand that our role is to look after people to improve the healthcare of our patients. But if we're not sure about what the purpose is of the organisation, we get a bit confused. So it's really important that we understand what the strategy is of the business and what our role is in employing that strategy. And that's the purpose of doing the Gallup survey, was to help inform the strategy, which is due out November? Yeah, it's due out in November. So we'll all understand what our role is in executing on the strategy. As frontline people, your role will be to look after patients. Lack of trust and poor respect, so you see that when things aren't going well. Toxic managers, not living by business values, not even knowing what the values are. Who can name the values for Tamaki? I don't think I could today either, actually, and I suspect they'll get changed at some point. you get changes in productivity and changes in profitability. So these are all indicators that things aren't going well. Luckily, you know how we have the curve where things go down, then they start coming back up. We're on the way up, aren't we? Yes, which is good. Okay, key elements for creating mentally healthy work environments. The leadership piece is super, super important. So in terms of health and safety, in terms of well-being, you have to have leaders that are committed to the task of looking after their people. So they have to understand that people are their biggest asset. They're not a resource to be used up and spat out. They're our asset, our biggest asset. Without you on the front line, we can't actually deliver the services that we need to. They need to be able to communicate the strategy. So we've heard some comments about communication, making sure that we communicate with everybody. So the organisation needs to be doing that. Needs to model appropriate behaviours, and we're seeing a shift in that kind of modelling of behaviour. I certainly see it within the MSO, and I'm sure you're starting to see it within the clinics. Am I right? Starting to see a shift? Yes, no? Yes, no? Yeah, some yes, some no. So some other things here. Organisation culture needs to be aligned with the strategy. So I talk a lot about strategy and a lot about culture. Those two things are intricately linked. Yeah, we need to be clear on our strategy so we can be really clear about what sort of organisation do we want to have, where are we and how do we get there. And again, that's what the Gallup survey is starting to shape and do. Now you'll see some of these other things here that impact wellbeing, and I've numbered them because they're interesting, and you might not be able to read the little footnote at the bottom, so I'm going to tell you what it says. It's a piece of research that's just come out of the UK that looks specifically at burnout and anxiety and stress-induced sickness. And so those things there that are numbered are the things that are most likely to cause burnout or anxiety or stress-induced illness. Workload and pace, too much of it and too fast is the number one. Number two, perceived person job fit. So if you have a job that you don't think you're a good fit at, that's actually going to really impact your wellbeing. Sounds a bit surprising, but that's number two. I was surprised when I saw it was number two. Emotional load. So if you're dealing with sick children all the time or difficult situations all the time, you're carrying a big emotional load. And working in healthcare, you often have quite a big emotional load. You see things, you hear things, you get involved in things that are difficult. And that emotional load will have a long-term impact unless you're dealing with it. Again, communication comes up. And role clarity. So knowing, and this came up in the group I was in, knowing who does what the roles and responsibilities are of each person, whether the person's a nurse, a doctor, an admin person, or whether they're in the MSO. Understanding what our roles and responsibilities are and where they start and finish and where they cross over. And that adage again, equipment. If we don't have the right equipment in the right place at the right time to do the jobs that we're required to do, it increases our stress. So that impacts our wellbeing as well. And recognition and reward. So these things come from science. They come from, well, you can see there that I've actually put the reference at the bottom. So those are things we need. Not all work is created equal. And if you've been around for a long time, you'll know this because you will have experienced places that are toxic. I've worked in a really toxic place. It was called North Shore Hospital. Anybody else worked there? Yes, and we left. Yes, not a good place to work. So it was toxic, and I left before I became unwell. People in my team who stuck it out ended up leaving and actually not being able to work. So I worked in the occupational health and safety team, and some of the nurses I worked alongside became so unwell. One of them's still not working, and that was a direct result of working in that toxic environment. So toxic work will actually make you sick. Good work will help you to thrive. So where we want to aim is we want to have a good work environment where everybody can thrive. All right, you probably can't read that, so, because I can't read it either, and I'm closer to it than you are. But this is a model for how we create mentally healthy workplaces. And I just want to talk to you, I'm going to move over here a little bit, so I have a better show at looking at it. So the things that we have to do within an organisation is we have to protect you. We have a legal requirement to protect you under the Health and Safety at Work legislation. That means we have to know what your risks are. So by risks, it's not just physical risks, it's risks to your health and it's risks to your mental health as well. We have to support you to be able to access the things that you need to do your job. And if you need it, appropriate clinical support. And then we have the opportunity to look after you when things aren't going right and also to reclaim things. So we've got people in this room who've been off work because they've been sick or they've been injured. And as an employer, we have an obligation to look after you, to help you re-enter into the workplace in a way that is safe and sustainable. This is where it gets interesting, so you're going to have to really focus on this. I normally do this in about 5 slides, and I've put it into 1. So you'll see here that we have 2 continuums. So we have a wellbeing continuum, so we can have a high level of wellbeing or a low level of wellbeing. And you'll see also that mental illness to mental health is also on a continuum. Where you really want to be is in the top right quadrant. It's where you always want to be with any of these diagrams, isn't it? In the top right quadrant. So you want to be thriving. So that comes from the slide before. Foster. You want to protect your employees if they're not doing so well and help them to manage. And if people are struggling, you want to help reclaim that. So that's if people have been off work or if they've got difficulties going on, you want to be looking after them. And if people are unwell, then you've got to support them. So that might be physically unwell, it might be mentally unwell, might be just that you're dealing with a crisis in the family and that you just need some additional time off work or some flexible hours or something else. All right, it jumped. So these are just some things that you can do. Now, one of the things to remember with this whole space is that we have responsibilities as an organisation. So we have responsibilities. I have responsibilities. We have responsibilities. So if you're in a team, we have responsibilities. And then, so we go I, we, us. So us is the entire organisation. We is the team approach. And I is me, myself, and I. So we have responsibilities at each of those levels. So I have a responsibility to look after myself, make sure that I exercise, I stay connected, I learn things, take notice, give people a smile or a hard time, whatever it might be. We, as team members, have a requirement to look after each other, to identify, know our teammates well enough so that we know if they're having a bad day or that they can put their hand up and say, I'm having a bad day, so that we can then maybe help them out, share the load. And as an organisation, it's about that design piece, so making sure that we have the right people in the right place at the right time with the right equipment and the right skill mix to do the job. All right, so if we want people to stay in the right-hand quadrant up the top, we want to be encouraging them to carry on doing what they're doing. We want them to recognise when things have gone wrong before and know how they got back into that quadrant, because that's the best time to learn that. There's no point in trying to do it when you're unwell. You need to, when you're well, go, this is what's working, and I'm well because I'm doing this, this, and this, and this. If people are struggling, we might want to do some of these other things. Help them with stress management, direct them to EAP. It might be we need to get them a coach. Who has a coach? Have you ever had a work coach? Supervision? You'd have supervision, clinical supervision. But what about looking after you? Do you have a coach? Sometimes that's a good thing too. And encourage the use of wellbeing tools. Now, I'm not a fan of apps. Apps are useful, but they're just apps. The real benefit is in the doing. It's always in the doing. It's not in the being on an app. If people are really unwell, then it might be, and I'm talking about staff here, I'm not talking about our patients that we look after. It might be making sure that we hook them into the right clinical team or the right clinical person. It might be, I've made calls to a doctor before on behalf of one of my teammates because they weren't in a space to do it. It might be offering to do that. It's not that we have to make it right, but it's about identifying that someone might be having some trouble and might need a hand. Might be that you refer them to the people in culture team. Work adjustment, so someone brought this up as well. Last year it was really inflexible and now it's much more flexible. So if someone's got something going on in the family and they need a bit of flexibility, then we want our person to have a little bit of flexibility because we want them to be able to bring their best selves to work. Sometimes stuff happens, right? Sometimes our partners get sick, our animals get sick, and we might have to be a little bit flexible about how we deal with some of that. And obviously protect against discrimination and racism. And I think as an organisation, and I'm clearly white, but I think, and I'm probably in the minority these days, but my sense is from hearing you today is that we do a pretty good job of that. A fishbowl. I like this picture. So, because what it tells us, if we have good water, those fish are going to be well, right? But if that water, if we don't put food in it, and we don't put those leafy things in it that oxygenate the water, what's going to happen to the fish? What's going to happen? They will die. What happens before they die? They get sick. They go belly up and they get sick. So this is the same for us. If we work in a really healthy work environment and it becomes toxic, what we typically do is we go, I'm going on holiday. But if we came back to the same work environment and nothing's changed, then we end up in the same position. So we've got to make sure that the water's healthy. We've got to make sure that the environment that we're working in, and we all have the ability to help create the environment that we're working in, we've got to help make sure that that environment is a positive and a good place to be. We spend a huge amount of time at work, don't we? Yeah. All right, a few little things you can do for yourself. So we've talked a little bit about what the organisation can do in terms of making sure that the design of work is right, and a little bit in terms of teams, playing your role in the team. Things that you can do for yourself. Has anybody heard of Lucy? Oh, go home and look her up. So she's a TED Talk speaker. She's amazing. She has a PhD in resilience, and she's from Canterbury. So, well, she's originally from the UK, actually, but Wellona. She's from Canterbury. Her daughter was killed when she was 12 in a car accident, and she went on and did a PhD in resilience, specifically looking at loss and grief. So this is the kind of stuff she talks about. And if you haven't heard her TED Talk is 20 minutes. I suggest you look it up. I've listened to the TED Talk 3 times, and I've heard her speak on stage twice. So some 3 key points from her that I really, really like is suffering doesn't discriminate. We all suffer at some point. We think when we're on social media that everybody else's life is absolutely amazing. Their children are well behaved and they never misbehave, and that baby is always asleep, feeds well, nothing is ever wrong. Those teenagers, they're just angelic. That is not true. We know this, don't we? That is not true. So know that suffering doesn't discriminate. Struggle is a normal part of life. We're supposed to struggle. It's how we learn, right? I think that, you know, the most critical part for me for learning was when I went through the intense suffering that I went through. I learned very, very quickly who my friends were. I learned very, very quickly what I cared about and what I didn't care about. So suffering is where we learn. They call it growth. Growth through grief, yeah. Resilient people are really good at choosing what they pay attention to. So rather than going, I have to do all these things, I can remember, Alicia, we've had this conversation before. Focus on the things that matter, focus on the things that you can control, and make sure that you control and prioritise ruthlessly, because we're always going to have too much to do, always. So it's about saying, what's in my focus of control, what is it that I can actually achieve today, and what is it that needs to be left? What has to be done today? What has to be done this week? What never needs doing? Get it off your list. Put it on someone else's list, or just get rid of it. Resilient people always ask themselves, is this helping me or harming me? That's actually my favourite one of the 3, is doing this helping me or harming me? So before you go and say to someone, you're really pissing me off, stop for a minute and say, is that going to help things or harm things? Is it going to make our day better or worse? What are we going to achieve from that? That's the thing I find most useful out of the 3, is what I'm doing helping me or harming me. I heard this talked about today too, daily huddles. So a daily huddle is a 15-minute stand-up at the beginning of the day where you talk about the things that need to be done during the day. It's not a whinge fest. It's just about focusing on what needs to be done today. How are we tracking as each of us individuals? Have we had enough sleep? Are we slightly off our game? Is everybody in the family all right? Do we need help or support? What are the things that we might need help or support with? So it's very short, very sweet. It's very about being clear about what the mahi is for the day and what our role is in doing that as a team. And you would have seen this before as well. Who's familiar with this? Yeah, so we know that this stuff works. So this stuff isn't just produced by the Mental Health Foundation in New Zealand. It actually comes from the United Kingdom. And it came out of the Economic Forum, and it's been around for about 15 years. And the Economic Forum was asked to do research on how you could lift the well-being of an entire country. It's a lot of people when you're talking about the UK. And this is what they came up with, was the 5 ways to well-being. So it is evidence-based, has quite a long history. So give your time, your words, your presence. Doesn't take long. This is the thing my kids always gave me the hardest time about. Mum, you're not listening to me. Who's had that before? Who's had a boss that sits with their laptop open while they're having a meeting with you? Does it make you feel good? What if they answer their phone? Does it make you feel good? Do you feel like they're actually present? No. So some of these things don't cost money. It's about being present. Give people your time. Give your kids your time. Give your co-workers your time. And then they'll give it back to you, hopefully. Be active. Everybody knows this. We've been talking about being active for decades. It feels like decades. Do what you can. Move your mood. We know that when life is a bit miserable, for me, I know if life is a bit miserable, I need to get outside. I need to probably get in the garden, go to the beach, or get in the bush. One of those things. Move your mood. Keep learning. I learn French, keeps me entertained. Might be learning a different part of your role, different kind of leisure activity, but keep learning, because that we know also helps wellbeing. Talk, listen, be there, feel connected. So connection, whether it's with your people, your friends, your family, the land, where you come from, get connected. Stay connected. When we're stressed, some of us go and hide, and that doesn't help. We do it because it's easier. We just want to go and live in a little rabbit hole. But in actual fact, it generally doesn't help us. So stay connected. Stay connected with the things that are important to you. And take notice. So that's about taking notice of yourself, what's going on for you at the moment. I'm going through, at the moment, it's my anniversary time, and I know that that impacts my well-being, and it impacts my mood. I get shittier. I'm more likely to blow a fuse with people who are annoying me. And there are days when I just feel really, really flat. But I know that that time will pass also. And I know that it's a time where I have to nurture myself and look after myself. So what are the things for you? What are the cues for you that you know that, oh, actually I'm feeling a bit off. Actually today's a bit rough. This week's a bit rough. What are the things for you? Take notice for yourself. Take notice for your colleagues. They're a bit off this week. What's going on with them? They're not at lunch today. They always come to lunch. Suddenly they're eating lots of donuts. What's that about? Or they're not eating lunch. Whatever it is, notice the change and then ask if they're okay. Take notice. Remember the simple things that give you joy, because when we're under stress, those are the things that go out the window. Sometimes it's quite handy to write a list of the things that give you joy and make sure you're doing them. Plan to do them. Ta-da! So what I've tried to do today is to give you a bit of a sense that wellbeing is about me, it's about team, and it's about Tamaki. So all 3 parts have a role to play in ensuring the wellbeing of you as individuals and of us as an organisation that is thriving. So there you go. Thank you for listening. Please stand up and have a stretch if you need one.
Almost there, guys. You guys are doing really well. If anyone needs to have a pee break,
All right, I'm back. Hope you had a nice break. So we're going to change track now. We're going to talk about Cornerstone. Alice is here and he's a star at Cornerstone. So he's now looking very worried, but he's done a great Cornerstone project. I'll just wait until they stop talking. Alrighty, who wants to go home? All right, excellent. Let's go then. Let's keep going. Okay, so Cornerstone has two parts. So people often think that it only has one part, but it has two parts. It has the CQI part, which is about continuous quality improvement, and then it has the equity part. So I'm going to talk about the CQI part first, which is really the bit that the nurses are most likely to be involved in. Who's been involved in a CQI project? Oh yes, Alicia's been involved in many, Reshmi's been involved in many, Alice did a great job, and yes, over there too. Which clinic are you from? Sorry? Oh, excellent. Oh, so Stoddard Road has just submitted their CQI proposal this week, and I don't know if you were told this, but it was one of the best I've seen. So kudos to you, there you go. So it's about developing a project proposal for your enrolled population and developing a final report. And basically what you're trying to do is demonstrate the stuff that you do to improve the equity and access to your services in your clinic. That's it. That's not too hard, doesn't sound too hard. And it also means that we can have junior doctors in your clinic that the college pays for. All right? So it's about showcasing the work that you do, being a little bit aspirational with some of the work that you do, if you want to be aspirational. So some of the clinics have been aspirational. And then making sure that we can get funding for the junior doctors that come and work in your clinic. Which is interesting because some of the clinics tell me they haven't got time to do this work. And I'm like, well, you have to do the work because you have a junior doctor in your clinic, which is actually an extra pair of hands, that's been funded by the college on the basis that you do the work. So not sure how that don't have time to do it works. Anyway. That's why we do it. So the benefits are it showcases your practice's work and how you can improve health outcomes for people who wouldn't otherwise have been accessed. Creates confidence and skills within the team to repeat and redefine each quality improvement process and apply it to either the same area or other areas. Some people have found it really rewarding and empowering to actually go back to what's important to them. I come to work to improve the health outcomes for the enrolled population of this clinic. Oh, that's what this is about. Oh, now I get it. Yeah. Helps evolve improved service delivery. It's focus on safety and efficiency. And, again, we get paid for the junior doctors from the college. So it incorporates the 3 points of the triple aim. Has anybody heard of those? You don't have to have, because I'd never heard of them until I started doing this work. Basically, it's about improving quality, safety and experience of care. It's about improving our equity, so for our population. So I'll come back to the equity piece when we talk about equity. And it's about best value for public health spending. So it's data-driven. So you can't just have a good idea and then say, we did this is our good idea, we did this, and this is what it meant. You have to say, we looked at our data for our enrolled population, and our enrolled population is made up of Māori, X percentage, Pacific, X percentage, Asian, X percentage, other X percentage, and European. So you need to know your enrolled population, because once you know your enrolled population, who comes to your clinic, where they're from, then you get a good idea of what their health needs are. So, are they more likely to have diabetes? Browns. Are they more likely to need cervical smears? We did that across lots of clinics, including Dawson. Is anybody here? Oh, yes, there's someone here from Dawson. Yes. Did that at Dawson. Are they more likely to need a CVDRA? Mount Roskill. Someone here from Mount Roskill? Yeah. So when you know your clinic, you know your population, you can actually work out what the risks are that are unique to your clinic. But given our clinics, we've been able to actually share some of that, some of the way we've worked to lessen the load. So we've had about 4 different projects that we've worked on. So we identify the inequities through our data. Then we work out what we want to do. We write a proposal, look at possible solutions. Then we monitor and review the changes. Then we make necessary changes. So it's in 2 parts. So we use our data, we make a plan, we implement the plan, we go, this worked, this didn't work. All right, we're going to do it again. And we're going to increase the things that worked, and we're going to get rid of the things that didn't work, and we're going to do it again. And then we compare them to each other. Say, we started off, and the first time we did it, this was our success rate. Here's a pretty graph. And then we did it the second time, and we increased those things that worked, and here's a pretty graph. And now we can show the difference. Here's a graph with both of them. It's not actually too hard, and that's it. Then we write it up, and we say, this worked, this didn't work. Yes, we can replicate it. We can do it more. We can implement it as part of business as usual, and we're going to do that by this. That is it. Done. Does it sound relatively simple? Or have I made it really complicated? Alice, is it simple? Alice did his as part of a uni project, so his was probably the most complicated one out of all of the ones I've seen. I've seen 18. Yeah. And his was the only one, just by the way, that had no rework required on it. So, yeah. Except for Stoddard's going to compete you now, because I think they're probably going to be very close. All right, that's CQI. Any questions? So you do a proposal. This is what we want to do based on our data. Gets submitted, gets approved, not by me, by an assessor. Then you get on with the work that you said you're going to do, and then you write a report on it. That's it. One of the things they really focused on is how you do the practice engagement. So this isn't just a one-person project, it's a team project. And so they look for evidence that you've done this as a team. And so quite often one of the things I come across when I'm in clinic is the lack of team meetings. And so it's really important that you're having team meetings or team huddles or corridor meetings, and that you're actually documenting that stuff somewhere, because then you can provide evidence that you're doing it. It's just not a one-person party getting stuff done. Also with patient and whānau engagement, they want to see that somehow you're talking to your people about what's important to them. So what's important to your enrolled population? Are you actually talking to people in your community that also provide services to, depending on your population, to Pacific people, to Māori people, to your Asian community? How are you working with them? So you would have just heard me talk about some of these, but some of the examples that have been used is how do you boost your child immunisations? So we've done a big thing about that, fluinims across the winter period for the whole of Tamaki Health. We've had, with CQI, we've had projects around HPV and smears. We've had people focusing on long-term conditions and chronic diseases, mostly around diabetes and blood pressure, and also CVD-RA. So they're the ones that we've typically picked on. We haven't done any with hepatitis C, but we're currently doing some work with hepatitis C with BBM. So that would be a nice one to pick if anybody's interested in that. So there you go, finished report, that's it. Title page, contents. I typically do the front end, so I would work with your clinic helping to do your proposal, and either Alicia or Reshmi would help with that as well, making sure that the nursing part is appropriate. And then you'll see that there's a space, because down the bottom is the bit that the clinic really has to do, and that has to be nursing led. You can't have a non-clinical person writing stuff about this. We've had reports that have come in that make statements about big shifts in diabetes, which the assessor just looked at and went, yeah, that didn't happen in 3 weeks. Yeah, so it needs to be evidence-based. Okay, just to give you a bit of an idea of the roles and responsibilities, so I would typically provide the template. I can pull the data on your clinic and provide it to you with a breakdown of your ethnicity and your age and gender of your enrolled population. The regional nurse leads, provide clinical guidance. They don't do the work, they provide clinical guidance and help you to do the work and help you with helping to write up the results. The clinic team needs to complete the work as described in the project plan. So you work off the plan. That's like your recipe for doing this work. So you write the proposal and you go back to the proposal and you do what you said you were going to do. Your cluster manager will make sure that it's happening in a timely manner. It's not their job to write the report because it won't be clinical if they write it, and it's a clinical piece of work. All right, jumping around here. Whoop. So the equity module. So CQI parked it over there. Equity is a different piece of work. So CQI is project-based, and equity is much more systems-based. So it's about making sure, and you've got to remember that this work is designed for single clinics, it's not designed for big corporates. So this is designed to make sure that we have systems in place to lift the health outcomes of our vulnerable people. So it's about providing guidance about what health equity looks like in general practice. It's about putting in place activities and policies that focus on quality improvement. So we have all of those done for Tamaki Health. So literally I drop them into the smart sheet for you. So that bit's easy. Lots of them were developed last year. So last year we didn't have any questions around equity or the treaty in any of our interview questions, and they weren't in any of our job descriptions. They've all been updated as a part of the process of going through Cornerstone. So we're looking at ways to improve health outcomes for Māori, but not just Māori, it's also for other priority populations. The college's expectation are that health outcomes for patients in whānau and a Cornerstone practice will become equitable over time. So they're not looking for a quick fix. That's why we talk about continuous improvement or continual improvement. And it's got to be evidence-based. So they're always asking for evidence. Has anybody seen this before? I like this picture. So reality is one person gets more than someone else, regardless of whether they need it or not. That's typically what happens. Equality is everybody gets the same thing, regardless of whether they need it or not. Equity is everyone gets the support they need, which produces equity. So I might get less than someone else, or I might get more than someone else. It just depends. So equity is focused on the outcome and giving people the things they need to produce the same outcome. That's what equity is about. And justice, and you'll see there from the picture, the reality is, you know, someone's really, really high up on that. You know, they've got lots of boxes. They've got way more boxes than everybody else. Poor kid, he's in a hole. That's the reality. And equality, everybody's just got the same box because, hey, we just treat everybody the same here. It doesn't matter where you are, what you need. We're just going to treat you all the same. Equity, see, the tall dude's got no box now, so we're thinking about treating people differently according to their different needs. And then justice is actually we just get rid of the fence. So that's what we call systemic barriers. So we have lots of barriers that get in the way of producing better health outcomes for people. One of them we've been talking about just recently is with self-swabbing. So we have this wonderful new tool called self-swabbing. And so what are the things that have been in the way? Some of the things that have been in the way are the traditional way of having to train people to do smears, yet it's not a smear, it's a self-swab. And so we've got to be really clear about what are some of the things that get in the way of improving equity for our people and health outcomes for our people. All right, so the Equity Smart Sheet covers 4 different areas, and I'm not going to go into them in any detail because I don't want to scare you off. But you'll see here it's very different. It's systems-based. So organisation and leadership, so that's largely about policy. Our workforce, how do we recruit people, how do we retain people, how do we ensure that people have an equity focus and understand the treaty. What are we doing in our practice team, what are we actually delivering, how's our practice team, what's the composition of it, does it actually reflect the people that in the community that we serve. So they're the kinds of things that it looks at. Oops. And you can't read this, but this is just what a smart sheet looks like. So I just want to show it to you so it's not scary because you're probably going to see one at some point. Typically when I work in a clinic and we're doing Cornerstone, I really encourage the nurses to focus on CQI and I really encourage the admin team to focus on getting the equity piece done. They have to work with the team because it requires producing evidence that you have those team meetings that we keep talking about. and that you are considering the needs of your population, and you have to be able to provide evidence of that. It also asks a lot of questions around training. What are you doing around training for the treaty, understanding culturally and linguistically diverse things? What are you doing about bias? How do you understand that? And there's a whole bunch of tools to watch and look at. But the gold and what the assessors always want to know is, so what? So you watched this, so what? What did you learn? What does it mean for practice? What are you going to do differently? How did you guys talk about it in a team? What are the 1, 2 or 3 things you've decided to do differently? When you did your patient surveys, what did your patients say? So what? What are you going to do differently? So that's what the assessor's looking for, particularly in the equity module. So roles and responsibilities. I upload the policy and the text into the smart sheet, so you would have seen on the right of that previous page that there's quite a lot of text. I would have dropped that in. That doesn't mean it's perfect for your clinic, it just means that it's a starting point. The clinic team need to complete the work as required in the smart sheet, including uploading the evidence. So that's the stuff that I put in is Tamaki-wide stuff. The stuff that has to happen at the clinic is how you operationalise the policy, making sure people know the policy, making sure that people have done the training, making sure they've thought about the training and it's changed the way they practice. And then the cluster manager's role is to make sure that the smart sheet is finished and done. So it's not particularly nursing-led. Nurses are involved, obviously, because it's a team process. But the place where the nurses need to really put the effort is in the CQI piece. Ta-da! Any questions? You still awake? So Cornerstone lasts for 3 years, and then you have to do it all again. So, but typically we start, so with this round of Cornerstone, we started last September, and most of them expired in March, and it's taken, I've still got 1 clinic that hasn't submitted the equity out of 18. Yeah. You may. Coming.
Natasha wants me just to mention that nursing leadership in the CQI project could be a big contributor to an expert portfolio. So that's something for you to think about and to talk to one of us about if that's an interest.
Any other questions? Do you need to have a stretch? Oh, another question.
Thanks, Pam. Does Tamaki Health have a goal for how many clinics we want to have with a Cornerstone accreditation?
Nice question. So last time around when Tamaki Health had just recently been taken over by Mercury, the focus was on getting all of the GP clinics Cornerstone accredited. And now what's happening nationally, and I don't just mean for Tamaki Health, but in general, is that clinics are focusing their efforts on clinics where we want to have junior doctors. So it's a requirement if you have a junior doctor that you have to be working towards Cornerstone. So currently we have 18 clinics working towards Cornerstone. And 21 working towards Foundation. Yeah, it's not one of yours. That's as much as I'm going to say. Any other questions? Oh, well done. Well done for staying awake. Do you want to have a stretch before you have your next speaker? Thank you for listening. So if you want to know anything, you know where to find me. Just send me an email. Ring me up.
Lucky last presentation. So introducing Dr. Gary Dennis. So I'm going to read out a little bio that he's prepared for me. So he's So Gary Dennis has suffered a serious brain injury in 2018, and as a consequence of the experience, he is a founder of Concussion Care, the only private practice in New Zealand that specialises in rehabilitation of concussion and post-concussion syndrome. Gary Dennis graduated with his wife, Dr. Lorraine, from Chiropractic College in USA in 1989, before most people in his room, or most people in this room were born. They have opened 9 clinics in 4 different countries, including Ireland, New Zealand, the Pacific island of Vanuatu, and the very first clinic in the Sultanate of Oman in the Middle East. His youngest patient was 4 hours old. His oldest is 98. To date, he has seen over 20,000 individual cases and made over 1 million spinal adjustments. For those of you who are old enough to remember, his patients have included Dire Straits, Cher, Neil Diamond, and His Royal Highness the Sultan and the Royal Family of Oman. For more information and to save time, Dr. Gary has put a bio insert in the concussion handouts that you can read on your own time. Today, he is going to talk about the challenges of managing concussion patients and to give us some tips that we can use in practice from Monday.
Hello, everybody. I arrived this morning and sat at the back of the room, and I spoke to a lovely lady there, and I said, "Hi, I'm Dr. Gary, and I'm going to be speaking at 4:30 this afternoon." And she said to me, "Oh, you've got the dead slot." So now I could have come at 4 o'clock this afternoon. That was kind of my plan. And Natasha said, "Hey, why don't you come for the day and spend the day with us and just see what we're about?" And I'm really happy that I did, because I've got a lot out of the day. And I'm hoping by the time I finish talking today that you get something out of my talk as well, okay? I'd like to show you just a short video to introduce you to our practice. My colleague, Dr. Chad, is down the back of the room here. Let's see if we can get this going. Hello, my name is Dr. Gary Dennis. This is my colleague, Dr. Chad Gordon. Welcome to Concussion Care. Concussion is a complex injury that is poorly understood. The secret is early intervention and quick access to assessment and therapy that addresses all aspects of the injured person and the challenges they and their family face. The key to recovery is a comprehensive assessment that establishes a functional baseline that measures the degree of dysregulation caused by the injury. Our assessment includes the vestibular, oculomotor, cerebellar, cervical, and autonomic nervous systems. For post-concussion syndrome, this may also include a gut health profile and behavioral optometry evaluation. Establishing this functional baseline is essential to being able to measure progress over time and ensure the best outcome. The upper cervical spine plays an important role in recovery. Unfortunately, it is largely ignored due to lack of expertise. As chiropractors, we specialize in spinal health care, so the cervical spine is not a problem for us. At Concussion Care, we offer a comprehensive wraparound program managed by one doctor. We do monthly reviews to ensure a consistent recovery back to full function. Rehabilitation is as much about the nature of the person as it is the nature of their injury. Our program includes a 47-page manual and counseling and self-management. We'll give you and your tribe the tools to help you self-regulate and avoid self-sabotage.
No referral is required, and part of your fee is covered by ACC. When you are ready to take responsibility for your recovery, give us a call.
Okay, cool. So when Natasha called me to invite me to come and speak to you, I said, okay, cool, but let me just ask you a few questions to make sure that I'm the right fit for this group. And the first question I asked was, who referred you to me to speak to your group? I'm not part of Concussion Services. This is a private practice. What made you decide to reach out to me? And her answer was, well, you're the first guy that came up on Google, so that's why I'm here. The second one was, you understand that I'm a doctor of chiropractic. I'm not a doctor of medicine. and concussion services medically managed in New Zealand. How do you feel about a chiropractor speaking to your group? And she was very warm and welcoming about that, because apparently tomorrow you've got a lovely lady chiropractor coming to talk about the management of chronic and acute back pain. So I'm glad to be here. But the invitation has created a dilemma for me, because I've got a certain conflict with the current narrative that's put out there about concussion and concussion services in New Zealand. So my dilemma is, do I talk about concussion services, I call the illusion of concussion service in New Zealand, or do I tell the truth? Should I tell the truth? Okay, all right. Now, as I do this, at a phase of my talk, I'm going to be critical, but what I'm going to do is be critical about the system, not the people. So concussion services is managed by wonderful, wonderful people. And I've been through concussion service, which I'll talk about. So this is not about the people, it's about the service, all right? So what I do, I talk about my experience and what got me into concussion management, and then I'm going to talk to you about education, and I'm going to talk to you about early intervention. In terms of education, I've given every one of you an information pack, okay? Education is key to concussion rehabilitation, and it's one of the cornerstones of our practice. One thing I didn't give you was this rehab manual. Now, it's 40 pages long. It's $25 per copy. Sorry, I can't give everybody a copy in the room. But this is one of the manuals we use in our practice as part of recovery. And I tell my patients to read this book 7 times, and I make sure that their tribe, their family, read the book 7 times as well. And the reason for that is this. It's an interesting book the first time you read it. By the 3rd time you read it, you'll start seeing stuff in there that suddenly, where did this page come from? And by the 5th time you read it, you're going, oh, now I get it. Now I understand what he's trying to get across here, okay? And by the 7th time you read it, you're sitting watching a game and you're seeing a player play and you know that that person's not right. That's the focus of our education, is to get you to be so knowledgeable about concussion that you can rehab yourself, because our concussion program it's a home-based rehab program, and it's all about educating the patient. So the information pack I've given you today, please don't read it once and throw it in the corner, forget about it. I would say to you, pick it up, put it down, pick it up, put it down, and read through it in bites over the next week. And if you do that, you'll know more about concussion than most nurses in New Zealand. Okay? So that's the education part taken care of, and it's up to you to self-educate, all right? So my story is one of a long journey. I had a very serious brain injury back 5 years ago. I was kite surfing on Orewa Beach. Something went wrong, and I had an accident, and as a consequence of the accident, I was unconscious for 8.5 minutes. My wife luckily was there, and she managed to revive me. An ambulance was called. I was taken to the hospital, and in the hospital, I went through the ED department, and I spent a number of hours there. And I passed all of the tests in the hospital. And the doctor was he's quite surprised, because he'd heard I was unconscious for 8.5 minutes. He'd heard I'd come by ambulance. And he said to me, Gary, he said, on a scale of 0 to 100, if 0 is bad and 100 is great, where do you reckon you're operating right now? And I said, mate, I'm a solid 90%. I don't know why I'm here. Now, my wife is going, she had a different opinion to me. And as a consequence of going through the testing and passing on the testing, after about 4 hours, I got irritated. Concussives quite often are not good patients. Certainly, I admit to me not being a good patient. And so I decided to discharge myself from the hospital. And I did so and left the ED department like this. That's how I left. I had a hemiplegia at the time, okay? Now, does that look like somebody who's 90% to you? Does it look like somebody who should be able to pass all the testing? So what's the problem? I went downstairs, got in the car, and I drove my wife home, okay? The following day, she knew I wasn't right. She's a chiropractor. She specializes in pediatric functional neurological development. And so she put me through some testing, and I failed her tests. So she's like, uh-oh, this isn't right. Not just clinically, but I'm going to use the word intuitively, and I'm going to talk to you a lot about your intuition in this room today. It's very, very important. She knew I wasn't right, sent me back into the system. We got involved with one of the concussion services at the time, where offering that they could see within the first 10 days of your injury under ACC. So I went and I got an assessment there. I passed all the tests again. But the doctor, listening to my story and the fact that I was unconscious, asked me about maybe having an MRI scan. Now, I've been offered a CT scan in the hospital, but I refused it. I'm a qualified radiographer and trained in radiology. I didn't want that much radiation to my brain. But when he came up with the idea of an MRI scan, I acquiesced to that. And a couple of days later, I had the scan, and they found 4 big brain bleeds going on in my brain as a consequence. So you have to ask yourself, how could I possibly pass all these tests with 4 brain bleeds? Think about that, okay? Yes, it is a problem, yeah. So, beg your pardon? No, I shouldn't. No, I can tell you lots of stories, but we'll keep going here and go from there, okay? So at that stage, I engaged with concussion services, and I went through lots of different assessments and tests with people. The message was constantly go home and rest, go home and take it easy. I took 2 weeks off practice and thought that would be enough. But on my second day back in practice after 2 weeks, I had a mental emotional breakdown in front of a patient, which is not such a good thing. So I decided I better take some more time off, which I did. And that eventually ended up being, I was off practice for 9 months. But in the first 3 months of my injury, I went through concussion services, assessment after assessment after assessment. Yes, you're concussed, yes, you're concussed, yes, you're concussed. Go home and rest. I thought it important I should see a vascular neurologist. I had brain bleeds. So we looked to get an appointment from a vascular neurologist. And my concussion took place on the 17th of September. We contacted the vascular neurologist connected to the concussion service, and they said, yes, of course we can give you an appointment. Come and see us on the 18th of January. That's 4 months after my injury, okay? I got brain bleeds going on here. Do you think I should see a vascular neurologist sooner rather than that? So I said, look, I'm not working at the moment. You must have a cancellation list. Put me on the cancellation list, and I don't care. I'll pay privately. Let's just get this sorted out. So a week later, I saw the vascular neurologist, and she assessed me. I passed all her tests, and she said, go home and take it easy. And I said, well, should I come back again? She said, yeah, probably a good idea. So the January 18th appointment that they'd offered me, I kept that appointment. And I went home, and I mismanaged myself as a consequence of not understanding what I was dealing with. Finally, after my 3rd mental emotional breakdown, my wife decided this is not working, and she reached out to one of the leading functional neurologists in the world. He's based in Melbourne. He happens to be a chiropractor, and I flew to Melbourne, and I went through all his testing, and I failed all of his testing miserably. And that was the beginning of me understanding how badly injured I was and how badly my brain was affected. And so he designed a rehab program for me that I could take back to New Zealand, and I came back to New Zealand and started on my journey to recovery. In that period of time, it got me thinking, what's it like for the ordinary person? Not everybody's married to a wonderful chiropractor who's trained in neurology. What's it like for the ordinary person who goes through services like this? I'm not a wealthy person, but I spent the money that was required to get back to getting better again. And what's it like for these people going through services here? So I decided as I started to recover, I'm going to go back and retrain and upskill so I can provide concussion care in New Zealand. So I spoke to my neurologist about it, and he said, Gary, don't do this work. And I said, why not? He said, it's too hard. Now, I thought he was talking about the academic side. Who here has ever studied neurology or brain function, neurophysiology? No? It's hard, isn't it? I'm not an academic, but I think it's the rocket science of the body, okay? But he said, no, it's not the academic side, it's the patients. The patients are hard work. And if it's not the patients, it's their tribe. Very often, it's the partner, or it's the coach, or it's the employer, just doesn't understand what they're dealing with. And as a consequence, it makes for very hard work, okay? But I can't not do this work. My life has been transformed by working with this neurologist in Australia, and now in my practice, I'm sitting with people every day whose lives have been effectively, in some cases, ruined by traumatic brain injury, and they're making amazing recoveries under our care. And this is not a brag, I'm just saying it how it is. Do you follow that? Okay? But he also said to me this, he said, don't think you know anything about concussion until you've rehabbed at least 250 people. He says, doesn't matter how much study you do, you have to rehab them to understand the nature of what concussion is. To date, I'm on my 740th case of rehab. So I've rehabbed 739 cases so far, and I've assessed over 1,200 cases, okay? So I'm beginning, I think, to know something about concussion. And that's why I'm here today to share this with you, all right? So I've come back to New Zealand. I've established concussion care. It's a private practice based in the North Shore. And I said at the start, education is a very big component of what we do. My colleague, Dr. Chad, is here today in support. Yeah. So he heard I was going to be the only guy in the room, so he's come over to give me support. Okay, all right. Now, in terms of concussion, let's get to concussion services here for a second, okay? I'm going to hold this and hold this. 1 second. Hold on a second, please. Now, concussion services, my experience is that concussion services in this country is based on a whole bunch of false assumptions. And those false assumptions lead to a whole bunch of problems. And that's the challenge that you face in practice. So I think it's important here you understand what you're dealing with as much as what your patients are dealing with. Because if you don't understand the challenges that you're up against and your patients are up against, you're not going to get the best results for them. So education is important when it comes to managing concussion, but early intervention is the key to managing concussion. And I'm going to finish my talk today by talking about early intervention and how you can make a difference on Monday morning. I've got a sheet, a three-step sheet there of action steps you can take in that pack on a Monday morning when you deal with your first patient, okay? So what is a false assumption? Well, my father says it's the mother of all cock-ups. And the false assumption with concussion management in this country is that it's based on rest. Most people will get better, just leave them alone. Just go home and rest. And if you do that, the person will get better. That's a major problem because it's not true, because most people don't get better from a concussion. They adapt to it. There's neuroplasticity and there's neuroadaptivity at play, but a lot of people do not recover from concussion properly. So all you have to do is rest, and that's a false assumption, okay? The person, next to false assumption is the person was neurologically integrated before they were injured. Now, I gave out the questionnaire today, and I asked you to answer the questionnaire and get your scores on the questionnaire. Did you all do that, by any chance? Yeah? Okay. Does anybody want to share their score? Beg your pardon? Did you add them all up? Yeah? No? Okay. I'm not going to. If you haven't added them up, don't worry. Has anybody added up all their scores? Has anybody? Would you be 39? Okay. Wrong test? Yeah. 27. Okay. All right. Okay. Good. Now, let me explain how this works. There's this assumption that before the injury, before the accident took place, you're 100%. That's the general assumption. And when you recover, you get back to being 100%. But 100% means that you are neurologically integrated. It means your cervical, vestibular, oculomotor, cerebellar, peripheral, and central nervous systems are all integrated. That's what 100% means, okay? And your perfect score in terms of autonomic balance and metabolic balance is 0. If you have anything over 20, there's problems or potential problems. So what we see here in the score is I said to you that, hey, I reckon I'm about 90%. I said that to the doctor in the hospital, or doctors, okay? Now my wife said something entirely different. She reckoned I was down around 20% here. This is a subjective score here. This is an objective score over here. You follow that? Okay? Now, so the two scores in the room were 39, 27. Your score was higher, wasn't it? You don't have to say what it was. Do you follow that, right? But it was significantly higher, okay? So the reason I'm having you do this, and if you haven't done it now, go home and do it when you're finished, all right? Just to see where you are right now in terms of neurological resilience. Because this line here is what we call the crisis line. Above this line, you may be asymptomatic, but there will be definitely neurological dysregulation going on. It takes a highly specialized physician to be able to diagnose this. Chiropractor, GP, osteo, they're not able to do this. When you get below this, it gets easier to diagnose, but the diagnosis tends to be subjective. I'll explain that in a minute, okay? So my assumption was that I was 90% in the hospital. When I went to Australia and I did my assessment, my score was 270. Keep that in mind, okay? The highest score we've seen in the practice to date is 325. That's the highest score we've seen in the practice to date, okay? But my score was 270. My score is now 5. Yeah, but I've been through rehab, okay? All right, now. The problem with this is when the person goes through rehab and they're discharged because they're assumed to be okay, okay doesn't mean that you're okay. It means you're somewhere here. You're in a subconcussive state. I call this thin ice. And we know that 25% of all people who get concussed go on and reconcuss again. And we know that it's much easier to concuss the second, third, and fourth time. And that's because loss of neurological resilience. Okay? Now, the next false assumption is, so that's what I've just talked about that. If a person does not lose consciousness, then it's not a bad concussion. Well, here's the reality. 95% of all concussions don't involve loss of consciousness. But 50% of all concussions are severe. As a consequence, 50% of all concussions are missed or misdiagnosed. And if you're told that you have a mild concussion, you'll go home and treat it as such, which means you do nothing about it. A mild concussion, this is a false assumption, is much easier to rehab than a severe concussion. Now here's the thing, patients are driven by symptoms. If you tell somebody they got a mild concussion and they go home assuming that, they'll assume they're going to get better and they won't look after themselves. And as a consequence, 6 months later, they're still concussed. And very often, a year later, they're still dealing with concussion symptoms because somebody told them they're going to be okay, just go home and rest. You follow that? The problem is, and I said at the start, false assumptions lead to problems. False assumptions are so those diagnosed in concussion are not doing the rehabilitation. Those diagnosing the concussions are basing their diagnosis on the assumption that most people are going to get better. As a consequence of this, those diagnosing the concussion are not doing the rehab, are not seeing the pitiful outcomes that take place as a consequence of the go home and rest protocol. There's an enormous, I use the word, there's an enormous void of misunderstanding as a consequence. And that filters from the top right down. Because ACC assumes that most concussions get better by themselves. And ACC assumes that when you get better, you're 100%. We know for a fact that you're not. And that's why I talk about this, the illusion of concussion services. The problem is it takes weeks to get an appointment. Generally speaking, what happens with concussion is I talk to you about the importance of early intervention. But if you think about it, if you're diagnosed with a concussion, whether it's in a doctor's rooms or in an ED, you're normally sent home. Take it easy for 2 weeks. If you're not right, come back and see us. Now, what's the problem with that? How long does it take to get an appointment with your GP on average? 2 to 3 weeks, okay? So go home, and if you're not right in 2 weeks, come back to us. How long does it take to come back? Yeah? Now, okay, you've come back, you've persisted, you've pushed through, you're here now. Now it's a month since your injury. Okay, we better refer you to concussion services. How long does it take to get an appointment with concussion services? An average of 3 to 4 weeks. Now we're 7 to 8 weeks after our injury. Is that early intervention? If you broke an arm, would you leave it 6 or 7 weeks before you decided to get something done about it? What would happen to the arm in that time? It would repair in the broken position. Is that good or bad? So the brain, injured, will adapt in that broken position. And that's where it becomes locked into dysregulation. So not such a good plan. Now think about concussion diagnosis, and here's the challenge medically, and I'm not knocking anybody here, because I know from talking to people in this room today the amount of time pressure you're under in your practices, all right? In terms of, first of all, it takes 2 or 3 weeks to see your doctor. Now pre-COVID, how long did it take? Less than that, agreed? Years ago, it took less than that again, okay? I specialize in concussion assessment and concussion rehab. When it comes to assessing a concussion, it takes me an average of 15 minutes to assess a concussion properly. Some I can do in less time, some take more. Some people take about a half an hour to assess them to the point where you know this person has a concussion profile. How long is the average GP visit? 15 minutes, okay. How long does it take to get them in and out of the room? Let's say 2 minutes, okay? The GP then has to take notes and put them to the computer and ask questions. How long does that take? Case history, 6, 7, 8 minutes, okay? What we've got left clinically is 5 minutes, maybe 8 minutes in which to do an assessment. Now, if it takes me 15 minutes, and I'm specialized, I'm trained, I've been doing this a long time now, how can a GP do it in 8 minutes? They can't. So all of their assessments are subjective. And what I mean by that is, I'm going to say almost intuitive. And half the time they listen to the story, that sounds bad, it sounds like a concussion. Do you follow that? Okay? Now, because they're under pressure for time, because we know the average waiting time in an ED department is, you told me earlier on today, the average waiting time is, I think, is 6 hours? Yeah? So these guys are under pressure. Any minute they can make to catch up, they'll do so. So, well, most concussions get better by themselves, so we'll just pass it on. And if you're bad, come back to us. And there's a tendency to pass the buck as a consequence. Does that make sense? This is not a reflection on the person, it's a reflection on the system. Does that make sense? So now the person who's being concussed is constantly being fobbed on to the next person, to the next person, to the next person, because, well, they're going to get better, but that's not the case. Okay? All right. The problem is there's no sense of urgency. A concussion is a serious injury. You've got 85 billion brain cells called neurons, 85 billion. If you damage only 1,000 of those cells, that's 85 million cells. Is that a lot of cells? Yeah, and that's only 1,000 of the brain, okay? There might be 2 or 3% or 2 or 3 thousandths of that going on. That becomes 250 million cells damaged or destroyed, okay? Is that serious? Incredibly serious. Should it be attended to straight away or as soon as possible? Absolutely. And here's the reason why. What people don't realize is a neurometabolic cascade takes place in the brain after the injury. That cascade lasts 10 days. So concussion is not so much an injury as it is a process that begins with a trauma and plays out over a week to 10 days. And that neurometabolic cascade is a potassium-calcium imbalance and glucose imbalance. There's a massive energy crisis takes place in the brain. Now, how you manage the energy crisis is going to dictate or determine a lot of the outcome. If it's mismanaged, which is what happens mostly, the person's going to go in a very steep downhill cascade, and it's much harder to get them out of there as a consequence. If they're managed properly in terms of early intervention, and this is why early intervention is the key, then that's a shallower cascade and a much better recovery outcome as a consequence. Yeah? Make sense? Okay. All right. Now, here's what I see as the biggest problem. There's zero accountability. Your GP is not responsible for your recovery. The OT you see in concussion services is not responsible for your recovery. The doctor you see, et cetera, et cetera, et cetera, et cetera, et cetera, they're not responsible for your recovery. But they're all getting paid, whether they get better or not, because they're paid by ACC. And I'm not saying that ACC doesn't care. They do care to a degree, but they've got a limited budget. And ACC, and I'm not knocking them, is a lot less caring than they used to be. And the reason for that is too many people over the years have taken advantage of the system and have lived off the system. As a consequence, ACC works more like an insurance company now. And the objective of ACC is to get you off their books. That's the objective of ultimately, that's the objective. Does anybody here disagree with that? No. Okay? I had 5 case managers during my recovery. 5. None of them were accountable. But none of them were there to manage they were supposed to be there to manage my recovery. The first girl, gorgeous, and I never met any of them, but when I say gorgeous, very caring. I was in a very, very sorry mental state, and I felt connected to this girl, and I felt like I was being looked after here. She called me after 6 weeks, Dr. Gary, I'm leaving. I said, what do you mean? I'm going to go have a baby. We're going to assign you a new case manager. I never met the second case manager. I never even heard from them. I needed to reach out to ACC after a period of about 3 weeks. When I contacted them, oh, that case manager is gone as well. You have another case manager. So I went through 3 more case managers till I finally got to the 5th case manager. And she's what I call the Rottweiler. At that stage, I'm 9 months under ACC. It's time to get me off the books, okay? And no disrespect to this lovely lady. That's just her job, okay? All right? And we're seeing this in practice on a regular basis. People come to see us, and they've been effectively put off ACC, even though they're not better. They're still struggling with their concussion. Do you follow that? Yeah? And a lot of it has to do with mismanagement and early intervention at the very start. Okay? Any questions so far? No? Okay. So in the pack I've given you, I talked at the start of education is key and early intervention is key. They're the 2 key components of concussion management. So in your pack there, just there's 3 steps. Just take out a page there. Concussion action steps. So Monday morning or Tuesday or one of these days, you're going to be faced with somebody dealing with concussion. And I believe if you follow these steps, it'll help you to get a better outcome for the person and for your clinic, okay? I've put at the top here, concussion is a serious brain injury. There's brain damage involved. People don't realize that. They think, oh, concussion's a concussion, it'll be fine. No, it won't. Concussion is brain damage. You must act with a sense of urgency. You must honor your clinical, and I put down here mother's intuition. Don't get me wrong. Don't see me as sexist, but you're all female. And you have this incredible intuition. And at the start today, one of the speakers today said that you guys are a lot more qualified and trained than you realize. You just have to have faith in that training, okay? And that's why I say, don't be afraid. This intuition that you have is incredibly powerful if you listen to it, all right? Early intervention is important. I said the first 10 days is critical. Don't wait and see. And if you've any doubt, treat it as a concussion. It's much better for you to follow these steps and have somebody come back to you later on and say, oh, that was overkill, which it never is, believe me or not, versus someone come back after 3 weeks and go, I wish somebody had told me what to do and how serious this problem is because my life is ruined as a consequence. Okay? Concussives are poor self-regulators. They have very poor awareness of who they are. Did I have a good awareness of how I was doing in the hospital? No, not at all. It took me 3.5 months, and it took me going to Australia to visit a neurologist over there who was able to demonstrate to me how bad I was before I honestly took my care or my recover seriously, okay? So concussives, for the most part, quite often have agendas, right? I love to work. Don't take me off work or I'll be miserable, okay? I wanted to go back to my practice. So when I got injured, how much time did I take off? 2 weeks. I almost never take 2 weeks off for any reason, okay? I was back in my practice after 2 weeks, and it wasn't until I had a mental emotional breakdown that's what stopped me from practicing. Have you got that? Others want to go and play on their rugby team. Others want to go and do other stuff. So they'll sit there and they'll lie to you. That's why in our practice we always have an advocate. We always have a support person. And it's important for you when you're dealing with a concussive that make sure you have a support person with them. And if you haven't got a support with them, get their phone number. Find out the next of kin. Find out the roommate, the person who is going to be in some ways responsible for them, and give them clear instructions on what's happened to this person and what needs to be done to help them to begin to recover, all right? And do not compromise. Kia kaha, you must stand strong, okay? Yes? Eventually. Yeah. No. No. The hospital missed completely. Now here's the thing. Here's the thing, okay? Here's the thing, okay? I just went back to the fact that the doctors don't have time to diagnose properly. Most doctors are not trained to diagnose. Most doctors don't have the time. It takes me 15 minutes to do a diagnosis and assessment. Most doctors do not have that time. So based on the idea that most concussions get better by themselves, the tendency is to push it down the line. I beg your pardon? I did, eventually, especially when the brain bleeds, yeah. And I went through every service we could provide here, ACC and private. I threw any amount of money at this that we could, you know, I'm not a wealthy person, but I was determined to want to get back into practice and spent 3.5 months going around different services, et cetera, and I got worse, not better. Beg your pardon? As an inpatient? Yeah, yeah. Have you been to one of those? You have. What are the outcomes? Okay. Yeah, no, I appreciate that. Yeah, okay, all right. So what I'm doing is I'm just pointing out the challenges we have now. I mean, and since COVID has come along, it's completely turned medical management on its upside down in terms of access and availability and responsibility and accountability. And again, I'm not knocking anybody here. I'm just saying this system has problems. As a consequence, your patients are having to deal with that. So what I'm giving you here is 3 steps to try and help you to achieve that, okay? So the first step is this. Lock them down for 3 weeks minimum, okay? Now we know this is standard in terms of a sports injury. Take them off the sport. But you have to use your intuition and think, is this person capable of even going to work? Because this is where the damage is done. Remember that they're in this neurometabolic cascade for the first week to 10 days. What do they want to do tomorrow? They want to go back to work. They want to go back to sport on the weekend, etc. So use your clinical intuition to decide they shouldn't be going back to the sport. They shouldn't be going back to what caused the injury. Should they be going to work? Should they be going to school? Okay? Now, I had a conversation with one of New Zealand's leading concussion specialists who manages the sideline when the All Blacks are playing and international games, and he said, where did the 3 weeks come from? Where's the clinical criteria for 3 weeks? Nobody knows. He said, with some cases, it should be 3 months they're stood down. That was his answer. Do you follow that? The reason I'm saying 3 weeks here is because if you follow these steps, within 3 weeks, they should be with a concussion service. That's what I'm saying, okay? If you follow these steps in 3 weeks' time, that neurometabolic cascade has completed its journey, and the person has a better understanding of where they're at. Make sense? Okay. This is a guideline. Yep. Okay. And use your clinical intuition and stand by that. It's very, very important. Don't allow yourself to be persuaded otherwise. Have them do brain breaks. The second step is have them do brain breaks. A normal brain has about 16 hours capacity in terms of function per day. Think of the brain as a battery. When you wake up in the morning, the brain is fully charged. Let's say you wake up at 7 o'clock, you go to bed at 10 o'clock at night. That's a 15, 16-hour day, right? That's a normal day. Go to bed, and the brain recharges during the night, and in the morning you wake up and you go again. And you rinse and repeat, okay? Now with a brain injury, you lose massive capacity. So you go from having maybe 16 hours capacity down to maybe having 4 because there's a massive energy crisis as a consequence of the neurometabolic cascade, okay? So the person wakes up in the morning, doesn't feel very, very refreshed. They get to lunchtime okay, and then they struggle for the rest of the day. Now at this stage, their system's in fight or flight. We've all heard of this. Fight or flight is part of the autonomic nervous system. The other side of the autonomic nervous system is rest and recovery. You're either in fight or flight or you're in rest and recovery. You can't be in both at the same time. So if they're locked into fight or flight, they're not recovering. And that's why we see concussives 6 months and a year down the road still dealing with the symptoms of concussion because they're locked in a fight or flight scenario, okay? So brain breaks should be 3 times a day. And this sounds extreme, but this is what's required to help the brain to cope and help the person to cope. Have them do a half an hour sleep 3 times a day. So about 10:30 in the morning, about 1:30 in the afternoon, about 4:30 in the afternoon. Make them go home, put an eye mask on. If they've got a set of ear protectors that you use for cutting the grass in the garden, put those on, and cover your body with a light blanket. That means your brain doesn't have to regulate body temperature. This is a sensory shutdown. It allows the brain to stop working and to recharge. And what you do is, instead of living from sleep at night to sleep in the morning, you live brain break to brain break. And it helps the person to self-regulate and manage their brain in such a way that you nullify this neurometabolic cascade and have a better outcome as a consequence of rehab. Any questions on that? No? Okay, cool. And the last one is get into concussion service as soon as possible. And have them if you have a sense of urgency around this, if you take this seriously enough, they will take it seriously. That's why I said, if you tell them they've got a mild concussion, they'll go, oh, it's just mild, I'll be fine. I'll just go home and take it easy. And they don't go home and take it easy. And they go out and play in their sport the following week, okay? But if you have a sense of urgency and you make a big deal out of this, they will do the same. And that sense of urgency is one of, get to concussion services as quickly as possible. And that means I've given you a handout there in your bag. The pack that I've given you is all the concussion service providers in Auckland. I would take that back to your clinic and I would photocopy it 100 times. Now, I apologize that I've got all the internet numbers there, but we don't have the phone numbers for you. That was a last-minute hiccup. But you can call these clinics and find out their phone numbers and put the phone numbers on there. And when you refer the patient, give them that sheet and tell them to find the concussion service provider in their area closest to them and to get on their books as quickly as possible. To go see their GP and not be fobbed off with, oh, look, come back in a couple of weeks if you're still bad. Don't do that. Go to the GP and get a referral to the concussion services straight away. And shorten that delay, because the longer the delay, the worse the outcome. The shorter the delay, the better the outcome. Yep, okay. Any questions? Has this been helpful at all? Yeah, so I didn't come here to have a rant. I just came here to tell it as it is and to help you to understand what you're dealing with and what your patients are dealing with and what we deal with every day in practice, because we deal with concussion and post-concussion syndrome, especially post-concussion syndrome, and we're seeing patients 5 years into their injury who should not be in that state, but they are as a consequence of lack of understanding and poor management. Yep, okay. Any other questions, concerns? No? Yes. So if we go back to, let me see if I can go back here again. Sorry, I didn't hear you. Yeah, okay, good. I've seen a couple of All Blacks so far. That's it, great, okay. Yeah, I mean, that's a tragedy where they have been mismanaged. And there was poor understanding. They did not understand the nature of their injury. And we're going back to, let's say, the older days where they're getting paid to get out there and do their business. And if they don't do their business, they don't get paid. And even now, that's the case too. But again, I was talking to this specialist a few weeks ago. No, not John, no, a different specialist. The system in place at international level is phenomenal. They've got 9 cameras on the game. They've got 9 people watching the game just for impact, just for injury. And the doctor can call from the camera and go, take that person off now. And he can overrule the ref, he can overrule the coach, he can overrule everybody. Do you follow that, right? That's the degree of professionalism at the top level, all right? And he said to me, it takes me 12, 15 minutes to assess an off-field assessment, all right? And very rarely does he put them back on again because he understands the consequences, okay? So can you hear me? But that's at the international level. That's at the very top. It's a phenomenal system that they have. But come down to counties level, come down to local level, community level, come down to school kids level playing rugby, where they're playing rugby to the same degree as these All Blacks are because that's their inspiration. They're their heroes. They want to play like their heroes, okay? How am I doing for time? Have I got time? I had a 15-year-old, first 15 rugby player come to see me from mum. Now, he'd already been to the doctor, and he'd been assessed, and the doctor said he could play rugby. He'd had a rugby injury. He had 5 stitches over his left eye as a consequence of the injury, went to the GP, and the GP said, okay, you can play. Mum wasn't happy with this. This is mum's intuition, okay? Mum brings him to see me. Turns out he had persuaded the doctor to let him keep playing. So the doctor was in 2 minds, oh, I think we should probably stand you down here. But he said, please don't stand me down. We've got the semi-final next week, and then we got the final 2 weeks after that if we win. And so she conceded. And she said, okay, go for it. Now, is that a good idea? The semi-final and the final are the 2 toughest games of the year, right? This kid she thinks probably concussed because he's got stitches here, all right? But here's the thing, we put him through our assessment and he failed all my tests. And one of the last tests, you might have seen one of the patients there had a laser light on his forehead, okay? And as I put the laser light in his forehead, I lifted up his fringe, he's got 12 stitches across here. From a motor vehicle accident he had 3 weeks prior to the rugby accident, where he was in a car traveling at 100 kilometers, went off the road into a ditch, bounced out of the ditch, across the road, smashed into a lamppost and wrote the car off, okay? And he smashed into the windscreen. Now, I'm not knocking the GP, but if a proper assessment had been done, they would have found that. If a proper case history had been done, she would have straight away gone, uh-oh, you're not playing. But by the time I finished testing him, which is all objective, which means all my tests are pass-fail tests. By the time I finished testing him, he said to me, I can't play, can I? I'm going, what do you think? He said, I'm buggered. Yes, you are. He could see he'd failed all the tests. He knew he was buggered. He knew he wasn't safe to play. Now he's rehabbing. Do you follow that? Okay? Make sense? Yeah? Okay. But that's what you're up against in terms of this. There's two sides to the coin. I say to you, stand firm on your intuition. Stand firm on your diagnosis. Even though you've never been trained to diagnose a concussion, you intuitively know this person is not right, okay? And stand firm on your instructions on what should be done with this person. Because on the opposite side here, you've got the young man who wants to play rugby, or you've got the coach who wants the person back on the team, or you've got the employer who wants the person back in work because if they don't work, they lose productivity. Does that make sense? And you have to make a stand for the patient, because if you don't make a stand for the patient, nobody else will. Yeah? Okay. How am I for time? Have I got 5 minutes? Any other questions? Yep. Yes, so most people, here's the thing. When are you ever 100% neurologically integrated? When is the vestibular system, oculomotor system, cerebellum, all this working in harmony? And the answer is we'd like to think at birth. We'd like to think that our babies are born 100%. Yeah? Okay? I'm here to tell you that's not the case. My wife is a specialist in pediatric neurological development, and many babies are born less than 100% because of the birth process or mishandling. Okay? Now, here's the thing. Quite often we associate concussion with a contact sport or a motor vehicle accident, all right? But you ever watch a baby learn to walk? How many times do they fall down and bang their head? Have you seen that? We've seen it, haven't we, okay? When they get to the playground, how many times do they fall off the jungle gym? How many kids playing bull rush have full face contact? Do you follow that? So a significant amount of kids are going around concussed, or in what I call a subconcussive state, where mother knows they're not right. They're not themselves, but the symptoms don't add up. So they take them to the doctor, and the doctor can find nothing wrong. But they're expressing these symptoms up here, neurologically. And nobody's put it together. This child actually has a brain injury. So that's when it starts. And as a consequence, I bet you, when you go home, if you take the time to go home tonight, go through and score, nobody in this room will score 0. I'll put $10 on that, okay? And I'm going to be very surprised that we don't find some people operating down here, okay? And we talked about wellness and work today. One of the presenters has talked about wellness and work today and coping with stress. The more you have neurological dysregulation in your system, the lower you are functionally, the lower your resilience to stress. And as a consequence, it starts to affect the metabolic and autonomic systems. And you start to express symptoms that are not obviously neurological, but they are neurological. So our focus in practice, here's the best one, okay? BSL Racing is one of the top speedway racing teams in New Zealand. They contacted us about 3 months ago. And it was after the rugby player came out about dementia. Okay, good. So that was a great story because it inspired a lot of people to get checked, okay? The team manager said, I want you to check all my drivers and see are they okay, because speedway involves impact and it involves accidents. They sent 8 drivers over to see us. We put them through the assessment questionnaire here, and they all were red flagged for underlying dysregulation. 2 were concussed, had a concussion profile and were concussed but weren't telling anybody. Why not? They don't want to be taken off racing. That's why, okay? 2 of them, one was down here, and one was down here at 145, okay? And the other drivers, the other 6 drivers who I was able to clear them for racing, but they all had some sort of neurological implication going on. And that's going to affect their ability to drive and their ability to be safe on track. Now the great news here is that they came to us 3 months ago. The season started last weekend. They all went through rehab. They all went through neurological training, and the 2 concussors went through concussion rehabilitation. They're all now racing this weekend because they've all got back to a point where the cervical spine, vestibular system, all those systems are reintegrated, and their scores have come up to not 0, but in the 20s somewhere. Do you follow that? Okay? That's one of my favorite stories, because this is someone who's proactive, and I'd much rather be the person at the top of the cliff stopping people going over than at the bottom of the cliff scraping people off the ground, which is quite often what we're doing. Any other questions? What's the rehab? Okay, so we're looking at the cervical spine plays a huge role in concussion. You can't get a head injury without getting a neck injury. Unless it's a gunshot wound, okay? Many concussions are as a consequence of whiplash. There's no head trauma, but there's a massive neck trauma. Do you follow that? Okay? So the cervical spine plays a huge role in concussion, in the injury, and in the rehabilitation. And it's almost completely ignored in New Zealand because they don't have the speciality. And it's one of the things that sets, here I am blowing my own trumpet, chiropractors apart is I've seen over 20,000 cases and done over 1 million adjustments. The cervical spine is my playground. Do you follow that, right? But it's a small part of the injury. So the vestibular system, oculomotor system, the cerebellum, and the peripheral nervous systems, and the autonomic nerves are all involved, okay? You have to rehab all those systems together. You can't go to the vestibular place over here and the cerebral place over there, and do you follow that? You've got to bring it all in together, and you've got to bring it in with the cervical spine, because if you don't rehab the cervical spine, it disrupts the rest of it, yeah? And that takes time. So our program is a home-based program. There's 4 visits involved just getting the person started, just to get them to understand what they're dealing with, get them into the rehab, get them to understand what they need to do on a day-to-day basis in terms of self-regulation. Once they get that program, it's a home-based program. 80% of what they need to do is done at home. They come to us for spinal care, and every 4 weeks we rehab, we reassess them every 4 weeks, and we remeasure them according to that sheet I've given you there, okay? And the goal is to bring it back down to a single-digit score. That's the ideal goal. Do you follow that? Okay? And that can take anything. It depends on how badly injured they've been or how long the problem's going on. But that's our approach. Yeah? Any other questions? No? Okay. Thank you. I really appreciate the opportunity to talk. I just get excited. I want to talk more. I hope there's been some value in this today. I really enjoyed spending time with you guys today. I've learned some really good stuff from my practice. And any questions or concerns, our contact numbers are there. If anyone wants to talk to us, feel free to give us a buzz. There's no charge for that. So you answer all the questions and top up the entire score and see what the entire score is. And that one as well, yeah. It takes about 12, 15 minutes to do it. Yep. Partially. So because we're chiropractors, we can claim for the cervical spine. But we are not allowed to diagnose concussion. How does that work? Okay? But, we are usually the port of last call. That's our experience. We're getting more and more first cases now, people who've been injured a day or 2 ago, right? And our waiting time is 48 hours at the most. Yeah. 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 And the credit is to the media and to, is it Carl Heyman? It was the rugby player. He came out. he talked about it openly, you know, and kudos to him, and then kudos to media to put it out there, because that changes people's attitude. They start realizing concussion is not just a kind of a bruise. Concussion is a serious brain injury. Yep, which is great. Okay, thank you so much. I appreciate it.
Okay, last silly thing, and then you guys can go home. I have a little game, and I have a chance to give out a gift certificate for a photography session worth around $50, so I need some volunteers. I'm going to test how well you've been listening. No one. Cool, neck deep. So I'll get you to come up. Yep. Anyone else? Cool, come on. Cool. All right. Okay, so I'm going to ask you guys a couple of questions. I will give you maybe 2 chances to get one wrong. The last one standing wins the gift certificate. Cool. What was your name?
Giselle.
Giselle, Jackie, and Nagdeep. Awesome. So, Giselle, how do we administer the BCG vaccine? I'll give you one more go. Okay, I'll give you another one. Once you've had the BCG vaccine, how long can you not have another vaccination in the same arm? Awesome. Cool, 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 cool. Jackie, can you describe what is box breathing? Amazing. Okay. Can you describe the 4 F's that are responses to stress? Okay, that's 1. Are you sure? You think about it? Stress. So what are our normal responses to stress? And one more? Cool, amazing. Okay, that was a trial run. These ones are the deciding ones. Okay, can you tell me who are the 3 key members of the wellness support team? What are their roles? They are in your clinic, if that's a hint. Yep, so you have a couple of members in your clinic. One of them was speaking today. Does the audience? So, what are the roles as part of the wellness support team? Is that a better question? Okay, I'll give you a different one. I'm sorry, that was hard. How far do you have to place a fire alarm from your bedroom? Cool, okay. This is why I'm supposed to be paying attention. What other roles do the fire department do besides attend fires? You can name 2. Cool. Perfect. Okay. What is the number 1 reason for burnout? No. What is the number 1 reason for burnout? Not fire, stress. Bye. Okay, goodbye. Okay. All right, I'll give you one more last chance then. What was the completion rate of the engagement survey? Bye. Okay. Goodbye. Giselle, can you tell me what the 5 ways of well-being is? Mm-hmm. Oh. Yeah. Ding, 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 ding. Okay. Yep. Yep. 2 more. No, okay. This is the deciding one then. We've just had this presentation. So what are the 3 steps to helping our patients with concussion care? Come on. Okay, last one. Whoever can answer this one first. What are 2 different pathways available for nurses as part of education? Whoever can answer it first. Cool, okay. Amazing, thank you. Okay, I'll write your name on it, thank you. Awesome, I'm just gonna end on a karakia and then we're good to go. Has everyone signed the sign-in sheet? I need to make sure you guys are all paid. Yes, awesome, perfect. I apologize for my pronunciation. Kia anoi tato tu ia ki ranga, tu ia ki raro, tu ia ki waho, tu ia ki roto, tu ia te here tangata, tuturu o whiti, whakamaua, kia tina, tina, oh my God, haumi I hui e, taki e. Thank you everyone for coming, and for everyone that's coming tomorrow, we're starting at 8:45. For anyone that's coming for the suturing workshop, we will meet you guys tomorrow at 8. Awesome. Thank you.